Good morning, everyone. Good morning. Please eat. Please chew enough. Make sure you swallow. Keep it safe. And if you haven't gotten food, please help yourself. The buffet tables are set up out back. But we're going to go ahead and try to get started right on time because we've got a very full schedule. And you're going to see me looking down occasionally at my timer here to make sure I get off the screen in time. I've got about 4 minutes to talk to you about as we get started on the 4th annual Emergency Medicine for Rural and Indigenous Communities Conference. And it's pretty wild. Yeah, we can do that. Thank you. Thank you, David. The check's in the mail. You got to keep rolling with it. It's so great to see everybody here in person again. After now 4 of these conferences, we're finally resuming, like folks are in many places, to meet in person. And I don't know about the rest of you, but yesterday at the skills session, last night at dinner, you understand the value and the power of meeting in person. So I'm very happy to see everybody. Thank you all for making the effort to come out here. Folks have come quite a long distance, and we're really happy to see everyone. My name is Sean DeAndrea. I've been working with the Emmerich community for about 4 years now, and in the Southwest, in the Navajo area for about seven years. I've been serving most recently, until very recently, as the Emergency Medicine Chief Clinical Consultant for the IHS. I'm going to talk for just a couple of short minutes, and there's going to be a hook that'll probably appear to remove me from the stage about the background of this organization. And for those who have attended in the past, you'll notice a name change. I'm going to talk quickly about how we arrived at that, and then we'll get started. Housekeeping items, we're going to roll with these throughout the conference, but bathrooms are to the left and to the right. Just keep going, you'll hit one. With regard to the COVID protocols, we're trying to keep this safe. When folks are not eating, we just ask you to keep a mask on, just so we can do our part with the ongoing problems around COVID. So 4 years ago, there was a meeting. It happened at Fort Defiance, and it was inspired by leaders and clinicians serving the Navajo community, recognizing shared challenges around emergency department operations, quality, Joint Commission showing up, and encountering problems. And we saw that there was not going to be a consulting group to come in and get us out of it, because just as at that meeting, and the same is true today, the experts are not out there to help us with the challenges we have. The experts are in this room right now. So we're not going to be able to bring anybody else in to help us out. And out of that was born what was called the Navajo Area Emergency Medicine Consortium, which later became the Native American Emergency Medicine Consortium. We've had 4 conferences since then, and we're having the 4th now. But we have to thank Dr. Donald Warren, who was a speaker at our 2nd conference, which was virtual. And he invited us to reconsider what we called this group. He invited us to consider the historical meaning and importance of the language we used. And so that's how it transitioned to the Emergency Medicine for Rural and Indigenous Communities Conference. And we're very excited to move forward with that title for the group and for the conference that we will have now and hopefully in years to come. So that's the background of this organization. There's a lot more to talk about. At the end of the day, there are not other conferences that I'm aware of that will help us provide the best possible emergency care to the Indigenous communities that we serve in a culturally, historically competent way that bring the standard of care for our many times remote communities to what they ought to be, which is those communities that are in academic centers, at tertiary care centers in the cities. So I'm out of time, and I look forward to talking to you all more and more as we go along. We've got a very full day. I'm going to turn it over to our friend and colleague, Dr. Christopher Gentoff, who's the clinical director at Chinle, and he's going to start us off with the land acknowledgement, and look forward to talking to you all throughout the conference and celebrating this community that's come together. So thanks so much for being here.
Morning. So we'd like to begin by acknowledging that the land on which we gather is within the Aboriginal territory of the Indigenous peoples of Arizona. We acknowledge with respect that we are on ancestral homelands of the Indigenous nations that have inhabited these lands for centuries. We know The land on which we gather is the stolen and occupied traditional homelands, and that their culture is older than the concept of Arizona or the United States. We take this opportunity to offer gratitude to the spirits and people of this land and encourage all people who live and work here to explore the impact of settler colonialism and systems of oppression that directly affect Indigenous peoples. Let our collective body of work bring people together and uplift the fight for balance in nature and healing the spirit. And I'd like to thank Deb Manuel for those words. Now I'd like to introduce for our invocation, Ernest Harry Begay is a traditional counselor with the Utah Navajo Health System, traditional counselor for the IHS and Navajo Nation for nearly 30 years. He's the creator of the Navajo modality of healing, black, turquoise, yellow, white, and glittering words recovery process. He's a member of the Diné Hatahtli Association or Navajo Medicine Association, and he's also very funny. Ernest.
Njone bene. Can you repeat that? Njone abene means beautiful morning. Again, it's one of our sacred mountains here. Nashkalenishle Mescalero Apache, that's my clan. Kintichini Bashachin, the red dwelling people are my dad's people, my dad's clan. Katnes Zahni Dashache, that is the interwoven, meaning the rain, when it's coming down, then there are layers that go across. That's where the clan came from. So that is my maternal grandfather. And then Kinyaani, the tar wing dwelling, the clan that was the first clan made with the Navajo people. Those are my Nali's paternal grandfather. My wife is Tohitlini. Her dad is Shihi. Her Che is Kachini, and her Nali is Betani. We have 3 children. And it's good to be here. First of all, thank you for all that you all do. Thank you. I've been on the Navajo reservation, been there 4 times 16 years now. So I'm an elder. That's what I've become now. I'm an elder. And when an elder gets a time to speak or to pray, they'll say a few things. So based on that, I want to tell you that mental, we think that's first, but before that, there's spirituality. So I tell my patients to say that your belief, that's the main one that heals. Your spiritual part, that goes and tells your mental part that you're all right, you're good. Mental then tells your emotions. And then the emotions then carry that to your body, physical part. So that's where healing is, that's how healing is perceived in Navajo. And I think that that's across all Indian nations. And in that, then toward the east, that's where your spiritual image is, toward the east. Then the south is where your behavioral part comes in. The west, your social part. And then the north, your physical part. So in that way, then all we are trying to do is to have them balance those things in there, to have them balance. So it all goes back to a person if they want to be healthy. And we all, as providers, we educate and we try to heal, help them along, but really to educate them. That's the big role in all of this. So with that, I'm gonna go into my prayer, and I'm gonna pray in the Navajo language this morning for all of you. So again, thank you. Johna Edo nitra digin. Adot ahona edo kuho. Betra ehonitlo, huno ka den Adom ni kein dengi ku bakage sakre ede. Ado bakage sapa, ado bakage sijan. Kwat ego kun holjish. Ako holda edije kwabin ye ki ilteki. Dan zade ade kwa ki ilte kwa ek akun de kat. Ayada eya ipin yeheki e kwado eya ikun. Njon dole yat dole. Nahaz ade lezel nahaz ade kwache. Alkhaat za joku. Ayada njono ba ahwini zi dole. It's easy adat edo bin yadat edo betrayada hot edole. Johot aye kwe bahasti dole. Belikeda hot si dole. Ekot edole. Don't hear where doku Victor Carmen. Well yakun hukum. Yat ego hojon jono kodo. Nikit na hasnet dole. Hojon wa dole. Hojon na hasle. Hojon na hasle. Hojon na hasle. Hojon na hasle.
Thank you, Mr. Begay, for that blessing to start us off. So everyone, I'm Paul Charlton. I know many of you in the crowd. I don't know everybody. Thank you all for being here today. It's really a very exciting opportunity that we have. Sean and I will talk a little bit more about some of the broader context here, but one of the things that we're really proud about is the community that has assembled around all of this arena of activity. This has been a lot of work that has gone into this, and I want to thank everybody who was present yesterday for the skills day that took place. It was very exciting, very well put together, and just a wonderful sense of everybody being able to come back together again as a community. The content that we have today is pretty unique. It does not feel like a normal emergency medicine conference. We have a lot of things that are kind of classic to what we do in emergency medicine, but much of what we're talking about is what makes it special for us to work in these contexts. And we're really excited about everything that we're able to do. I would like to give a big thank you to everybody here in the room for all of the dedication and the things that people have done over the last couple of years. I think we've come out of something that was a really tough situation, and many of us were working in communities that were very heavily affected by the COVID pandemic and the subsequent sequela from that. And I'd just like to honor the fact that we made it, possibly with quite a few scars along the way, and we're reemerging with something that is very exciting for what we can do to build this community going forward. And so with that, I want to say it's my honor to be able to introduce our next speaker. And this is a really special opportunity here. So our next speaker is Victor Lopez Carmen. And for people maybe who have not been familiar with him, I think you will see that in this arena that we're operating in and globally, what we're seeing, this is somebody that will be a name you'll see more and more. He has already been extremely accomplished and has served as the UN Global Indigenous Youth Caucus, formerly co-chair, and now is on their advisory council. He's also within our medical community. He's a medical student currently at Harvard Medical School, where he has already founded several important initiatives through that. The OAISA pre-medical program at the Brigham and Women's Hospital, also founded the Translations for Our Nations program, which was a COVID intervention. And he's somebody that is sought after already. We were competing with some other groups in terms of who would be able to get Victor's time. So we're very excited to be able to have Victor give us our keynote address now. So I'd like to introduce Mr. Victor Lopez Carmen. Thank you very much.
Ihani washte Liosum Chaniavu Haiso Ampo Victor Tea Victor Imachiapi Hunkpati Dakota Imataha. Thank you so much for having me today. I really appreciate that introduction. Bio's always a little bit weird to me as well, because I always consider myself just person from my community. And that's how I was raised. And I'm really excited to be able to speak to you all from that perspective today. I'm not a physician, like you said, I'm a medical student, but I grew up in my community. And I think that that's an important perspective as well to be able to give. And I'm not going to try to teach physicians how to deliver clinical care, because that's your job to teach me. But I hope that I can impart some knowledge from my perspective. So thank you for this opportunity and all that you do in Indigenous communities. Go to the next slide. Just the clicker here. All right, cool. So the title of my talk is Indigenous Rights-Based Approach to Emergency Medicine. So I wanted to frame the discussion we're having, emergency medicine, in Indigenous rights. I feel like that's an important framework to begin with. Here's the objectives. So first, I want to give context on Indigenous peoples and Indigenous rights. I also want to talk about the relationship between Indigenous rights and health disparities, with a specific focus on emergency medicine. And then I want to talk about the UN Declaration on the Rights of Indigenous Peoples, because I feel like this is an important, very important declaration for Indigenous peoples globally, also in the United States, but it hasn't, in my opinion, really made its way to the level that I feel like we need into the field of medicine and emergency medicine, and the considerations that medicine should be taking when partnering with Indigenous peoples, and then applying the declaration to emergency medicine as well. So first, a little bit about me. I don't want to give a talk without giving you a little bit of context about who I am and where I'm from. So these are my tribal flags. I'm an enrolled member of the Crow Creek Sioux tribe in South Dakota, and I'm also a Yaqui. On the left, you see the Yaqui land. We are in Tucson. We have communities near Phoenix as well. And we have villages in Sonora, Mexico, where a lot of my family is from. So you can see that little dot right above the border is in Tucson. That's our reservation. And we have an inner city community there as well. And then down in Sonora, the state just to the south, you see our villages there. Those are all the different names. My family is from Vicam. You can see the little dot in the corner on the right. And Vicam means the tip of the arrow, not just the arrow, the very tip. So you can tell we're very militant people. And on the right, this is Dakota territory, present day, North and South Dakota borders. But this is where my family comes from since time immemorial. And then we also have traditional territory above the border going into Canada as well. This is my family. That's me when I was a baby with my mom, and then my dad on my dad's side, my Dakota side on the left. And so yeah, I'm a medical student, but I've been active in the United Nations space for about 8 or 9 years now, formerly the co-chair of the UN Global Indigenous Youth Caucus. So what the caucus is we advocate. It became an official caucus in the UN system in 2008. And it was recognized within the space of the United Nations Permanent Forum on Indigenous Issues. So I was the co-chair. At one point, I was a focal point, but I work with Indigenous youth around the world to advocate for our rights. And a lot of this has had to do with health. This was us at the UN Food and Agricultural Organization at the Food Forum, and we were advocating for traditional food systems there. And that was in 2017 in Rome. But just wanted to give a little bit of background on what I'm bringing into the Indigenous rights discussion, that it's based in that experience. Another picture of me with Indigenous colleagues at the UN. And I think, it is important when talking about Indigenous rights and the UN Declaration to understand that this is not just a US, it's not US centric, that Indigenous rights, no matter where you go, where Indigenous peoples are, we have our rights, our collective and individual rights, and we share many different struggles together, but we all come from different communities that are unique in their own ways as well. So first objective, like I told you before, to gain context on Indigenous peoples' rights. So first, I try to define who are Indigenous peoples. Obviously, it's not going to be a perfect definition, but I tried my best to think about it to be able to give one that I feel you can take with you, but feel free to adapt it as well. Like I said, it's not really easy to define all of us, and I don't think we should be, but I think it's important in the framework. So here's my definition. Indigenous peoples belong to indigenous nations that have a pre-colonial continuity with their traditional land since time immemorial. They consider themselves politically distinct from societies that colonize their lands and waters. Despite the ongoing detrimental impacts of colonization, they are determined to preserve, develop, and transmit to future generations their ancestral lands, waters, cultures, self-governance, individual and collective rights. So I want to bring it back when I talk about Indigenous rights to the UN Declaration on the Rights of Indigenous Peoples. This was adopted in 2007 after many, many decades of advocacy from our elders within the UN system. There was a point where they were in the UN negotiating the declaration, which they were doing for quite a long time, and they did a hunger strike within the United Nations building to try to get a provision into the declaration. So this took a lot of work, and I wanted to include photo of when the declaration was adopted and how incredibly happy our elders were when that happened. My aunt was in that room. And then here's a photo of some of the elders who went to the United Nations close to the time when it first became the United Nations. And just to show how far we have come in advocating for our rights, the first Indigenous leaders who came to the United Nations when it was still the League of Nations, which was the predecessor to the United Nations, was Chief Descahe. He was Mohawk. And there was another traditional leader, I'm forgetting his name, but he was Maori. When they heard about the United Nations, the League of Nations, they said, we're nations too. And they went to the UN. This was in the 1940s. And they went to the UN and they said, this is Gathering of Nations. So they arrived there and the UN didn't let them into the building and they kicked them out and they were waiting outside. And so we've come from that point to this, and we've gone even further since 2007. So I wanted to recognize that. Also the declaration, this was in the declaration, the United Nations, its bodies, including the Permanent Forum on Indigenous Issues, specialized agencies, including at the country level and member states. So that means countries. And Indian Health Service is a government agency of the United States. So I think it's important for anyone in the Indian Health Service to know that they are beholden to this declaration because the US was a signatory to it. A lot of countries adopted it. Some countries have even added, ingrained it into their constitutions. Which is what Chile is doing, in the process of doing right now. So the declaration is the minimum standard. This is also important. It's not the ceiling, it's the floor. And the rights that are recognized in there are the very minimum of how countries and member states should be respecting Indigenous people's rights. Here are some other UN declaration provisions. They cover discrimination, self-determination, lands, territories, and resources, racism. I just wanted to include some context on some of the other provisions in there, but we'll get more into that later. So objective 2, to learn about the relationship between Indigenous rights and health disparities, including increased medical emergencies. So these are some of the research that I've found on Indigenous health disparities. Found research on Native Mississippians that they have the higher rates of chronic disease, including asthma, cardiovascular disease, diabetes, and smoking. And we all know that those risk factors, those chronic risk factors, obviously lead to more medical emergencies. Native Americans have been significantly more likely to die from COVID-19, more likely to die from accidents, suicide, a lot of emergency medicine applications here, and disparities. including motor vehicle traffic death, which is the highest among all other reported unintentional deaths. So there's a lot of preventable deaths that fall into the field of emergency medicine in Indigenous communities. Here are some other statistics that I found. The top killers, leading causes of death in Native American communities, poisoning as well. You see that up there in the unintentional motor vehicle crashes, a lot of things that are very preventable and systemic, and life expectancy as well. So I wanted to talk about colonization and Indigenous rights and how these things are leading to these disparities. And I found research to go, with this information. The lack of self-determination, to live a traditional way of life is a direct result of colonization. And the ability to preserve a traditional way of life has been shown in studies to be a risk factor or a protective factor in diabetes rates because of our traditional foods primarily. And the colonization factor, I think, when colonization happened, I think it's important to understand that we have a right to our traditional foods, and that really disrupted that right, and that has led to a lot of we talk about choice, but in many communities it's not really a choice. In many Native communities, our food deserts today, and that's an Indigenous rights issue, and that makes diabetes an Indigenous rights issue, in my opinion. And all of the acute illnesses that stem or their rates increase from diabetes, and the rates of diabetes, that makes those an Indigenous rights issue as well. And the IHS, also, and I know this is a lot about funding, but to properly fund and staff clinics to enable communities to have preventative screenings and counseling and everything they need to try to reduce the rates of diabetes. And the reason why I talked about diabetes, because I found this recent New York Times article where it said that Native Americans have some of the highest rates of health conditions, such as obesity and diabetes, that make a person much more likely to die from COVID-19. And you can see here that our lifespan dropped almost 7 years since the pandemic began. And we've had the highest cumulative COVID-19 death rates, highest hospitalizations. So all of these chronic diseases that stem from the disruption and the lack of respect for Indigenous rights since the time of colonization, they're still killing us today. So here's sort of my framework that I created. And it's a funnel that, that creates these disparities, colonization, the ongoing maintenance of the systemic oppression of colonization, and the lack of systemic investment to turn those conditions around and to seek justice, create these disparities in Indigenous communities, medical emergencies and things like that. And then when you add that in, the Indigenous health and emergency medical disparities, this is another framework, but I wanted to show that when you add in education on colonization and continued impacts on Indigenous health and understanding and implementation of Indigenous rights in the UN Declaration on the Rights of Indigenous Peoples, that we can find a new, we can envision a different future when you add those factors in to reduce those health disparities. So objective 3, examine how the implementation of the UN Declaration on the Rights of Indigenous Peoples can improve Indigenous health and decrease medical emergencies. So the first example I want to give is environmental violence via poisoning. We saw in the earlier slide that poisoning was the second largest unintentional killer in Native communities. And it's something that I feel like we don't really talk about that much. So I wanted to give some concrete examples. So first of all, going back to the UN Declaration on the Rights of Indigenous Peoples, Article 22 says that states, countries, shall take measures in conjunction with Indigenous peoples to ensure that Indigenous women and children enjoy full protection and guarantees against all forms of violence and discrimination. And we're talking about environmental violence here, that is a term that was recently actually formally adopted by the United Nations. It's a very recent term, environmental violence, but it is a recognized form of violence. We're going to Article 29. States shall take effective measures to ensure that no storage or disposal of hazardous materials shall take place in the lands or territories of Indigenous peoples without their free, prior, and informed consent. States shall also take effective measures to ensure, as needed, that programs for monitoring, maintaining, and restoring the health of Indigenous peoples, as developed and implemented by the peoples affected by such materials, are duly implemented. So the UN Rotterdam Convention is a legally binding convention in the United Nations systems that informs how countries should handle toxins and pesticides. And it currently allows countries to export pesticides that they prohibit for use within their own borders. So the United States currently exports thousands and thousands of tons of pesticides that have been deemed illegal to use within our borders on our own citizens. And this is one of the things I want to talk about too, because as a Yaqui, and I think many other Indigenous peoples can relate, our people cross the borders. Like we have communities on both sides of the borders. So the policies here in the US impact our health in Mexico, and the same thing on the northern border as well. And I think it's important as physicians to try to comprehend how the policies here might be leading to more medical emergencies in Indigenous communities around the world as well. And this is just a quote from the UN Special Rapporteur on Toxics in 2001. So I did a paper with Dr. Tim Erickson, and we looked at the impacts of pesticides in my community, the Real Yaqui communities in Mexico. And we have testimonies from many different traditional midwives, Yaqui midwives, children, and just Yaqui community members where people were passing away. And oftentimes these were emergency medicine cases where they were going to the emergency room with, with acute exacerbations of liver disease, for instance, or respiratory disease. And so I just wanted to highlight here that these are the stories of real people that have been impacted by this policy in the US who have passed away. You can see here, Luisa on the second from the bottom passed away while she was hospitalized, and she went to the emergency room. And this is all from pesticides, a lot of leukemia, a lot of cancers that are killing people in my community. And it's not uncommon for people to come up from our village to cross the border into Arizona to receive care. When I was in 7th grade, I got hit by a firework in the village, and they couldn't take care of me down there in the village. So I was driven across the border and ended up in an emergency room in Arizona, and ended up in a burn hospital for about 2 months. So this is a statement from the UN Special Rapporteur on Toxics after the one that I just showed you. Indigenous people such as the Yaqui have suffered grave adverse impacts on their health and dignity from the ongoing use of highly hazardous pesticides. These pesticides are often imported from countries that have banned their use domestically because of uncontrollable and unreasonable risks. This is a survey when I was working with the International Indian Treaty Council that we did with 118 Indigenous peoples from around the world. And we asked, what is the traditional means of subsistence for your community, tribe, nation, or peoples? And this is the breakdown of what they said. You see farming is the largest, gathering, fishing. The point is that Indigenous peoples are still very connected to the traditional territories and still rely on traditional foods for their communities around the world, also in the US. So this is part of the UN Stockholm Convention, which is another legally binding convention that deals with toxins within the United Nations system. In the preamble, it said Arctic ecosystems and indigenous communities are particularly at risk because the biomagnifications of POPs and contamination of the traditional foods. So I wanted to show you all that traditional foods, that is an indigenous rights issue, but the contamination of them with pesticides as well, and other, toxins that are stored or used in our communities without our free, prior, and informed consent. And indigenous women and girls are disproportionately impacted because they have, in many communities, the central role in food gathering and food preparation traditionally, even still to this day around the world. Cultural practices and higher body fat ratio that lead to increased exposure and risk to these toxins, and that lead to the acute conditions that we see, emergency medical conditions from this poisoning. And here's a picture of indigenous girls in California. They're gathering tulle wreaths for basket weaving. And just wanted to give an example of some of the traditional activities that are beautiful and empowering, but because our rights have been disrespected, have now become an increased risk factor for indigenous girls. So UN DRIP Article 30, military activities shall not take place in the lands or territories of indigenous peoples unless justified by a relevant public interest or otherwise freely agreed with or requested by the indigenous peoples concerned. States shall undertake effective consultations with the indigenous peoples concerned through appropriate procedures, and in particular through the representative institutions prior to using their lands or territories for military activities. So I wanted to give this example as well and frame it within that, that provision of the UN Declaration. So the Yupik in Alaska have been disproportionately harmed from the former military bases in their region. The US Department of Defense dumped toxic waste on the island until 1972. That's still impacting them today in their land and their soil. And this has been exacerbated as well by climate change because of the melting of the permafrost, the melting of the ice, and spreading of the contaminants in different animals that they hunt as well. Another community, the Tewa Pueblo in New Mexico, they're surrounded by uranium mines and factories, and just have disproportionate levels of toxins, PCB levels, that are above the standards for health that have been set by the EPA, for instance. And this has led to cancer, renal disease, birth defects. The Mohawk Nation in New York, same thing. They've been contaminated from activities that have gone on in their territories without free, prior, and informed consent. Elevated levels of heart disease, diabetes, hypertension, and that those things lead to medical emergencies. So some photos from my community, but also going into the implementation of the UN Declaration on the Rights of Indigenous Peoples. But this is my community here, some Yaqui community members, and then this is one of the containers where they store the pesticides in our community. So indigenous peoples have been advocating for their rights for a long time. The woman in the green and white is my aunt, and then the woman on the right of her is my other aunt. They went to the UN a long time ago, and they've been advocating for the respect of our rights in these pesticide policies. And that has actually led to real change and international bans on these highly toxic and dangerous pesticides, lindane, endosulfan, and other highly toxic POPs used in indigenous communities. But even though there's this ban in the UN Stockholm Convention, and remember that still allows countries to export them to other countries. So they're only banned within the borders of one country. But if another country accepts them, they can still ship them, and they still do. And so they still end up in our communities. But this is one example of how indigenous peoples have used the UN Declaration on the Rights of Indigenous Peoples to maintain progress. So another example I want to go into is treaties. So the international standing of treaties in the UN Declaration on the Rights of Indigenous Peoples Indigenous peoples have the right to the recognition, observance, and enforcement of treaties, and states have to honor and respect those treaties according to the UN Declaration. So according to that, we all know that, and many people I think know that the Indian Health Service operates under the trust responsibility, which is based on many numerous treaties, laws, Supreme Court decisions. So the obligation of the Indian Health Service is a treaty precedent, and the UN Declaration said that the U.S. is obligated to honor our treaties, and so the Indian Health Service is a part of that. And I think it's important for more and more people in the Indian Health Service to recognize that their obligation to provide healthcare is an Indigenous right. UN DRIP Article 24, Indigenous individuals have the right to access without any discrimination all social and health services. So this is about our right to equitable healthcare and healthcare services. So one thing I wanted to show is that the underfunding of the Indian Health Service and all the other systemic issues that lead to the negligence of health, that's not honoring Indigenous rights. And I think one thing is a research paper that I found that said that 9 to 11% increase in the rate of hospitalizations occur for each 10% increase in the disparity between healthcare funding for federal employees versus funding for tribal operated healthcare programs. And we can see here this disparity, 2017, Indian Health Service receiving about 4,000. When you compare it to other federal, medical programs like Medicaid, Medicare, there's a huge disparity between what we're receiving and other healthcare programs run by the federal government are receiving. And one of the most stark, I think, is that we receive less funding from the federal government for our healthcare than prisons do. And not to say that prisons deserve less, I think they also deserve more. But I'm just using that to show the level of funding that we get. And I think that that's important. So that's another Indigenous rights-based issue that I think the Indian Health Service can tackle in terms of more funding, that is a rights issue, and that's their obligation in the treaties that were made with Indigenous nations, and that's backed up by the UN Declaration. Example 3, representation in medicine. So the UN Declaration, Article 18, says that Indigenous peoples have the right to representation, to participation in decision-making processes that impact us. And that's a right that all Indigenous peoples have. The UN Declaration also says we have the right to be actively involved in developing and determining health, to administer those programs as well on our own through our own systems and our own institutions. And Article 29, again, just coming back to this, that we have the right to develop and our own through our own systems solutions, and that states should take effective measures to promote those solutions, those Indigenous-led solutions. So this is a little bit of research I've been doing that's not published yet, but it's based on census data and AAMC data. So we found the total versus expected AIN physicians in 2018. And based on our proportion of the population, there should be close to around 7,000 Native American physicians in the US if we had a representative population of physicians. And right now we're, a little over 2,000. So there's a disparity, of over 3,000 missing Native American physicians. And then this is how long it would take at the current rate of Native American medical student matriculation for us to achieve a representative population of Native American physicians. So in 2018, 39 Native American medical students matriculated into US medical schools. So we took that number and we said, if that maintained, if that remained stable in continuity, how long would it take for us to achieve representation? And that's actually, 39 is actually pretty average if you look at the years. So that's kind of where we're at right now. But it would take 108 years, and that's not counting population growth either. So it's probably underestimated. This isn't published yet, but I just wanted to show this to give you an idea of how far behind we really are. And then I wanted to show if we doubled the matriculation to 78, it would take 54 years. So in order to achieve a representative population of Native American physicians, we would have to matriculate 843 Native American medical students every year for 5 years. And right now we're at 39. So we're really far behind. And this is an Indigenous rights issue as well, as I just showed you, that it's a right for us to be represented in decisions that impact us, including in healthcare and emergency medicine that is so essential. So in 2019 to 2020, there were 52 American Indian Alaska Native residents, and that is about 1/3 of our proportion of the population that year. So, emergency medicine is doing a lot better than a lot of other specialties. A lot of other specialties are even worse off, but we can still push more. We can push the needle. We have to find ways to do that because, for instance, I wanted to put this here that Native Americans have the highest levels of homelessness per capita. And we all know that homelessness leads to increased ER utilization for healthcare and many other healthcare conditions, acute conditions that we see in the hospitals. And so it's just one of the reasons why it's so important for us to have representation in emergency medicine. This is a quote I really like that I hear. If we're not at the table, we are on the menu. And that's the case with representation in medicine and emergency medicine as well. So objective 4, an Indigenous rights framework that you can use in your clinical practice, political advocacy, and healthcare delivery. So these are some of the considerations. That it's not extensive, but I think that these are important to consider in your work. So to understand, to know the UN Declaration on the Rights of Indigenous Peoples and what it is, especially if you are connected with the Indian Health Service. Understand the rights of your Indigenous patients, because you see Indigenous patients, you should understand what their rights are in the UN Declaration on the Rights of Indigenous Peoples. Understand the historical and ongoing systemic impacts to Indigenous rights and how they affect your patients. Ask yourself what specific systemic attacks on Indigenous rights are increasing medical emergencies in Indigenous nations. Find ways to support Indigenous peoples in advocating for the protection of those rights. Ask yourself how care can be improved to consider Indigenous rights and historical abuses to those rights. Ask yourself what you can do in emergency medicine partnerships to take Indigenous rights into account. Understand that Indigenous rights are at the core of Indigenous health and Indigenous emergency medicine disparities. And I wanted to talk about one positive example that we did. Dr. Davies and I co-founded the OHS pre-medical program. I was technically an intern, but on the surface, I was the co-founder of the program. But we brought 8 Native American medical students, pre-medical students, to Harvard Medical School and the Brigham, and they all came from tribal college and community colleges. And we knew that those educational pathways into medicine were the least represented among other pathways, and that tribal and community college students face very unique pressures and unique challenges. So we wanted to focus on them. So for me, it was a rights-based approach to this problem of representation in Indigenous communities. We named it after Dr. Charles Eastman Ohiesa, who happens to be one of my direct ancestors on my Dakota side. But just like any first year Native American health program, there were some bumps, but the testimonies after the program were incredibly profound, and how this changed people's lives. People who might not have ever had the opportunity to come to Harvard Medical School and shadow. And one of I think the most amazing things is that part of the program is at the end, they're going to get a letter of recommendation from Dr. Davies and I for their medical school applications. So we're just trying to do, a small scale level solution for this problem. Within this program, I think there are also lessons as well. And I wanted to share, part of my personal journey with the program. Although I co-founded it and I was the co-lead for it, in the institutional policies, I was only allowed to be an intern because I wasn't faculty, even though I was the Indigenous co-founder and co-lead. And I tried to advocate for myself to say that, you know, Indigenous peoples are their own experts, and there should be something in the institution, in the policy ingrained that recognizes Indigenous expertise in Indigenous programs as equal to, for instance, faculty expertise, because we're bringing our experience. And I was doing that too. And it's no one's fault, but this was a policy in the institution that because I wasn't faculty, I couldn't be on an equitable level, even though I was a co-lead for the program. And then because I was an intern, I was working on a grant for 2 months that I was invited to apply to from the Rolex Foundation. And I was told that because I was an intern and I wasn't faculty, that I couldn't apply for the grant because the funding had to come through the faculty. So I wasn't able to attain funding so the program could continue. And I think this was very frustrating to me as an Indigenous expert who co-founded the program. But I'm happy that, you know, Dr. Dabies is the co-founder because she's faculty. So she'll be able to find more funding for it because she has that power. And I think it's important that in these partnerships that that we recognize that partnerships, whether it's emergency medicine or otherwise, it's always better when policies are ingrained that allow for the respect of Indigenous leadership, and that there is some sort of framework that allows partnerships and medical partnerships to be Indigenous led and truly Indigenous led. So another thing I wanted to show everyone, another article was our right to health and traditional health related practices. And so this is more on the clinical level, but I've heard many stories of Indigenous peoples going to the emergency room. And I wanted to share one. In a traditional ceremony, sometimes we have scars and they lead to scars. And one of my friends went to the emergency room and they saw his scars from ceremony. And they said this person is self-mutilating. And he was unconscious at the time because he had a seizure. And so he couldn't tell them what happened. And because of that, he went through an entire different stream of care into the psychiatry that was very traumatic to him. And so these traditional aspects of who we are, I think, do need to be respected in emergency medicine spaces as well. Same thing with language. We're seeing more and more language revitalization, but during the pandemic, I think many Indigenous communities were left without COVID-19 information in their Indigenous languages. And that's an emergency medicine concern as well, because if they can't understand, there's going to be higher COVID-19 rates. And obviously, you know, in many cases they could, but I have friends in many Indigenous communities who asked and who told me, hey, what's going on? Can you tell me about COVID-19? We don't have any information that our elders can understand because they only speak our traditional languages. And I think it's important to consider Indigenous languages as we're promoting and pushing for their revitalization, because I believe there's going to be a future where Indigenous peoples, where tribes are speaking their languages. And I hope for that, where every kid grows up knowing their language, and medicine should begin to start figuring out how they can reflect that as well. So this is one of the things that I did. I created translations for our nations. We worked with Indigenous communities around the world and created COVID-19 information in Indigenous languages. Here are some of the examples. We put out like one of these surveys and we got 117 Indigenous peoples from around the world who volunteered to work with us, with faculty, to create COVID-19 information in their Indigenous languages and to work with us. And so you see all these languages here, many of them from the US as well, including Inuit languages. We had also Navajo too, Hopi. And this is just an example that I wanted to share. If you can click play. one of our translators that we partnered with.
Public service announcement about the corona or COVID-19 disease outbreak.
Ngihe mbungana ngokomtati bori he ngi jonga ora tin si corona ta krite ha he COVID-19 si aninja.
While we adhere to the precautionary measures that prevent the spread of the coronavirus,
Ute chans na ko tin tam sika ntango jonga te ho yu thave te kita.
it is important to strengthen the defenses in our body through responsible and healthy nourishment.
Te ngo chans na ko te ngi tam sika te ngo khak am ngo kieri na ko tu te ngi jonga ki tu ngi jonga te kitang.
Having a healthy immune system means that our bodies can fight the virus.
You can pause it.
Angie had khak am
Goes on for, this is a short clip of a longer video, but just wanted to give an example of one of the community partners we worked with to create information. This one was about nutrition. She was going to go into some of the traditional foods that that might help because they couldn't go into the cities anymore to get food. So a lot of them were, a lot of indigenous peoples were going back in a big way to the traditional foods. Okay. All right, and then traditional knowledge as well. This is part, I think, of what I would like medicine to start figuring out how to respect more. That indigenous peoples don't have to be, have any degree, for instance. They have traditional knowledge, and that should be respected in and of itself. And the UN Declaration says that indigenous peoples have the right to maintain, control, protect, and develop their cultural heritage, traditional knowledge, and traditional cultural expressions, as well as the manifestations of their sciences, technologies, cultures, including human and genetic resources, seeds, and medicines as well. So when indigenous peoples come into the emergency room and they want to use traditional medicines, the system should find a way to respect that. And I know that many systems are, including certain Indian Health Service hospitals and things like that. And those are I think, really great measures to respect indigenous rights within the clinical care itself, and to respect the use of traditional medicines as a valid form of medicine, and respect indigenous sciences as valid science as well. And that Western science is often, one of the misconceptions is that there's so much indigenous science that is misappropriated as Western science. Many of the medicines that are used today were invented or created by indigenous peoples, Native Americans, and that I think medicine, one way that systemically it can respect indigenous rights is to find ways to respect that history, and that indigenous peoples have the right to maintain our own sciences and medicines. This is another part of the survey that we did that I wanted to show, just to give the importance of our medicines and our cultural practices, how important are traditional indigenous knowledge, cultural practices, cultural heritage, including seeds, sacred places, and medicines for the resiliency and vitality of your community. And this was 118 indigenous peoples. 80% of them said it was essential. 2% of them said somewhat important, and 18% said very important. So around the world, our traditional practices and medicines are still vital to us. And I think that's so important for emergency medicine to understand that that is a part of clinical care, because most indigenous peoples, when they get sick in their communities, or a vast majority of them, in my experience, I can't say, I don't have the data on this, but in my experience, are using some form of traditional medicine. And many of the indigenous peoples I know who are going to the emergency room are also using traditional medicines at home, or integrating that into their care themselves. So that's the end of my presentation, and now it's up to you. Thank you so much for hearing me and giving me this opportunity to speak. Like I said, I'm not an emergency physician, but I wanted to be able to talk about something that I hope will give you a framework going forward. as you continue to do all the amazing work you do in the IHS and otherwise. So thank you so much. Are we doing questions or?
Thank you very much for a fantastic presentation. Stay up for a sec. So there are going to be opportunities for questions and answers. This, I think, for Mr. Carmen Lopez, I think there's so much content here that we're going to want to talk about. One of the key foci for the conference is what we can do to help implement the ideas that we're talking about when we go back home. So not just hearing great ideas, but actually thinking deliberately during the conference, how do we make these go into effect when we go back home? So we are deliberately structuring in time at lunch, both today and tomorrow, and then in the afternoons, today and tomorrow, for smaller group discussions on implementation. I think because there is so much content here, we should probably, and you're going to be here for both of the days. Yeah. I think we should direct some of the more in-depth discussions to the lunch and then the deliberate afternoon sessions on this. I want to say thank you so much for this and helping put it in the context that what we all are doing here as individuals is part of a broader theme of narratives that I think is very motivating and very important, and is something that we all have a lot to learn from. So thank you very much for that.
Thank you.
Thank you. So we are for our next speakers, Dr. Dom Maggio is going to come up to help present them. Is Dr. Dobias here? Val, are you here? Val, do you just, as Dom is coming up, do you want to make any other comments here just while Dom's walking up here about any of the other activities that you and Victor have been working on?
No, I just want to commend Victor he's an extraordinary student, beyond a student, right? He's a representative, he's a UN ambassador, former for the Indigenous caucus. And so all of you can recognize his spirit, his representing his peoples, and all the extraordinary work that he is doing. And there are times that you meet people in your life that you know are agents of change. And sometimes the fights are difficult and they're challenging, and there's a lot of hard work ahead. But he is that man and that person at this moment. So I just want to commend Victor for all that he does and his advocacy. So it's extraordinary. So my comments are, I've been lucky to work with and connect with this particular individual who will make a difference in many people's lives. And if all of us can do a little part to make a positive impact in life, the world would be a better place. So thank you, Victor. That's what I want to say.
No, thank you. Dr. Dawi is an amazing person and is doing so much good. And at Harvard Medical School, when I got there, I haven't seen, it was hard to find physicians or mentors who were doing work with Indigenous peoples and Indigenous health. I think, so I'm really grateful that I was introduced to her, and she's been a really amazing mentor to me and taught me a lot. So I'm equally grateful for you and for this opportunity, for all of you, for everything that you're doing again. So thank you.
Thank you very much, Victor. Thank you. And then Dr. Maggio.
All right, good morning. Can everybody hear me okay? Okay, my name's Dominic Maggio. I'm the ED director at the White River Service Unit, working for the White Mountain Apache tribe. I've been involved in various ways with this conference for the last 4 years as well. It's an honor to be here. Part of this conference, there's 4 pillars to the conference. Part of it is this recognition of why we're here, and that was just a testament to the global perspective of this, which oftentimes I can lose working for the region in general. But another part of this is the clinical perspective, and bringing that excellence from a medicine perspective to the front lines, right? Because that's what the whole system, the whole IHS system, the whole tribal system is about delivering. So I had the honor of coordinating the clinical portion of this. And so we were just spoiled with speakers today. So I'm going to introduce our first one. Our first speaker today was actually my clinical mentor in medical school. So Dr. Richard Cantor, He's a professor of emergency medicine, professor of pediatrics at Upstate Medical University. He was the chair of the pediatric emergency services at the institution. He was the medical director of toxicology for the state of New York. He's a researcher, author, mentor, internationally renowned speaker. If you've been to any national conference on emergency medicine, you've likely run into him at some point in time. So we're incredibly lucky to have him. Cantor, can you hear us? There's always the Zoom audio upload.
You can hear me?
There he is. And so, all right, pleasure to have you, sir. So Dr. Cantor is going to talk to us about something that none of us like to deal with, especially because we're in highly rural areas with very limited backup, which is critical care and resuscitation of the critically ill infant. So I'm going to step off the stage and hand it over to a better speaker than me. So Cantor, you have the mic.
Well, thank you. Greetings from Syracuse, from my sunroom. It's always an oxymoron in Syracuse to call a room a sunroom because we have a cloudy climate like Seattle, but you know, without dreams, you have nightmares. This is a wonderful opportunity for me at many levels. First of all, I get to reconnect with Dom. Dom was one of those med students that I got away with the illusion of being a mentor for, but he was developmentally more advanced than I was when he was a med student. He was superb. I was proud of him when he got his residency in San Francisco, and even more proud that he found his way to work in the situation he's doing. I have a checkered past with Native American issues in my own life. When I was senior resident in Syracuse in pediatrics, I was the resident pediatrician for our own local Onondaga Nation. And it was one of the most rewarding experiences I had. It wasn't analogous to the scenarios that you have where I was pretty connected to the medical center, but I learned so much. And now I'm sort of at the other end of things in the medical school admissions committee. And I'm proud to say that our med school has a pathway for Native American applicants. And it's a learning process, and one that the prior speaker highlighted wonderfully. So what I'm going to talk to you about the next bit of time is sick babies. My career has been dedicated to the care of children. I was boarded in adult emergency medicine, but I hate adults. They're just not trustable. They're going to die. They smell bad. They lie. I don't like them. But my point of this whole talk is that with certain maneuvers in your day-to-day practice, you can save most of these kids. Because generally the protoplasm is in your favor. Their lungs work, their kidneys work, and their hearts generally work. So as much as there's trepidation in terms of taking care of small kids, I'm serious about the fact that with standardized approaches, you can get good outcomes, which is the point of the talk. Take a look at this bell curve here of anybody's serious illness. And this is a probability bell curve, probably not, probably so. Why did I put this up here? Well, take a look at this group of patients or kids, the well-appearing kids on the far left in my slide. These are the easy cases. Well, kids are great. You've all read triage notes that sound like the child's on death doors, and you go in the room and the kid's dealing cards and telling jokes, and you go like, whatever this mom tells me, I'm in the clear. On the other end of the spectrum, let me get to the far right, is the ill-appearing group, and we'll talk about them today. And frankly, they're easy because you're automatically directed to do certain interventions. Where you make your money, sorry for the dollar sign, is the difficult group, the kids who are near sick but can be reversed, and your clinical judgment can make all the difference in the world with intervention and whatnot. That's where we are, our sweet spot in EM. And it's no different with adults, you know, the chest pain that could be bad but is bad, that kind of thing. So that's my graphic on that. So I want to talk initially on general management principles of these kids. And this is not in the book, this is time-tested realities of my experience in dealing with small babies. The ABCs of unstable infants. Number one, the airway. One of the most humbling moments for me when I trained was not doing BLS maneuvers on the upper airway. When you get a kid with stridor, pick a stir, And you're thinking, oh my God, I got to tube this kid. They have retractions and they're grunting. So many of us run to the equipment and the oximetry and who the hell knows what. And then we forget the chin lift and the jaw thrust. Trust me when I tell you, moving the big tongue out of the way, and baby secretions are disgusting and they're fat and thick. Don't be shy about suctioning them. And if you have to suction them, don't get some stupid feeding tube. Use the Yankow or something rigid because they deserve it. So don't forget the airway. In terms of breathing, and this is a pet peeve of mine, all older docs hate new technology. Number one, because they don't know how to use it. But number two, it kind of draws the practitioner away from the bedside and the physical exam skills. My point being that good SATs on a monitor have no relationship in children to good ventilation. Most of your 2-month-olds are non-smokers, all right? And they don't generally have a chronic lung issue. Oxygenation is not hard for them, basically, but ventilation can be encumbered. Grunting is one of the most ominous signs in these kids, and it's auto-positive end expiratory pressure. If you see a grunting kid, oxygen will not fix it. You will have to intervene with some positive pressure, whether it be something as simple as an albuterol treatment initially, or the Kruper who gets a vapinephrin or whatever, or on the other end of the spectrum, intubation. But grunting bad. And that is a nice oximeter, right? Remember this thing you bought when you were in med school, the stethoscope? One of my pet peeves at the bedside of these kids is watching my trainees in a critical kid stare at the monitor and nobody lay hands on or do any oscillatory evaluation to see if they're ventilating. Trust me, your parents bought you the stethoscope for a reason. Use it. And I can't overemphasize this. As an example, febrile convulsion kids, which we see tons of, I've been in practice for so long that I do mini studies below the radar. And back in the day with simple febrile seizure kids, when we used to do blood work, which we don't do anymore, I would send off a venous blood gas out of curiosity when they were postictal and they first came in and they were sleepy. And the PCO2s were incredibly high, which freaked me out. And they all self-corrected when the kids woke up. So ventilation doesn't equal oxygenation. Enough preaching. All right, circulation. There isn't any child in the world that doesn't deserve 120 per kilo saline bolus. You're going to hear a lot of research articles arguing, do you use lactated ringers or saline? I could care less. When I practiced, I had a silver dollar in my pocket called I don't care coin, which was I would just flip it and let somebody else make the decision. But everybody deserves a bolus. And the second message is everybody's septic, certainly under a month, but under 3 months if they're super sick. Absolutely give antibiotics presumptively. As long as you get a preemptive prior pre-treatment blood and urine culture, you can do the tap later. And no one can fault you for doing that. So if you walk over to the bedside, get access, draw your bloods, push some antibiotics. We'll go back over this in a minute. A moment on vascular access. Now, in today's generation, sonography has helped find veins and arteries and all the wonderful things in life. But there are things that are sitting there in front of you in these kids that are kind of helpful. The usual sites, back of the hand, the antecubitus, the foot, the saphenous, they're always there. Don't forget them. You kind of know this from the old days. But don't forget the head. The scalp veins are sitting up there under the hair, or if you have a child without much hair development, you're blessed. And this is a high-tech procedure, and I'm being facetious. And it's the first place I'll look in a critical kid because there's not much going on up there and I can have my way with the situation. The veins are listed up there. Let me get you another picture. Here's my high-tech equipment. It consists of a rubber band and a piece of tape. And if I put alcohol around where the elastic band is here, I can highlight the temporal vein, or you can get a frontal vein, and I can get a 22 angio into that space. I would caution you not to draw blood from that. Don't lose the line for getting blood. If you need blood, you can do a fem stick or an arch stick later. But to get access, this is a good, easy poor person's way of doing it. And I don't think there's any of us out there in the wilderness that doesn't have a rubber band, a piece of tape, and an angio sitting around. So enough said. One of my things that you should have stocked somewhere in the hospital or wherever you work where people have babies is an umbilical catheter tray. Most of these are in the OB suite or the neonatal unit. And they come with everything you need to get to the belly button. Now, what am I talking about a belly button for? You're thinking, oh my goodness, I don't do neonates very often. You know, I get that in a NICU. That's where we roll. But you can have 14 days of access to this remnant that's sitting there for you. And you can see the central circulation. I put up a nice fancy diagram. But if you take a look, you know, as God made it, you have two arteries and you have a vein. The vein is very fat, open and wide and welcoming. And all you have to do, watch my cursor, is go in about 3 centimeters. You don't need to siphon it through the ductus venosus in the liver and up to the heart for access. And you will get a tremendously easy opening to cannulate. And if you don't have an umbilical tray, you can get another, like I said, an angio and just thread it in there. And that will buy you time to give volume and interventional drugs. This is sort of what it looks like. There's a tie cord on the base of the cord, and that's in the delivery room because the cord is fresh and full with blood. But at 14 days, it's still patent, but in a good way, it's dried out a bit and it kind of stands at attention. So don't forget your basics. There's the vein with the catheter inserted. This is incredibly rewarding and it's there. So I hope a 1-2 in the morning event, this will happen and you'll be very happy about it. And there's enough pictures there. Okay. Third part, we did scalps, we did IOs, we did rather umbilical veins, and now the IO. Now, when I trained, IOs were on pretty much full arrest kids because we had a humanity issue. We felt it was barbaric to do it in kids who were cognizant and awake, but that's not true. If you compare the sadness of 12 sticks on a very healthy, well-fed baby with a large BMI, and you fail, one quick IO is certainly less pain for the child. And the IO needles are a miracle. And I've got listings on the left, and there's new products every day. And you can give every drug you ever given a resuscitation intravenously or centrally through an IO, except adenosine for obvious reasons. It doesn't get to the heart very quickly. You can even give blood products, but don't forget the IO approach. It's a tibial tuberosity is what we use in most kids. It's tremendously rewarding. You can even use a spinal needle, but that's a practical airway kind of thing. All right, now let's talk about airway here. Here's the problem. Intubation, in my career, as part of one of my confessional mea culpas, if I took the thousands of kids I've intubated, I probably should have intubated about 80% of them 20 minutes earlier than I did. We're kind of reticent to intubate in babies, and you shouldn't be. Intubation is in my mind, a sign of control. You prevent aspiration, you ensure ventilation, oxygenation follows. It's also something where you can really control the work of breathing in the child. What babies do worse than adults is they get acidotic quickly when they don't ventilate. They generate a lot of lactate. And in an acidemic environment, your interventional drugs are not a happy place to work. We used to, I have a print, the handout, I don't know what I sent in, but for some reason I wrote no cuffs. No, cuffs are indicated in almost every size group now. It's been researched, it's got meta-analysis, use cuffs on the tubes, and I'm not going to teach you. Regardless of the age, rapid sequence intubation is indicated. Now, you're very good with adults with this, where you sedate, paralyze, and you all have your favorite drugs, and God bless you, enjoy them. Anything you want to use on a kid works, whether you want to use a depolarizing agent or non-depolarizing, just use what you're comfortable with. But don't be a wuss. And why am I saying that? I used to give these kids like a hint of Valium or a benzo, and kids will kick your butt. Don't bother. Take them out. Take them out. Pre-treat them, pre-oxygenate them, give them a paralytic, and go for it. Something worth doing is worth doing well. So as far as the airway is concerned, tube them. And I guarantee you, and a lot of you are in the Wild West out there, PICUs love to extubate. They don't like to emergently intubate. So no one will ever be discomforted by the fact that you may have jumped the gun and tubed some kid early enough. Should be the worst thing you ever do. Believe me, history favors the aggressive. All right, there's the usual picture. You went to med school and learned about the upper airway. Everybody's got a big tongue and a small this and a whatnot. But the only take-home message here by far is the fact that the larynx is incredibly anterior and superior. You're never, my best advice is when you put the blade down, a CMAC, a bougie, whatever you guys like, wherever you're looking, I guarantee you the opening to the glottis, the epiglottis, is about 3 millimeters higher than you think it is. It's always towards the next floor up. So it's just a pointer, but that's a separate lecture. But keep it in mind. And the last thing about breathing and ventilating, God bless nurses who are the smartest people on the planet. Everything I ever learned in my life that was practical and useful, I've learned from two groups of people. One were the nurses in the emergency setting. They're brilliant. And I was shameless. I would just pick their brains day in, day out. The other is my wife. But the kids swallow air. They either swallow it in distress, seizures, or they swallow it from being bag ventilated on with a mask. That big gut is the end of the vital capacity and the tidal volume in that kid. And you must, I repeat, empty that air out. So slip an OG or an NG in there and do some suctioning. I can't overemphasize this. It's very embarrassing. I've done a million post-intubation films with flat plate, say, oh, it's above the carina, God, let's get a soda. And then I look at this monster gut filled with air and I'm realizing I'm pushing up against an obstruction. So get the air out. And other pitfalls, quickies here before we get to cases. Number one, you must always correct hypoglycemia at the bedside. Please get the blood sugar. They drop like a stone. Don't be embarrassed with missing that. Keep them warm. And I'm telling you, if everything's great on a Monday and it dies on a Tuesday, it's always the freaking airway. Be humble. Direct visualize. You don't feel comfortable, take it out and do it again. Okay. Let's do some cases. The overview of my cases are the following. We're going to do a little shock, a little blue, a little seizure, and a little lethargy. And we're going to move quickly through the cases. We all learn from cases in emergency medicine. The days of lists and causes are over. Information in a vacuum is called med school. Real life demands case review. Okay, let's take case one. Shock to the system. This is a 1-week-old. Let me move my screen down. Presents with a 1-day history of poor feeding and apparent respiratory distress. 1-day history, okay? Vitals are terrible. He's tachy. He's breathing at 40. His pressure is not acceptable at 50/30, and his SATs could be better in room air. He's got a cap refill that is pending. It's so long, and that's not too good. And he's grunting. All those bad things I told you about initially. And he has no murmur. Okay, so how do we classify this kid besides like, oh my God, he's sick? Well, basically, this kid is in uncompensated shock. Everything's failing. He's dilating. He's perfusing the wrong places. He's not ventilating. What's the etiology? Now, you don't need to be a scientist at this point. Stop. Don't do a medicine grand rounds. What are the 6 causes of this? No. Somebody's got to do something here. Could he be septic? Could he be hypovolemic cardiogenic? We'll get into that. And on top of this craziness that he's going through, he has accompanying respiratory failure. So you got to work on this. All right, where should therapy begin? Airway, it's open, it's moving. He's breathing, but he's got a lot of work of breathing. He's retracting and grunting. So something ain't working right. And his circulation is completely unacceptable. Could it be distributive or better said, septic shock? It's probably not hypovolemic. He got sick in a day and there's no history of vomiting or diarrhea. So it could be that if you want to play scientist. But like I said earlier, get your blood cultures and push some antibiotics. We're still pushing ampicillin because of listeria and it's around. And there's a 3rd-generation cephalosporin in your future. You can use taxine, you can use ceftriaxone. It's all listed, but just give it after you get the blood culture in the urine. Done. We did it. Okay, great. Volume is indicated. Like I said, I'll give him 20 per kilo of saline, and I may go up to 60 per kilo, depending on the clinical response. I will, in the midst of this, get a film to check heart size. You can do it with sonography. That's completely up to you, but I do need to have an estimate in my mind of what's happening after the boluses. So we push the saline, and I mean push it. Don't drip it fast. Don't put it on a rapid pump. You sit there with a syringe and you push it. Okay. I gave him 60 per kg of saline and he got sicker. What a lovely moment. And his liver fell out of his body. No, it got bigger. And his chest film is as follows. His heart was bigger than his lung. Portable films are terrible. You're going to remember all your peds cardiopulmonary radiology. Is it boot shaped? Is it egg on a string? Who are you kidding? It's just the heart's in the chest. It's big, and it's not a good looking situation. So I didn't do a good job here. I must have missed something because the volume didn't fix it. Case decision point. Should I tube him? I should have tubed him when I met him, but I got to it. When, like I said, if you don't ventilate, you become acidemic and nothing works. And again and again and again, take them out, use benzos alone. That's not going to work. Say goodbye, do it right. Okay. And again, about the stomach, I threw that second slide in to remind you. So case progression, could this be heart disease? Okay. What's the possibility? Of course, it's a possibility. Not the cyanotic variety. Remember, his SATs were 90%. And most of the blue kids who have really critical cyanotic lesions will show the colors in the first day, in the NICU. We'll get to that. This kid, I should have put it in the slide. When we put him on some O2, his SAT came up to about 96%. So that really favors non-heart, a cyanotic heart disease. But what he has most likely is what we call a ductal dependent lesion. And you'll see where I'm going with this. That's a picture of the patent ductus here, which is the life-saving shunt between, for a child who's got a left-sided outflow obstruction where the blood's got to get to the body somehow, and you'll see where this goes. So this is my cheap way. This is with all apologies to my pediatric cardiologists. This is peds cardiology in 2 slides. Number one, I divide cardiac anomalies in newborns into 2 groups. The first group are called the blocks, and they're LV outflow obstructive lesions, aortic stenosis, coarctation, interrupted aortic arch. The holes are what you grew up knowing about: ASD, VSD, PVA, and a full AV canal. Why do I divide these up? Because they have different threats to the well-being of the child. And you'll see where this goes. The blocks, generally, those kids can't make it out of the NICU if their ductus is closed. With LV outflow obstruction, you'll go into immediate shock without the PVA. So bad news. It does close at home, however, and that's how you meet this kid at a week of age who comes in, who's doing okay, and then falls apart in a heartbeat. And these kids come in less than 2 weeks of age in failure, and they look septic because failure mimics sepsis with poor perfusion. So remember that if it's under 2 weeks, definitely under a week, they are probably a ductal dependent population. The holes, now they're different. They can hang around for a while and they don't cause any real difficulties until, and try to follow this in your mind. When you're born, your right-sided cardiac pressures are higher than your left because they've been pumping blood to your lungs, which were full of blood. As you develop over the first month, the left-sided pressures predominate. When they take over, they get higher than the right as we grow up and keep in our physiology. When the left-sided pressures go up, the holes become a problem, whether it's atrial, septal, ventricular septal, whatever. When left-sided blood pounds over to the right side of the heart, it goes into the pulmonary artery outside of the right ventricle and just pisses off the lung. And eventually you will absolutely go into failure. And that's what I'm getting at. When the LV pressures are high enough, you're in trouble. They don't get sick for a couple of weeks. And this is a divining rod in my therapy for these failure kids who come in looking septic. The age matters. Younger favors ductus, older favors holes. Okay, case resolution. The child's in failure. The antidote, and I'm a toxicologist as well, for ductal dependent lesions is prostaglandin E1, and you should all have this somewhere in your armamentarium. And basically it opens the ductus and the kid's cured at the bedside. It's a miracle. They had an echo, showed a coarctation, and he was repaired surgically. That's a clean case, non-septic, whatever, shocky kids. What's the take-home message? Kids under 2 weeks in shock deserve consideration of volume loss by history, sepsis, that's everybody's got it, and then the ductus dependent lesions, and just give the prostaglandins. If you give a prostaglandin to someone who doesn't need it, It's like a tree that falls in the woods. It doesn't do anything wrong. So there's no risk, zero risk here. There's zero risk here, and feel free to use it. And here's my shock made simple algorithm. Get pre-treatment blood cultures, give antibiotics, boom, done. That's 2 minutes of your life. Give volume, give 20 per kg. If everybody gets sicker, you're screwed. It's probably cardiogenic. It's not distributive or volume loss. If the heart's big, give the prostaglandin. Like I said, if it's equivocal, you've got room for more volume. Let's keep going. If the vitals improve, give another 40 per kilo. If they stabilize, then you can have a lot of fun. You can have a bedside conversation about what to do next. Consider sepsis. If you're thinking they're hypovolemic, they better have a history. And there's no secrets in a 1 to 5 day old with diarrhea, vomiting, poor intake. You'll get it. If it's not there, it ain't happening. If the vitals aren't better with the volume, you're up to pressors. That's a separate lecture. Every once in a while, you get a kid with pallid shock. It's rare. Usually it's an hemolytic anemia. Don't give them a lot of crystalloid. If they come in with a hemoglobin of 3, you're going to screw them up with volume that's crystalloid. You got to give them packed cells, but that's a real outlier. Okay, that was shock. Got it? Simple. Most kids get better. They do well. The cardiac kids, prostaglandin buys them some time, and you move on. Okay, let's do the next case. This is called nothing seems to work. This is what I call the definition of insanity, which is doing the same thing over and over again with expecting a different outcome. You'll see where this goes. This is a ALS call in the middle of winter of a 3-week-old African-American male who's having breathing trouble. He's in mild distress, marked distress, and he's blue, but is perfusing pretty well. They heard wheezing somewhere on the way in, and his albuterol treatment was given as per protocol on the way in. Up he comes, you meet him. The mom says nothing happened in the delivery room, and he had a normal history there. She was worried about sickle trouble because he's got 2 siblings with sickle cell, but sickle cell doesn't affect you in the first week of life. You don't have enough beta chains to give you a sickle crisis. He was well all day. They put him in a bathtub. He coughed a bit and then turned blue, and he's been blue since. All right, let's take a look at the physical. He's tachycardic. His heart rate is 180. His respiratory rate is up. His BP is acceptable. Cap refill's okay. His SAT is 50% in room air. All right, what do you do when you get a bad SAT? My favorite thing to look at is people put it on the other side of the body of the patient, as if the other half is doing well. It's like a hermaphroditic cyanotic person. That's obscene, but we do it. Okay, what in general, he's just pissed off and blue. All right, little retractions. We took him to the trauma room. We drew a big crowd because people freak out with peds arrests and things like that. So we got a big crowd in the room. On exam, he's moving air. His good air entry and no murmur. Now, a moment. His heart rate is 180. Now, I'm going to hit my desk now. This is 180. Ready? As you're typing your EMR, do not insult me and say S1, S2 is normal. The only person who can hear a murmur in that heart rate is a full of crap third-year med student who calls it a mid-diastolic diamond-shaped crescendo murmur. The heart is, in my chart, beating, okay? Sorry. And the skin is blue and the pulses work. So for some reason, he's not in failure, but he be blue and real blue. All right, some data comes back. His hemoglobin was meh. His gas on 100%, not so good. His PO2 is 50. He's ventilating at 28 with his PCO2, but he's not doing well. One of our seasoned nurses who, tough cookie, came in and she saw the stats in the room. She was the night nurse, and she was early part of her career. She was really nurturing. And then now at this burnout phase, she was neutering. But she goes, well, how much O2 is he on? I said, 100%. She goes, well, give him more. I said, we don't have that. But I didn't do anything with the 100%. This is not cool. His EKG was just sinus tach, and his film showed cardiomegaly only. No fancy shape. So real-time case progression. This is a true story. I gave him albuterol. Why not? We gave him a bolus. Why not? I gave him antibiotics. Great. Because we all know the leading cause of cyanosis is ceftriaxone deficiency, but it's my case, my screw up. It worked. It didn't do a damn thing. So this is my point of being insanity. What am I doing here? Nothing was working. reality-based outcome. I gave him 100%. I didn't budge the SAT. He's still screaming. The room was getting smaller at this point. All the fancy crowd that was watching it started backing away because they were worried about the outcome and they didn't want to be in the room. And more people were watching the case from afar. Here's the film. It is not helpful. It is helpful in the sense that he doesn't have the snowflake appearance of failure or any free air like a pneumo. But otherwise, I got nothing here. All right, not helpful. So it was time to earn my money. I kind of knew what this was, but number one, I gave him some morphine. You're thinking, what the hell is he doing? Well, I have seen this before, and you'll see where this goes. He got stoned. What a shock. And, you know, we were holding the mask on him. We're giving him 100%. He was freaking out. He was cold. And his stats were 50. What was I doing? So he just completely zoned out. His respiratory rate decreased. His sats jumped to 98%. My heart rate went below 200. And basically what he had, and I've got these 5 T's for you, was a cyanotic heart lesion. Take a look at the list. The way I remember the list, I think I'm still on screen, is by my fingers. This is truncus arteriosus. This is transposition, tricuspid atresia, tetralogy of Fallot, totally screwed, total veins. Those are the 5 lesions. Everyone but tetralogy will mess you up in the first 12 hours and they won't make it out of the NICU. Tets can get home and lie in wait till your shift, and they can come in with a TET spell. This is a handy table. I don't want to dwell on it. There's a picture of tetralogy. It's not the point of the lecture, but this is the one that can hang out at the mall for a week and then get sick on your shift. And TET spells are very fascinating, not the point of the talk. They're self-limited, scary as hell. And the treatment is, without getting into it, take a look at the interventions, is to decrease blood return to the heart and get people stoned. Okay, so let's do the take-home message. This is the blue kid. The secret of mammalian oxygenation: do not complicate things. You breathe it, that's the lung. You pump it, the heart, and you carry it, that's the hemoglobin. Anything that mucks up one of those systems makes you blue. And use the hyperoxia test. I'll get into that in a second. For some reason, with methemoglobinemia patients with hemoglobin poisoning, their SATs are always about 87, no matter what we do. As a tox person, I'll tell you, we don't know why that is, but I threw that in. So here's my cyanosis made simple chart. Number 1, give supplemental oxygen. If its SATs go up, it's lung. End of story. Let's try it again. Give O2, no luck, didn't go up. Could be heart, could be hemoglobin. How do we break the tie? If the PO2 goes up, but the SAT stays low, it's hemoglobin trouble. The PO2 is just dissolved bubbles and a gas and fluid. And if your heart's working, it'll go up. So you'll get a wacko gas where the PO2 could be 140, but the SATs are low. That's methemoglobin or hemoglobin poisoning. You can dissolve it, in other words, but not carry it. Let's keep one more algorithm. If the SAT doesn't rise and they both stay down, consider both, the blue heart disease or methemoglobinemia. But if the PO2 stays low and the SATs are low, it's heart disease. Better stated, I love this table. This is the hyperoxia test. You can see at the top here, this is room air. This is 100%. You can see with pulmonary disease, the PO2 goes from 50 to over 150 and the SATs go up. That's a nice group to play with. The methemoglobin group, the PaO2 initially is about, SATs are 85%. You give them 100%. Oh, I dissolved it. That's your PO2, but I didn't saturate it. I've got hemoglobin poisoning, and the rest is heart disease. Okay, so that's blueness. Okay, we're getting there. So we did shock, we did blue. Now let's do C's. This is one of my favorite cases because it combined my favorite thing, critical illness with psycho craziness. This history here is striking. A 2-week-old comes in for seizures. You've seen this before. He's 2 weeks now. He's a neonate. Mom fed him, put him down. She went in the room and he was seizing. Not complicated. Normal birth history, okay? He's twitching and postictal at times. They couldn't get a line in him on the way in. They gave him rectal benzos and he's coming to your house. He comes in your ED and you begin your care. Life's good. Okay. Now, we had everything ready for this kid because we got a pre-announcement. And if there was ever any, what's a good word, golden rule of emergency medicine is if you prepare for a complication, it never happens. Excuse me, and we were kind of ready. So in he comes. His vitals are okay. Nothing to say much here. He's tacky. Who isn't? He's not a bad guy. He's got good cap refill, but he's seizing. His fontanelle is flat. His pupils work. I couldn't see his disc margins, and neither can you. 2-week-old, anybody who says they can see their disc margins, they can also, that's the kind of person who can see the Loch Ness Monster and Bigfoot. So forget that crap. And the pharynx had some secretions. Okay. The neck moves well. His chest, he's moving air. God bless him. His belly's got swallowed air, but it works. His pulses are normal and he's seizing. So, okay, so let me get to the point. What are my first priorities? And this is where we mess up. You're thinking, I gotta get meds in while he's seizing. No. Your first priority is the ABCs. Like I said, most sick kids hypoventilate, and kids in status are definitely hypoventilating. I don't care what the SAT is. The real reason to stop the seizure, besides saving white and gray matter, is to get the lungs working. So what interventions would I provide? I'm going to oxygenate and ventilate, and I'm going to stop the seizure. Okay, you've all been to this with adults. It's a simple thing. You give 3 doses of a benzo. You should do them quickly and should piggyback them, and don't get shy about it, because what is the side effect of it? Maybe they get apneic and you tube them, but we'll get to that. Phenobarb is something you can load people with. It will stop a seizure. It will stop breathing, but we can fix that. But it will stop a seizure. This kid stopped breathing. Is this bad? No, I intubated him. Is that a negative clinical thing? No, it means, to me, intubation is like a greeting card for the airway. It means I care. That's a bad joke, but you get my point. He's not going to aspirate. All right, a list. I hate lists, but common etiologies of baby seizures. Take a look. 99 out of 100 kids are going to be febrile, and you know what to do with febrile seizures. But he's 2 weeks old, and he's in this creepy group. He could have been beaten up with trauma, non-accidental trauma. He could have a congenital malformation, structural lesion, or some metabolic thing going on. He is an open book. None of this wait and watch kind of thing. So here's my priorities for neonatal seizure. I'm going to give him antibiotics. I'll tap him eventually. I'm going to CT him, mea culpa, because somebody could have shaken him or had some bad ways with him. And I don't have anything rapid or more rapid than that at the bedside. I'm going to spend money on metabolics. We'll get to that. And I worry about a toxin. The most common toxin to worry about is cocaine. And benzocagnine in the urine is a very reliable tox screen. And sorry to say, it's still out there. So keep that in mind. All right, lab results come back. Okay, chem strip, good. CT was normal. I'm very pleased with that. His white count was normal, but take a look at these crazy electrolytes. He's hyponatremic, hypochloremic. What do you do when you get a bad lab value that doesn't make sense? You repeat it. So we did, and it was just as crummy. So I now have a hyponatremic normal glycemic seizure kid. Now, what's going on? He's 2 weeks old. And we did tap him, which was normal. So I got another list. I apologize. A low sodium. What are the etiologies? Now, it's very simple. I either drink it down or lose it out. The dilutional group, formula mishaps are not a joke, especially in lower socioeconomic groups who have limited resources and actually add more water to the formula, and they dilute their child. It's a sociologic, unacceptable outcome of the effect of poverty in our country. SIADH is overstated, but you save free water with inappropriate anti-diuretic hormone. Salt depletion is kind of weird in kids, but they can get it. If you say Lasix to a kid, they just will pee. I've got 2-year-olds who take grandma's Lasix, but that's not this 2-week-old. Adrenal is a big thing here because that's part of your mineralocorticoid axis, and we'll see where this goes. You can sweat it out if you have cystic fibrosis, and most of the indigenous population is protected from this. This is endemic mostly to Scandinavian people. And then you can poop it out, but you'll have a history. So where are we going with this? Where does our patient fit? And this is the most annoying part of the case. I was feeling good about America, having stopped the seizure, figured out he's hyponatremic. I was going to give him some salt and call the PICU, and life's good. But then the third-year med student comes out and says, there's something wrong with this kid's genitals. Now I'm thinking, oh, does he have genitals? Did I look? No, I didn't do much of that. I did femoral pulses with my hand under the diaper because I was mostly concerned with points north. And he had ambiguous genitalia. And then, like, anybody who's seen this knows what this is. This is congenital adrenal hyperplasia. You just screw up your adrenals. You don't make cortisol. You don't make mineralocorticoids. You waste salt. Your urine. You guys can read up on this. It doesn't matter knowing it at the bedside. It means knowing what to do about it. And there are formulas for how you give 3% saline. Most of the time, the kids get better on the way in. So this is a hyponatremic seizure. The take-home message is, sorry, take off the damn diaper. Don't miss these things. Don't miss a hernia, ambiguity, and make sure the femoral pulses are there, and check the anus because there are imperforant anuses out there. Seizures made simple. We're getting there, guys. Number one, this is a great article. It's not even that old. It's 5 years old. And they go with the evidence-based interventions for status. The stabilization phase, I've summarized it in red, is what a shock, ABC, and the D should be dextrose and chemstrip. I can preach it until I'm blue in the face. Then the next phase, look what they say here, benzos followed by barbs. Now you're thinking, I don't do that. I usually give phosphenotoin, and you can, but they recommend barbs. It's pretty old school, but it works. And then there's phospheny. A myth about phospheny. In the beginning, God made phenytoin, and you couldn't push it fast because the diluent, propylene glycol, was toxic to the heart. They took it out, they phosphorylated it, and they said, now you can drip it quick. Yeah, the joke is, it's not an active drug until you dephosphorylate it. So it's not the quickest actor. And then, of course, valproate, and then levetiracetam was in there, which does work. I love asking neurologists how that works, levetiracetam, and they make up some story. I don't think they know how it works. And third therapy is when you paralyze them and you do ECG monitoring. These kids will never get to that point. Most of them will stop with either phenobarb or the Keppra. Okay, I'm ending with this. My cheap way to work up a lethargic infant is not seizing, just out of it. And I will hold to this till I'm long gone. Easy steps for a lethargic kid. Fix the damn sugar. I can't keep telling you this. Get a finger stick. It's cheap, free, and fast. You look like a fool if you wait for the blood to come back an hour later and they're sitting there with a sugar of 10. It's happened. Everybody gets Narcan. The only person who doesn't like Narcan is an addict. And I don't think 3-year-olds are addicts. When I did my fellowship at Bellevue at NYU, I gave Narcan to a junkie and he started chasing us around the room. And I said to the nurses, what do I do? And they said, you woke him up, you deal with it. That's New York. In Syracuse, they would have helped me. Narcan, Narcan, Narcan. No downside, okay? You got to image people. You can't miss a bleed or a tumor. You're going to have to do it quick and dirty. And eventually you get around to tapping. Like I said, draw the blood, get the urine, give them Septizure, and you got about 3 hours to tap somebody before the antibiotic screws up the culture. So that's the beginning. What I just pointed out to you could take 20 minutes to work up and very simple. These are non-negotiable actions in my mind, and you all know how to do this. Okay, other easy steps. Look, mnemonics are helpful, right? This one's called AEIOU tips. It's very helpful here. A problem when you get to my age is with the mnemonic is you remember the letter, but not what it stands for. But that's my problem, not yours. I made intussusception red because they lied to you about it. They say it's current jelly stools and vomiting. No, they get lethargic, very lethargic. So it's put in there. So remember that mnemonic. Okay, those are my cases. So let's go back over the final points and we'll wrap it up. The shocky infant, the majority of hypotensive peds patients will get better with a fast intubation, quick volume resuscitation, antibiotics, and pressors. Occasionally, you run into this guy, the cardiac kid who gets worse with volume. You know how that goes. Prostaglandins for everybody. It's on the house. Just do it. And again, like I said, if it's less than a week, it's usually ductal dependent. If it's later, it's a whole. You treat the whole kids with Lasix and positive pressure, and they get better very quickly. What about the blue kid? Hyperoxia test. Like I said, if it rises with a little supplemental O2, it's lung. If you give him a supplemental O2 and the SATs stay low, meaning it doesn't bind to the hemoglobin, but the PO2 goes up, you've got methemoglobinemia. If you get O2 and both things don't go up, it's a blue heart. And the kids in status, the concepts, everybody's hypoventilating. Number 2, use the standard epileptic drugs you use, you know them well. Intubation does not equal defeat. It's a good thing to do. And later on, if they're not getting better with standard interventions, it's always something structural or metabolic for that reason. With that, I think I made it. I can't tell you what a treat this is. I'm really sorry I didn't make it out there for the conference. This is just the world we live in, unfortunately. And you know, the way the pandemic is rolling and whatnot. I know a couple of things to be true. I respect you all immeasurably for doing all this. I'm thrilled that you care enough about kids to bear with me. And you are so lucky to have Dom with you. It's a lucky thing that's going on. He's an amazing person and physician. I'm lucky that he left Syracuse because it's a pain in the butt. But with that, I wish you good health and thanks for listening.
Thank you.
You're welcome.
It's syphilis. A couple of old slides. While preparing for this, I came across the idea that 1 in 5 Europeans in the 1800s had syphilis. So it was really prevalent. I love this. All of these men have it. Women stay away from dance halls. I would suggest it takes more than dancing to catch it, but it's possible that that's the issue. All right, so my intention is to kind of march through a little bit of the epidemiology. That's kind of my training. I did time at the CDC as was mentioned and did the Epidemic Intelligence Service. So I'm by nature an epidemiologist. I want to put that out there because I want you to know that it's there. One of our preventive medicine docs met with our regional hospital summit, regional healthcare ER, to talk about syphilis. And they literally said, oh gosh, it's been years since I ordered a syphilis test. We don't see syphilis. So what I'm here to tell you is it's there. If you're not seeing it, it's because you're not looking. And then we'll go over some of the clinical highlights. And these slides, I don't know if you're making slides available. If not, email me. I'm happy to send these. It's a hodgepodge of CDC slides and other public domain slides. You're welcome to look at them at your leisure. All right, so this is the overall epidemiology in the US. This is where I did my training in Chicago, this type of era. So this was the HIV era, right? And we were seeing a lot more syphilis. And so I was pretty used to syphilis, but then honestly, I fell off the radar. We didn't see much syphilis for quite a long time, and now we're coming back. Fortunately, we're not back to here. I think it was all the dance halls that maybe did that, but hopefully we'll never get back to that rate. This is again, the total versus early, non-primary, non-secondary, and primary and secondary. These are the cases that are of public health importance because they're highly transmissible. We looked at our data recently, and one of the things we found is we're not very good at putting our syphilis cases in the right categories. So for us, we just look at total cases, but I would admit that I can't tell you with great confidence which are primary, which are secondary, and which are tertiary or late latent. It seems to be going up more in the West, which I think includes us. We're obviously Southwest, but in the CDC data, we would be included in the West, at least Arizona would. And here's the rates for men and women. One of the things that we've all learned in medical school and is still true is that syphilis is a little bit more common in the slightly older. So we see things like herpes and chlamydia in the younger teens. We see gonorrhea sort of in this range, and then syphilis comes in up there. But that's by no means hard and fast, right? All it takes is a sexual contact with an infected person. One of the things I mentioned during the break, speaking to somebody, is that STIs are all about social networks, right? If you have a social network, all humans are sexually active, more or less, and it's just a matter of what's in your social network. So a lot of these diseases just have to enter the social network. And in most settings, people are most sexually active with people in their same age range. So it sort of keeps these things divided by age. When I worked in Africa, we saw a lot of overlap with older men and younger women having similar epidemiology because there was a lot of more what I would categorize as predatory sexual practices of older men having sex with younger women. But in our culture, most people stay within their social network. Now, here's the one that I think should be most sobering to us. Look at the slope of the line for American Indian and Alaskan Native. So everybody's going up more or less, but the American Indian and Alaskan Native community is seeing a much more significant. And again, I think this is just a matter of when did things enter a social network. And so now it seems to have entered well. I also mentioned at the break, for those of you who like to look at video of syphilis outbreaks that I think are really interesting. If you Google Frontline and Conyers, Georgia, there was a huge outbreak in a high school there about 2 decades ago that was highlighted on the front line. And it was exactly that. There was a social network of a lot of sexual activity amongst the high school students. Syphilis entered it, and there was an explosion in the rates of syphilis in that community. Again, more or less to keep us focused on our area, we are one of the higher rate areas for primary and secondary syphilis. And again, primary and secondary means recent transmission, presumably, if it's correctly categorized. And then drilling down even further, here we are. So we're in one of the high rate counties. So the message of all of those slides that just went by is there's a lot of syphilis. It seems to be increasing in American Indian Alaskan Natives. It seems to be in our area. So you need to be aware of that, and you need to be looking for it so you can treat it. Who gets it by sex and who their sex partners are. To some degree, I think the fact that men are heavily overrepresented, I think it's because clinically it's easier to see the lesions in men. So there's a lot of women who will have syphilis and the lesion will be internal to our exams. And unless you're doing vaginal speculum exams, you're not going to see the lesions. So I think we're probably missing a fair amount of disease in women, but nonetheless, we also see much higher rates in men who have sex with men. And now going back to American Indian Alaskan Native, and you'll see that it's the second highest rates for both men and women amongst the race ethnicity groups. The other high rate is amongst Black and African American. So now to congenital syphilis. You might remember that slide on overall syphilis. Not surprisingly, the bump in the early 90s correlated to the bump in total cases. And we're starting to see an uptick in cases right now in congenital syphilis. So it makes sense, right? If there's more syphilis in women of childbearing age, there will be more congenital syphilis. And where is the congenital syphilis? Again, not a big surprise. It seems to be in the same areas where there's more syphilis cases. If you look at actual rates of congenital syphilis by race ethnicity, again, these are CDC slides for 2020. The highest group is American Indian Alaskan Native. Now, obviously, the number of cases is much lower because the proportion of the population that's American Indian Alaskan Native is lower. And this is from the Arizona Department of Public Health. I didn't pull up New Mexico. I do have something later on in New Mexico, but same story. There's a big increase in syphilis amongst women, and there's an increase in syphilis in babies. So 166 babies born with syphilis in 2021 with 10 deaths. That's fairly profound compared to where it was just 3-4 years ago. And one of these cases, which sort of prompted our notice, honestly, we were distracted by COVID, so we sort of missed the start of the syphilis epidemic on our reservation. So we sort of have low numbers. They were climbing. We didn't really notice it because we were busy with COVID. And then we had a death of a newborn with syphilis, and I think that brought it more clearly to our attention. And this is the data from us. This is the only data I'm going to give from our local. We have a more sophisticated set of data to try and drill down a little bit. But the point is simply that we're having more syphilis in our area as well. And so I suspect, and I know that many of you have really good data at your sites, I suspect you're all seeing somewhat similar data. All right, so that's enough of the epidemiology. The conclusions are pretty simple, right? There's more syphilis than there had been since the early 90s. It seems to be disproportionately affecting American Indians and Alaskan Natives. There's more congenital syphilis, so we need to be aware. So what is syphilis? This is the clinical stuff. The statement, as I made earlier, is to know syphilis is to know medicine because it's such a complicated disease. So I'm not going to cover all the nuances, but as much as it's complicated, it's also not. In a sense, I would just say the summary is simply, it can do a lot of different things, and it clinically can look quite broad, and it ought to be in your differential of many, many things, and it probably isn't. It's sort of like as an ID consultant, as soon as I see a consult, I almost always am ordering an HIV test. Probably nowadays I'm ordering RPR, just as I did in the early 90s, because if it's not the primary disease I'm dealing with, it may be part of the constellation of infections the patient has. So I would say that it's going to be hard, but it's not as complicated as our textbooks would make it. This is a great slide. I just came across this. I had missed this article. It was in 2020 New England Journal. Nice summary on syphilis. If you're going to read one thing to refresh your memory on syphilis, this would be the article. And if you're going to look at one slide from the article, this would be the slide I'd look at. And the thing to remember is if you get syphilis, you go primary, you could go straight to CNS early. There's secondary, and secondary can cycle. So in other words, you have a rash, it's syphilis, you never get treated. 3 or 4 months later, you have a recurrent rash from secondary syphilis. That happens. But I think the interesting one is probably 70% of people who march on to latent will have lifetime latency and are asymptomatic. So it's not universal that people will present with symptoms. And so a lot of the elders we find who have dementia and we notice that they have syphilis, it's dementia and happen to have syphilis infection in the past. It's not the cause. Now, occasionally you'll end up just treating because you have nothing else that's treatable, but that's not really an ER decision. All right, so how do we test? This is kind of the big change over the last several years. For many of you, it's not a change because you trained under the newer guidelines. Traditionally, we got an RPR, which is really just a mix of non-specific antibodies, both IgG and IgM, and it's not specific antibodies against treponema, and that's why there's a lot of false positives. But why is it a good test? Well, it goes up when you have active disease, and it typically, not always, goes down when you're treated. So it's a nice marker that things have gone well with the treatment. The problem with screening with it is so many other things give you a positive that you end up with a lot of false positives and you have to confirm it. So if you're pregnant, you have higher rates of false positivity. If you have lupus, et cetera. So then became the reverse screening, which is looking for the antibody first, often by ELISA or CIA, but that's overly sensitive and not completely specific either. So you need to go on and say, is it really a positive? Is it active? And if it's RPR negative, you confirm it with the most specific test, which is the TPPA. In an ideal world, you'd probably do this up front, but TPPA misses some, so you sort of would never be perfect. All right, one thing I want to mention, only because it's worth knowing, we put a lot of weight on an RPR, right? And we get dilutions of RPR. It's a visual test. If any of you have ever tried to do it, like be the person who reads it, there's reader variability. And that's one of the reasons we talk about fourfold changes. I could look at a card and say, it looks agglutinating to me, that's a 1 to 2. And the lab tech may look at it and say, no, that's actually negative, it's 1 to 4. So a 1 to 2 and a 1 to 4 are actually the same value, they're just interpretation. We're going to go at White River to an automated RPR system, which should remove some of that variability. So who should you test? You really should test anybody with lesions. 30% of genital lesions with syphilis are painful. So even the painless versus painful is not a really hard and fast differentiation. Sometimes you think you saw something like this. I remember one of my favorite, I don't know, you have to be sort of an ID geek, I guess. And I did do some tropical medicine training, but I was seeing patients in rural Malawi years ago, and a kid walked in and I was like, oh my gosh, it's yaws. I haven't seen yaws since I saw it in a textbook 25 years ago. Some things just stick in your mind. So if you see a weird rash, typically looks raspberry and heaped up, that's a very syphilitic rash. Of course, it could be yaws if they're coming from rural Africa, but I suspect you won't see that. So again, who to test? Any kind of neurologic defects, acute hepatitis. This one is missed, I think, occasionally, like especially in our setting, we tend to attribute it to either infectious or alcohol associated, and we have seen a syphilitic hepatitis. So you just be aware it's in the differential. Again, I suspect those might be picked up more on your inpatient unit, but if you're in the ER and you're curious, you might send that as part of your evaluation panel. So how often do you test people? Pregnant women, and I'll come back to this another time because I have one specifically on pregnancy, should be at initiation of prenatal care, which hopefully is in the first trimester, but I know it's often not. Should be done again by 28 weeks, and then it should be done at delivery if you're in an area where there's a fair bit of syphilis. And I hope you just picked up on the fact that there's a fair bit of syphilis where you're working. So you should be testing pregnant women ideally 3 times during pregnancy. If they have a partner, of course. Men who have sex with men should be tested in most settings about every 6 months. Some settings I know with high rates will test every 3 months. When I worked in Chicago and had a large panel of patients with HIV, I almost never got people in that often, but that would not be unreasonable if you have a lot of syphilis in your area. And then HIV positive individuals typically are tested every 6 months or so. It depends a little bit. I took care of a lot of maternal child HIV, and obviously it's not like HIV itself gives you syphilis. It's just that the behaviors that led to HIV often lead to syphilis infection. So it really depends on the sexual activity and partners of the patients. So here's a bunch of lesions. And the reason I picked up these is partly to let you know that it looks like a lot of things, right? I mean, a lot of these, I might have thought this was some sort of abrasion or maybe even herpetic. It wouldn't jump out at me as being syphilitic. So I think if you're looking at a lesion and you're testing for herpes or you're thinking it's herpes, you really got to do an RPR as well. I will say, and this is totally off topic, but our first and only case of monkeypox so far, I swore it was herpes. It just looked like herpes to me, and it was monkeypox. So I'm not so convinced that myself as a non-dermatologist is that discriminating in my ability to differentiate the causative organism based on how it looks. And then there's atypical lesions, like this is a chancre in the mouth, and I don't think most of us would think about that automatically. All right, so secondary syphilis, I think all of us know this is the one that's teeming with spirochetes. They're everywhere in the body. It's quite impressive if you were to do dark fields, which none of us do. But these are the unusual skin manifestations. Those are the things that most of us notice. This is also when you're going to see the hepatitis predominantly. So if you see people with pounds and soles or other unusual skin manifestations and they're sexually active, especially if they have new partners or multiple partners, you would want to add a syphilis test to your evaluation. So here's some examples of secondary syphilis lesions. And it can lead to hair loss, which is a notable thing that perhaps sometimes we miss. And then tertiary, this is the one that you're not really going to see clinically that much. You might see these lesions, which are really impressive. And this is, by the way, what yaws looks like. It's that classic guma lesion that looks sort of raspberry-like on the arms. But that tells you something. It's not specific to syphilis. It's a treponemal manifestation. But mostly what you're going to see is the CNS if they're clinical. Remember, 70% are not clinical. And tabes dorsalis is the dorsal root ganglia being destroyed, so it can manifest in tons of ways. The classic ones from med school days are the Argyll-Robinson pupils. I think I've seen that once in my career, but any kind of ataxia, unexplained neurologic defect would merit looking for syphilis. And then there's latent. And I think the thing to remember about latent, if it's within a year, then it's really functionally like primary and secondary, both in treatment and how to think about it epidemiologically. If it's over a year, then it's different. You really can't time it. And the only way to know is if you happen to have the good fortune of having a negative RPR within the last 12 months. So sometimes you have it, but most of the time you don't. You get the patient who's RPR positive, it's a titer of 1 to 16, their TPPA is positive, and you can't time it. So you just assume it requires full treatment for latent. And then I do want to highlight pregnancy. As I mentioned, obviously the only way to get rid of congenital syphilis is to identify pregnant women with syphilis and treat them. If you treat them, you'll be treating the baby. You do want to document a 4-fold decline and at least 30 days before delivery to feel confident that you've adequately treated the baby. The interesting change, I think I might have it on the next slide. I guess I have it further on, so I'll mention it here, given my time. 2015 CDC guidelines said that pregnancy gets treated with 2 doses for early syphilis and 3 doses for late. But 2021 guidelines say treat it just like a non-pregnant patient. So single dose should be adequate. Arizona public health guidelines still are on the 2-dose regimen. I don't know that I'd lose sleep over that. If you have a patient and you give them 1 dose and you want to give them a second, no one's going to fault you on that. But 1 dose is considered adequate. You treat pregnancy-associated syphilis the same as non-pregnancy associated. Congenital, tough manifestations. I have only once or twice, maybe in my career, seen clinical where I said, aha, this is syphilis. Once was just doing a well child exam at 4 weeks. They had a cataract, and there are not a lot of reasons to have a cataract in a newborn. Turned out to be congenital syphilis. So mostly you're going to see a kid that doesn't show any signs or symptoms. The most recent case we had in our community was a 5-week-old with an aseptic meningitis that turned out to be congenital syphilis, but there was no skin or exam manifestations that would have told you this was syphilis. So how do you test? Again, I think these are kind of nice slides to help guide you. If you have, a person has syphilis, your IgM goes up. Almost nobody tests for IgM, but your specific antibodies, IgG, go up over time. Your RPR goes up and then comes down with treatment, although some people never go away. So these are the serofast. So these are the slides to remember when you're thinking about which test you're using. Early on, none of them are going to be positive, just like any other infectious disease, right? Early on, you're not going to catch it with antibody tests. It takes at least a week, often 2 weeks. And then this is the group that I've seen some pregnant women. It's so unfortunate for them, but they just keep getting penicillin because they're 1 to 4. They've had syphilis in the past. They come in, you don't know, you treat them. They stay 1 to 4 next pregnancy. You're not so sure, so you retreat them because, of course, they've been sexually active. They've come in pregnant, and so it's really a tough one. But unfortunately, in pregnancy, you're just going to have to overtreat, and you have to talk to them about it because it's not a pleasant shot to get. All right, these are the limitations. We already talked about them. This is what it means when we say 4-fold, right? This is 2-fold, this is 4-fold, this is 8-fold. It's sort of basic math. And this is what happens if you ever get syphilis, you're going to have antibodies for life. So the FTTA or the TPPA is always positive. You use the RPR to tell you if it's active. Again, you'll have some people, and one of the pieces of data that I'll show you in a minute, some studies show as many as 20 to 30% of people are what's called serofast. So they stay RPR positive for life. So it's not a perfect test, but a 1 to 2, a 1 to 4 is a good indicator that they're RPR fast. Almost nobody who's just RPR fast, meaning that they kept their RPR positive despite adequate treatment, is at 1 to 32 or 1 to 64. So those definitely get retreated, but the other ones are tough, sort of head scratchers. I think from an ER perspective, just assume it's recent, give them a shot and say you're going to follow up with your PCP and they'll decide if you need more penicillin. And that's a perfect response for an ER. All right, I think life has gotten easy because, back in the day, we always obsessed over 1 shot, 2 shot, 2 or 3, 3. And now all of the early stuff gets 1 shot of penicillin and the late gets 3. And so life has gotten simple. So late gets 3 doses. And neurosyphilis gets IV penicillin. Again, not necessarily an ER decision. This person comes in, they're demented, they get an LP. If they're positive, of course, they get treated. And this is from that New England Journal article. It's the summary of the updated treatment guidelines. Again, if you were looking for one resource, of course, the CDC guidelines work well, but if you wanted one in an academic journal, that New England Journal 2020 article is a good one. So as I said, pregnant ladies, treat them according to the stage. And that's the big difference. So if you hear people saying, oh, shouldn't we give 2 shots? Yeah, that's what we said 5 years ago. The new data says 1. Again, I don't really think one would argue if you gave 2 instead of 1 because you're not certain. And here's a summary of what we do. Early gets 1, pregnancy early gets 1, late latent or late latent syphilis gets 3, and neurosyphilis, of course, gets IV. And I think we should say it's worth remembering that penicillin is the only proven treatment for syphilis, right? We have other things that probably work, but there's not enough good data. So if you get somebody who's allergic, your best strategy is to desensitize, not as hard as you think. If they're not pregnant, there are acceptable alternatives such as doxycycline, but the safest thing to do is penicillin, and desensitization is usually quite safe. And I would say serologies are great, but it's a rare event that you have the RPR available from within a year. So what we're doing, I'm going to go on because I got my little cue to remind you of the sero-fast. So some people will keep some RPR, but it'll be low and it'll be about 15% maybe. There we go. So this is kind of the summary of what we're doing now at White River, and I would suggest most of us should be doing because of the epidemiology. In the old days, we would test, we'd eventually make a diagnosis, the public health team would go out, they'd investigate, they'd do some tracing, and they'd try and treat them, either get them to come in and treat, or if you have it available in your jurisdiction, they would treat in the field. What we're doing now is we're trying to encourage testing and diagnosing and treating all in that first contact. So if you're seen in the ER, you draw an RPR, it's positive, treat them, report it to public health nursing, they'll do the follow-up. We are switching within the next month to a rapid analyzer in our own lab so we can get RPRs back within an hour and we can make a decision right away. We are using point of care testing for our field work. And this is a test that we studied and published from Zambia. It's just a lateral flow test and it measures IgG. So this doesn't tell you that it's active disease, it tells you they have syphilis antibody. But in the right setting, such as a high incidence setting, you could use that as an indication to treat. So we're encouraging our field test. You got a contact in the house, you do a finger stick, it's positive, you give them penicillin, you draw the blood for an RPR, and you let the PCP or the team follow up to decide, oops, did I give them an extra dose of penicillin for a false positive? They had syphilis way in the past and they're not active, or hey, they need more penicillin. So the risk is you will overtreat, but we feel like that risk is worth it in our setting right now. We don't have it in the US, but the lateral flows we used in Africa did HIV at the same time. So we can get both an HIV and syphilis point of care test. All right, so this is what we're doing. We're telling our ER, please test everybody. And if you're treating them with a cocktail for STI, add bicillin to your treatment regimen, given the rates of syphilis in our community. In our clinics, treat if they're symptomatic or exposed. If you're just screening because you're doing it routinely, then wait for your results. In the inpatient setting, we're recommending an RPR on everybody who gets admitted, which is what we used to do back when I was in training, especially at the VA. Everybody got a RPR because there was a lot of untreated syphilis. And then our field team is treating on contact using a lateral flow. And I think I'm going to stop at that because am I 1 minute? Oh, so I'm going to stop at that. I'll leave it at that. There are very limited data on what to do when somebody falls off the wagon on their penicillin. But if they go more than 9 days, you got to sort of assume that didn't count and start over. So it's kind of a bummer, but there are some data on that. So I think, are we going to wait for questions or do you have questions or?
For Dr. Irlu's presentation, because
Okay.
they're both sort of interlinked.
Kind of
there.
related. All right,
Yeah.
thank you very much.
Thank you.
Perfect. Okay. Thank you, Jim. So yeah, it's just on to the next epidemic. It's been essentially we've learned over time from COVID to work very close and hand in hand with our public health department. And I think that's kind of very unique from an IHS systems perspective is when you can get this interdepartmental work. So the next lecturer, also infectious disease related. And the logic here is that essentially practicing in the rural Southwest, we're exposed to some very unique kind of zebras in terms of infectious disease. So Dr. John Irlu is the IHS Chief Clinical Consultant for Infectious Disease. He's been ID specialist working at Gallup Indian Medical Center since 1994, which I knew he had longevity, but that's longevity, which is wonderful. Yeah, and so he's also on the volunteer faculty at the University of New Mexico. and then a senior clinician at the Division of Global Health Equity at Brigham and Women's. So we're just lucky to have him comment because he is the regional and national expert on this topic. So thank you again.
Thanks so much for the invitation. Can you hear me okay?
Yes.
Super, great. Let's get started. So this is my only disclosure. Like Dr. McCauley, I really hate syphilis. I've hated syphilis for the last 20 years when I was Dr. Charlton's age, working in Gallup, and there's my penicillin to prove it. So let's start with this case history. I'm going to present a 35-year-old man who comes to the ED complaining of severe right groin pain. It's been going on a day. He's been staying in a hogan at his family's sheep camp in the mountains of Northwest New Mexico. He has very marked myalgias and fever. He has a headache and chills. So in physical exam, very febrile to 104 degrees Fahrenheit. The BP is kind of low at 92 systolic and the heart rate's 124. You notice that there's tenderness and induration in the right groin. And but right after you see him, the nurse hands you a CBC report. It shows that the white count's 19,000, 85% polys, 13% bands. The hematocrit's only 47 and the platelet count's 175. So what are y'all thinking at this time? I'd be thinking about these things personally. Group A streptococcus and Staph aureus can very easily cause a purulent adenitis in the groin. You should also think about things like plague and tularemia. Acute HIV infection usually causes adenopathy, but not focal in one single place. LGV, lymphogranuloma venereum, caused by chlamydia serovirus L1 through 3, can cause this picture. And primary syphilis, you often get a groin lesion about a week after the initial chancre. So I'd be thinking about these things, but this person is really sick, so I'd favor the first few on this list. So what was this? This is a classic case of plague or Yersinia pestis. My literature review goes back to 1320 BC by Zabud et al. In the Bible. First recorded case of plague were amongst the Philistines. They were cured with some gold buboes that were used for treatment. Then later, 542 AD, during the reign of the Emperor Justinian in Europe, there were 100 million deaths. And then everybody's familiar with the Black Death pandemic of around 1347, about 250,000 people died in Europe. And then finally, in 1894, Alexander Yersin discovered the bacillus. This is a picture from a bone church taken by my friend, Larry Crook. So these folks in this community in near Prague were so happy about the end of the plague epidemic that they decorated their church with the skeletons of plague victims as a way of expressing thanks. So what do we know about plague? Plague is enzootic worldwide among small mammals. And it likes to go to high desert type places like Central Asia, Kazakhstan, Rajasthan in India, the highlands in Kenya, and then in places like the Four Corners region in the United States. It's carried around this area by prairie dogs and some rock squirrels. But in urban outbreaks, kind of like the famous bubonic plague outbreaks, it's carried by rats. What happens is a flea bites someone who has the plague or bites an animal that has the plague. It swallows the bacillus multiplies in the gut. The flea gets a small bowel obstruction, but with its SBO, it's very, very hungry. It voraciously attacks the human host. And because of the SBO, vomits plague bacilli right into the wound. So you get an transmission that way. And so you get it from flea bites, contamination of an open wound, and very, very rarely from human respiratory spread. So these are some pictures of some cute little prairie dogs looking out of their hole. If you see this, you're probably okay today. But if you see this, that's a sign of a prairie dog die-off, and these these areas are highly infectious. The fleas are hungry because their host has expired, and they will bite you, and you can catch the plague. So prairie dog die-offs are a big deal when you see them in our region. Dogs classically are essentially asymptomatic, but there is a case report of dog to human transmission that you can see in that MMWR reference there. Cats, unlike dogs, almost always die of the plague. There's even a case of human transmission from a cat, from someone who tried to do CPR on a cat who had plague. So this is a picture of what happens to a plague, just a massive hemorrhagic diathesis and hemoptysis. So clinical manifestations, what do you need to know as an ED provider? Bubonic plague. This happens primarily in the summer. So, right now it'll be kind of like the tail end of the season. The incubation period is about 2 to 8 days. And what you would see on the person on your stretcher is an extremely tender, non-fluctuant node that's proximal to a really subtle flea bite. So these are not purulent, pussy nodes. These nodes are essentially dry. They're full of bacilli and some inflammatory cells, but there's not pus in these lesions. Skin is red, shiny, and edematous. So that's a really typical picture right there. Memorize that look: stretched out skin, exquisitely tender. Even the pressure from the sheet is painful for this patient. And here is a bubo in the axilla on another patient. Real super tender. You don't want to touch these, or they don't want you to touch these. Septicemic plague is another variant. This is fever, nausea, vomiting, diarrhea, bellyache. Blood cultures by definition are positive, and the mortality rate's really high. In a series published in Gallup many years ago, like approximately 30 years ago, Tempest and Crook, who were my former bosses, they showed that people who came into the ED and were initially thought to have gastroenteritis often died when they had septicemic plague. Those who were thought to have pyelonephritis and got gentamicin were the survivors. So just keep that in mind for a minute. And then lastly, pneumonic plague. These are bilateral interstitial infiltrates, often complicated by a bad bacteremia with meningitis, ophthalmitis, and arthritis. This is seen in urban outbreaks. It's not at all common in the areas where we work. So how do you diagnose it? Let's just focus on bubonic. You stick a small syringe into the lesion, you inject 1 cc or 1 ml of saline into the node, aspirate what you just injected, inject, reaspirate, inject, reaspirate until the material is pink. And you then take that pink material and get a gram stain and Giemsa stain, and you can see a safety pin-like rod. A fluorescent antibody stain can be done in Fort Collins. There are PCR assays out there. They're not commercial. They're mainly done on old skeletons to detect plague in ancient ancient persons' remains. You can also send some of that fluid that you get from a blood culture or from the node aspirate and inject it into blood culture bottles. And you should also obtain 2 blood culture bottles to see if there is a bacteremia. So here's a blood smear. This is a person who has these safety pin shaped bacilli, so dark on the ends, little sticks on the side, maybe. This is a bad sign if you see this on a smear, but that's what it looks like. What's the best treatment? Streptomycin, really hard to get. You have to give it usually intragluteal. Gentamicin, much easier to get, 5 mg per kg, usually given every 24 hours. My colleague, Dr. Boulanger, who used to work in Crown Point, talked about in one paper that she wrote, the equivalence of gentamicin and tetracycline. Quinolones work well too, so levofloxacin and ciprofloxacin, but gentamicin in 2022 is really the drug of choice. If the plague is in the brain, if it's in the joints or they're in shock, you can use an old-fashioned drug, chloramphenicol. Haven't used it in 2 decades, but it's out there. And then a nice treatment for very mild cases of bubonic plague is doxycycline, so 100 milligrams twice a day. And you might consider giving it after the IV treatment, and you give it for about 7 to 14 days. So gent first, doxy second. So what are the pearls that I want you to take home today? Look for really tender buboes in the axillae or groin in patients who are in shock. So you're in the 4 corners, someone's in shock, make sure they don't have bubonic plague. It'd be a real bad miss. Think about septicemic plague in people who have undifferentiated fever and shock, and give gentamicin 5 mg per kg right away if you think the person has plague, because that's the treatment of choice. There's a reference from Crook and Tempest for that that I mentioned in the talk. Okay, let's move on. The next patient is a 59-year-old. It comes to the ED. There's fever, cough, and bloody phlegm. And they have a history of working as a construction worker in Southern Arizona. You find some right basilar bronchial breath sounds, and you see tender red nodules. And the CBC is notable for a slightly high white count, but all those eosinophils. So that I put things in green to draw your attention there. Physical exam, the temp is not 1,000, it's only 100. And the white count, as I mentioned, was 19,000, all eosinophils, or 19% eosinophils. Here's the X-ray. So a cavity in the right lower lobe, not in the apices. And it's kind of thin-walled and has a little bit of infiltrate around it. So remember that picture. So I would be thinking at this point about TB, but what's wrong about TB in this case? It's in the lower to mid zone of the lung, not in the upper lobe. Why would you see eosinophils in the peripheral blood? And so those 2 things are unusual. Anaerobic lung abscess possible, but more I would think about a chronic infection with fetid sputum, and I would often see an air fluid level in that round cavity, so it doesn't quite fit. And then thin-walled cavities, thin-walled, there's 3 possibilities that you should think about: cocci, sporotrichosis, and if you're looking at someone who's coughing up blood from the area where my tribe lives in Northeast India, paragonomyosis, so that's a lung fluke. So what is the epidemiology of cocci? Because that's what this case is. It's seen in a lower Sonoran life zone, but in these places, San Joaquin Valley, Southern Arizona, New Mexico, Western Texas, Northern Mexico, and you can actually see it in South America, especially in Venezuela. It seems that African Americans and people from the Philippines and Pacific Islands are at some increased risk for dissemination. And persons who are pregnant are also at risk for dissemination, especially during the 3rd trimester. And a paper that might be relevant to this group is this one. It's one our group wrote back a few years ago, looking at cocci among American Indians and Alaskan Natives for a 14-year time period. And compared with whites, we basically looked at hospitalization rates. Hospitalization rates were much higher amongst AIAN compared with non-Hispanic whites, 58% versus 13.4% hospitalization rates. And we noted that among the AIAN in age over 65, diabetes and evidence for extrapulmonary or progressive cocci were the big risk factors for admission. So how do you get cocci around here? Outdoor activity. Construction is #1 in the patients we see, archaeological digs, but it can be something as simple as living next to a place where there's construction going on, a bad dust storm, sandstorm sort of thing. That's what you look for. Heavy rains in February and March usually lead to an increase in autumn cases. So think about this around this time of year. And remember that cocci is infectious. You can get it by breathing in this dust, but it's not contagious. A person can't cough it onto someone else like tuberculosis. If someone had a draining sinus, you wouldn't want to take the dressing, let it sit around and create spores and then breathe in that dressing. So throw those dressings out immediately into the bio waste, and don't mess with that bag. So mycelia grow in the soil during the rainy season. The mycelia turn into arthroconidia, and then you get spherules in the tissue. So here's a picture of that. Here is some mycelia. Every other segment of the mycelium involutes, and they crack off. So this is your crab legs or arthroconidia spore appearance. It swells, starts to look like a lemon. Next thing you know, it looks like a grapefruit with septation. And then it septates even further, so it looks like a pomegranate, until finally it is a large spherule full of these tiny endospores that can be transmitted to other tissues. So everything up here happens in the environment. This happens in the human host. What's it like, and how's it likely to present in the ED? Acute infection, 60% are asymptomatic or just have a mild cold. 35% develop a self-limited pneumonia with the typical things: fever, sweats, anorexia, cough, chest pain. That sounds like regular pneumonia, but on exam, go looking for that erythema nodosum. When you get the labs, look for peripheral eosinophilia. And then when you shoot the chest x-ray, remember those thin-walled cavities. That's the big thing. But you can also get infiltrates, hyalurodenopathy, and effusions, just like bacterial pneumonia and TB. But a thin wall cavity should make you think. 1 out of about 200 people just get disseminated disease with extrapulmonary disease. So here's a picture of erythema nodosum. I think you've seen these sorts of rashes before. They're tender, they're red, and they're nodular. So chronic disease happens in people with diabetes or other immunocompromised hosts. You can get progressive cavitary pneumonia, empyema, bronchopleural fistulas, osteomyelitis, septic arthritis, wart-like skin lesions, and then lastly, the dreaded complication, chronic basilar meningitis with hydrocephalus. So here's a warty toe lesion from cocci. Here is a septic joint that you can see there in the wrist. And this is a patient I took care of who had a big adenitis. This is a big lymph node full of cocci. So how do you make this diagnosis? A culture is the way to go. You basically grow it on the plate. If some growth happens, you don't open the plate and sniff it like you would to check for Pseudomonas' smell. You quickly keep it sealed, send it to the state lab, give them a warning that you think it's cocci, and then they'll do PCR on it. You'll have a diagnosis in 2 days. And this mold grows pretty fast. A serum and CSF antibody can be sent. The EIA is sort of the screening test. The immunodiffusion and complement fixation are secondary tests that can be done. And with a comp fix, you can actually get a titer, kind of like an RPR. There's a spurious cell skin test that was available. It disappeared, became available. We don't use it. I would go with this serology and with the culture. Here's the draining sinus I just showed you from the lymph node. This is an AFB stain showing a classic example of a spherule packed with little endospores. And you can see all the polys reacting around it. So how do you treat it? Antifungal disease. We give it to severe acute disease. We give it to acute disease in immunocompromised hosts. And we give it for disseminated disease. So you don't have to treat every mild case of cocci. Amphotericin used to be the gold standard. You'd give IV ampho to everybody. You would give it intra-articular injections, and we still sometimes do that. They even did CSF barbotage, where a person was placed in Trendelenburg because they had meningitis. A lumbar puncture was done. Ampho was mixed with purified olive oil, and the olive oil was allowed to drip downstream into the brain. We don't do barbotage, it's barbaric. We have other better treatments, but we still use IV ampho for people who are immunocompromised with severe diffuse pulmonary infiltrates. The treatment of choice is fluconazole. So I usually use 400 milligrams daily for pulmonary cocci, but if it's in the brain, you have to at least double that, if not triple it. And then itraconazole can be used as a backup drug. You're probably not going to mess with this in the emergency department. It also has to be taken with an acidified diet. So people often will take their itraconazole and chug it with a Coke. The duration of therapy is 3 to 6 months for acute valley fever, should you choose to treat. 12 months for severe disease with dissemination. And then if it's in the brain, it's a lifelong treatment. I have a link down there to the Valley Fever Center of Excellence's nice little handout that you can download. It has a lot of good information in it. So ED docs, what should you look for? Look for thin wall cavities, look for erythema nodosum, look for peripheral eosinophilia. Go ahead and send that COXI, EIA, IgG, and IgM test as screening tests, and then consider doing an immunodiffusion COMFIX. In our hospital, we had them all lumped together because the internist wanted it that way, but this is a really good way to screen. And if you think somebody needs therapy, it's a good idea to pick up the phone and call an ID doc like Dr. McCauley, Dr. Giannis in Phoenix, or one of us up on Navajo, where there are 5 of us. So last case, last few minutes. This is a 31-year-old man, comes to the ED with diarrhea, bellyache, and back pain. On exam, the temp is 102 Fahrenheit. The heart rate's 120. The BP is 87. Toxic appearance, diffusely tender belly. The white counts is 12. The hematocrit's 50. Platelets are 93. Alk phos is 121. Transaminase is great. Billy great. Glucose a little bit up. Urinalysis is normal. And a chest X-ray shows patchy infiltrates. So if this person came in the ED during the last 2.5 years, we'd say, oh, this could be a case of COVID, and there's a mesenteric thrombosis or something else going on. That's what we would think about automatically. But what you really ought to think about are these things. Septicemic plague can present with bellyache, Rocky Mountain spotted fever, pneumococcal pneumonia. Sometimes you get abdominal pain when you have lower chest infiltrates. Group A strep toxic shock syndrome, really hard to diagnose, very lethal. Think about it in this sort of presentation. But for this case, this is a case of hantavirus pulmonary syndrome that went quickly from prodrome to full disease. So this was first recognized in Gallup in 1993 by Bruce Tempest and Larry Crook, the authors of the Yersinia pestis paper I talked about. The earliest cases were retrospectively diagnosed by serology from frozen serum banks back in July of 1959, first case, and then an MPOX stain from some post-mortem tissue from 1978. So this has been around for a long time, but it was recognized in 93. This is Dr. Tempest, who is my mentor, and then my colleague, Dr. Crook and his wife. Dr. Crook is the guy on the far right there. The syndrome is, we call it hantavirus pulmonary syndrome or hantavirus cardiopulmonary syndrome. The US vector is the deer mouse Paramyscus maniculatus, and the virus is called Sin-Nombre virus. There are also a couple other hantaviruses that are in the United States, Black Creek Canal and New York, carried by different rats and mice. And these are the mice from our region, the deer mouse. Unlike a house mouse, which has a gray belly, mus musculus, you flip these over and the underside is white, and some of that extends onto the tail. But there are mice all over the New World, from Canada all the way down to the southern tip of South America, and you can see all the names of these viruses and their hosts. So this is not just a Four Corners bug. Here's some hantavirus, the bunya virus budding off a cell there in this electron micrograph. So what do you want to not miss about hantavirus in the ED? Febrile prodrome phase. The most common symptoms are fever, chills, and myalgia. But the really, really frequent one that you ought to look for is nausea, vomiting, bellyache, and diarrhea. Cough and malaise can be there, but they're not prominent. And then sometimes people are just short of breath, a little dizzy, back pain, and sweats. But you ought to be thinking about hantavirus in the back of your mind, and anybody you see who's vomiting, has bellyache and diarrhea, in my opinion. CJ Peters from the CDC has shown us that it's not HANA if they have a rash, conjunctival, injection, petechiae, peripheral, or periorbital edema. What you need to look out for is thrombocytopenia. This is critical. If the platelet count's under 150 or 140, start thinking about this. And if you're thinking about sending somebody home, bring them back in 12 to 24 hours to watch the trend. Because if it drops greater than 40 points over a period of 24 hours, that person probably has hantavirus in the right clinical setting. Also, the hematocrit will rise. So when you see it go up, up in the 50 range, that's a bad sign. Then bands, atypical lymphs, and immunoblasts. So here's some of those immunoblasts that we're talking about. There's dense chromatin, concretions in the nucleus, like any plasma type cell, there's blue cytoplasm, but there's some clearing right next to it. So think about that on these two cells here. Koster-Fukar criteria. Fred Koster is an old friend of mine, did some research together. Hemo concentration, a crit greater than 50 in males and 48 in females. Platelet count under 150, leukocytosis with left shift, absence of toxic granules. Immunoblasts make up 10% of the lymphocytes. These are really helpful criteria for making the diagnosis of hantavirus. In Sehotzoi Medical Center in Fort Defiance, Arizona, they did a study on this. And I believe Dr. McCauley's group tried using these criteria during the COVID pandemic, and they were not quite sensitive enough, was my understanding of what he told me once. Here's a chest x-ray. It goes very quickly from minimal infiltrates to a total whiteout effusions in enlarged heart that's not pumping. So hypotension and pulmonary edema are the main component of the pulmonary phase. There's pump failure with low cardiac output and a high SDR. And then there's a recovery phase where they have a lot of polyuric diuresis. They get better fast. And then some of them are left over with the equivalent of PASC. It's like a post-acute sequelae of hantavirus with asthenia, myalgias, and PFT abnormalities, a little bit of wheezing and whatnot. It's not at all uncommon in these folks. So how do you diagnose it? You send a lab test and you send it to the CDC, and you might get it back a month or two later. You can send EIAs. I think they go to ARUP in Salt Lake nowadays. These also take a while. They're not going to help you in the emergency department. And we used to be able to get an immune blood assay at UNM, but no longer. So what should you do as an ED doc? If you suspect this, get moving really fast. When they show up, a PA catheter is really helpful, but not in the emergency department. This is something to do at the tertiary care center, not at small Indian Health Service hospitals. Don't give IV fluid. IV fluid will push this person into pulmonary edema. Don't intubate in the field. The intubation can lead to a drop in preload, and the patients will code, and you'll have a disaster on your hands. So try not to intubate if you can help it. Dr. Harkin from UNM says norepi is the best drug to give. She doesn't give antibiotics. I always give Rocephin, gentamicin, and doxycycline because I'm an ID doc and she is a pulmonologist. ECMO can save lives. You can drop the mortality rate by at least 33%. There are no good antivirals, and don't give any IV fluid. So pearls for you to take home, a few seconds left in the talk. Don't miss the prodrome with the GI symptoms and myalgias. At that first visit, try to think about it so you at least bring them back in 12 to 24 hours for a recheck CBC. Send that CBC, look for those low platelet counts, high hematocrit, and immunoblasts. And then when you are convinced they have the disease, do not give lots of fluid and don't intubate. There are some references. I always like to close with a picture from my homeland. This is a rice field in the village of Secho Zubza in Nagaland in Northeast India, where our tribe lives. That's all I have. Are there any questions?
just fantastic folks in all of the sites that are colleagues in this effort. And then number three, just how many partners there are in other places that really care about this and about strengthening all the work that's being done. So I think what we'll do, thank you, John, for all the help with everything. We're going to go ahead and go to the break for the lunch. And if we could put up the agenda on the screen, what we have planned for the afternoon, the lunch is free time. However, we are leaving an open opportunity if people would like to be part of a voluntary sort of working lunch, where maybe over the next 10 minutes, people could get their food. If you want to come back into this room, we are going to have a discussion both today at lunch and then tomorrow at lunch about some of the bigger picture directions that we're looking to take things. And for today, Victor was generous enough. He will also be able to continue on some of the bigger picture themes with some question and answer with that fits into what we're talking about. What is the direction of next steps for Emmerich, for the people working in the IHS, for this community that's assembled here today? But that is totally voluntary. We will have a similar discussion tomorrow, continuing those same themes that will be a little more specific about concrete next steps for Emmerich and for the IHS. This afternoon, we have two excellent, we have four excellent presentations. There will be a panel. We will be at 4:30. Again, there will be optional small group breakout sessions on this. There will be an additional discussion available around the missing and murdered Indigenous women and families. So they will stay as well for that. So for the afternoon, your choice in terms of what you want to do for lunch, your choice of if you want to participate in any of the small group discussions and which one. And otherwise, we'll plan to see everybody back by 1 for the start of the formal content. So thank you, everybody.
Sticking around. Great conversation. Hey, everyone. Welcome back from lunch. Hope everybody, it seems like everybody was here. Thank you for participating in that conversation that we just had. We're going to, as Paul said, do it again tomorrow, but get more specific about the direction of MREC, and we'd really be grateful for your input on that. For those who weren't here, hopefully you got some fresh air. So we've got an interactive moment here, and you could win something. You could win something which implies free. You get a free thing. A free thing. Yeah, yay, free things.
It's talking.
That's-
That's talking.
That's talking. Okay, but you're gonna have to work for it. So we got a couple of questions. And these are important historical trivia questions that are very relevant to this group. And you already should know the answer to one of them because Victor provided that earlier today in his presentation. But for one insulated, very fine, high quality, frontline Indigenous partnership official water bottle, which will be mailed to you later because they're in Boston. Who can name the first Native American physician in the US? This is a two-part question. What's that? But he's got a mic too.
Susan LaFleche. I'm pronouncing it wrong, but I know that it's something like that.
Yes.
Yeah, LaFleche. It's a French word, so.
Yes. That's I can't pronounce it. Dr. Dobies, can you pronounce that for us?
La Flèche, what does that mean? La Flèche, no, it's an arrow. Picot.
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 Laflèche
is a-
Picot.
La Flèche
Susan
Picot.
Laflèche Picot. And I don't have a date. Let's see. It looks like
They are 1889.
1889. Graduated from the Women's Medical College of Philadelphia. Okay.
Where did
So,
Dr. Osa
You
graduate?
know where to pick up your bottle, your water bottle, Victor.
It's in Boston.
That was you.
Okay, but now that was, I think, the harder of the two. Don't yell it out, but who's going to get their hand up first for who is the first male Native American physician in the US? Quick hand. Somebody had the answer before. This is for the limited edition water bottle. Somebody had it, actually. Somebody had the answer.
Somebody over there. Yeah, what did you say, Bruno?
No.
Hint, they're related to Victor.
I think somebody said it earlier.
Well,
Oh,
yes,
Oh, yes, eh?
correct. Yes. Charles Alexander Eastman, oh, you say.
oh, yes, sir.
Oh, yes, thank you. Okay, so just connect with the flip team here
Yeah,
for
just
your
give your name.
commemorative edition water bottle.
Address, you can't have that, that has my coffee in it, but.
Yeah, you
get
can't
a
have this
fresh
one.
I promise.
It's got Val's special coffee in it. And so stay caffeinated through the afternoon because there's more questions to come. And with that, turning it over to Topher.
Thank you. Sir. Good afternoon, everybody. My name's Topher. I'm going to be helping host the next portion, an interview with Dr. Celine Gounder. I am the current clinical director at Chin Lee Comprehensive Healthcare Facility for 1 week. 10 years before that at White River, including the director prior to Dominic, and hire Dominic was one of the smartest things I've ever done. Second, of course, to marrying my wife. My mother's people are Ashkenazi Jews, left Germany in the early 1930s. My father's people are Scandinavians who left northern Norway and Sweden to the balmy shores of Lake Superior in the Upper Peninsula of Michigan in the late 19th century. I am here to introduce and have had the pleasure of helping coordinate the emergency medicine public health portion of the conference. And to inform that, one of the lasting lessons for me from our work during COVID is that what mattered to patients' well-being at every level was our capacity to break down barriers, traditional barriers that separated locations of care. So breaking down hospital from public health organizations, breaking down barriers between departments within hospital, between emergency department, outpatient, urgent care, inpatient, discharge planning, et cetera. That is what fundamentally made a difference in keeping people healthy at home. And if they need to go to the hospital, at the hospital near their home, rather than transferred somewhere else. Or if transferred somewhere else, we could bring them back into the fold to bring them home. So it is us working together with our colleagues, largely in the public health sphere, that allowed us to make a fundamental difference during the signature public health crisis of our careers, hopefully. And transitioning from that, for those of us who work in the emergency department, which as a clinical director, I don't know that I will ever again, many of us have had that moment where we're dealing with remarkable complications of chronic disease or of what we call diseases of despair, and seeing it over and over and over again, and I'm wondering, you might have wondered, is this an accident? There must be something structural. There must be a cause to all of this. You're not wrong. That's the theme that drives the next portion of the this conference. So we're ready, I think, to bring in Dr. Gounder. So we'll be doing, oh, there she is. Fabulous. Hello. So I
Hey,
have sort of a
Topher.
hello. I have a sideways Zoom presence, so nobody gets my good side. So for those of you unfamiliar, this is Dr. Celine Gounder. Her robust bio is available on the speaker page of the website. Really briefly, what's relevant to me and I think to us here is that she is a physician and infectious disease doctor with a national level platform speaking to the highest levels of power, who is grounded in the fundamental commitment to patient well-being and fighting against the structural inequities that lead to poor health outcomes and difficult lived experience for the patients we provide care for. Perhaps most relevantly for us, in addition to her work with national news organizations and service on the Biden transition COVID committee, she hosts a podcast on the lovely named Just Human Productions website called American Diagnosis. The season 4, the current season, is addressing specifically issues pertaining to social inequities affecting Indigenous Americans, on which a very recent episode was Victor, who you heard earlier this morning. Good episode. And also relevantly, she has done work at our sites. So she's been at White River and Gallup and other sites in the Northeast. And it was during her time at White River, when she was working with us as a hospitalist, that I met her and sort of became a Gounder head in the early days. So I was working in the emergency department. She rolled into the emergency department to see if at the end of her day as a hospitalist, to see if there were any pending admissions. And it was a fortuitous moment for me because I had just had a patient come in that I'd seen over in our urgent care with a confounding question. Trigger warning for those of you who might be a little bit queasy about children's masticatory habits. So a woman brought her toddler in, and she was concerned about the infectious potential of bloodborne pathogens because here's it comes. She had found the toddler chewing on a used condom that had been left in the living room by her cousin who had spent there the night before. And she was concerned about the potential for contracting HIV from that exposure. A brief, slightly panicked online search via Medline revealed very little data to offer this mother the reassurance that I thought entirely appropriate. And Dr. Gounder rolls in And I posed this question to her, and she very politely, without rolling her eyes once in front of me, said, "Thank you for this interesting consult. You can offer the patient's mother the appropriate reassurance." And the politeness with which she handled this question won me over absolutely. So thank you, Dr. Yonder, for joining us at the 4th Annual Emergency Medicine for Rural and Indigenous Communities Conference. Appreciate your time.
Oh, it's great to be here, and thanks for inviting me, Topher. And hey, Victor, glad to see that you're there and that you gave, as I understand it, the keynote this morning.
Victor
So
says
Topher,
hello.
I noticed that you introduced yourself by your clan name, so to speak. Do you want me to do the same thing?
Yeah, if you would like to introduce yourself, anything else you want to say about yourself, go ahead.
Yeah, sure. So my father was from rural India, from a rice and sugarcane farming village. He was the only child to go beyond the 5th grade in education, and then he got very lucky, got some scholarships, eventually came to the US for graduate school and settled here. My mom is from Normandy in France, and so she was born right after World War II. My grandfather worked in construction, and if you know the history of Normandy and D-Day, there was a lot of reconstruction to do in Normandy at the time. So that's where she grew up. And then she came to the US. Her oldest brother went to school with my dad, and that's how they met. And the rest is history. I was born here.
Terrific. Okay, so just to recap a couple things from this morning, we've had a really some vibrant discussions and a couple of good questions that we can use to set the stage. One of the questions was that how we as non-Indigenous clinicians can provide appropriate care to places where we are serving as guests. And Victor had an answer that I'll cite him this time. I don't promise to cite him when I quote him on this in the future, is that we should be brave in discussing colonialism. And I think that set the stage perfectly for where this conversation is going now. And I would like to start with kind of a big picture question as we're hopefully emerging from COVID. In what did the COVID pandemic teach us about the structural inequities that affect the lived experience of our patients in Indigenous communities, and how can we take those lessons and apply them forward?
Yeah, and I had the honor of serving on the Biden-Harris Transition COVID Advisory Board with Dr. Jill Jim, who many of you probably know. So it was also really interesting, not just having served in various different IHS and tribal health facilities to see firsthand some of these challenges, but also to hear from her what the Navajo Nation has been dealing with. And she and I continue to talk on a weekly basis what the tribe continues to deal with respect to some of these structural issues over time. I think, well, very early in the pandemic, we saw Indigenous communities in the US hit especially hard. As you all know, some of the highest incidence rates, some of the highest mortality rates from COVID were on reservations in Indigenous communities, especially at the beginning of the pandemic. And many people ask, well, why is that? And I feel like the answers that were given were very, on some level, surface answers. They're only sort of the first step in explanation of saying, well, people live in multi-generational households and, denser households. You have young people, old people all together. And so there's more risk of a, say, younger person who works outside the household, bringing COVID home to an elderly person who's at risk. And a lot of the explanation didn't really go any further, any deeper. And I think the question is, well, why? Why do many Indigenous people live in multi-generational households? Why do they have, another explanation for why COVID was so deadly for Indigenous populations is, oh, well, they all have higher rates of comorbidities and chronic medical illnesses that increases the risk. But that's, again, that's sort of where the conversation often stops and it doesn't go any deeper. And, you know, just as one example, what are some of those structural barriers? Why is it people live in multi-generational households? Why is it there's no running water on in some reservations or on parts of some reservations? Why is it so difficult in some areas to get electricity or sewage or, you know, other basic utilities? And part of this I learned from a young, she's both a ER doctor and a lawyer. Her name is Ernestine Chaco, and she's someone I got to know when I was working in New Mexico. And she taught me about some of this. So she told me about the Marshall Trilogy, which is a series of 3 Supreme Court decisions that really are the basis for much of federal Indian law. And that really impacts how land can be used. So the first of those Supreme Court cases establish what's called the right to occupy. So people have, on a reservation, Indigenous people have a right to occupy the land, but think of it like occupying a car. You have the right to drive the car, you have the right to sit in the car, but you don't have the right to sell the car. You may not have the right to repair the car. And that creates a lot of impediments to, you know, going back to use of land. If you want to build something on that land, if you want to renovate perhaps, or do repairs on a home on that land, if you want to bring water infrastructure, electricity onto the land, because it requires a lot of permissions from the federal government, that creates a lot of red tape and makes it very difficult to undertake some of that development of the land. Some of the other barriers also enshrined in this Marshall Trilogy have to do with how the rights to the land are passed down over generations and what's called fractionation of the rights. And so you have, in the end, you know, over generations, more and more people who have rights to land, which means that if you want to do something with that land, you need to get that many more people on board in agreement to do that, which also creates a barrier to development. So those kinds of barriers are enshrined in Supreme Court decisions. And then you have other laws. So for example, the General Allotment Act, the Dead Indian Act, the Burke Act, there's a number of laws that get passed around the same time in the 1800s, where the idea behind a lot of that was to try to get Indigenous people to assimilate and settle land, farmland, in the way that white settlers did. And as a result of that, and I'm not going to go into all of these details, this gets to be a little bit in the weeds, but as a result of that, you end up with what's called checkerboard patterns, which again will be very familiar to people who are Indigenous. They could teach me about this, but you have a checkerboard pattern of ownership of land. Oklahoma is a great example of this, where some is owned by Indigenous people or people of Indigenous descent, and some is owned by other Americans. And that really dilutes the ability of Indigenous people to dictate the terms of how things function politically in those areas. So I think what was interesting to me, you know, learning these lessons from Ernestine and others, was that so much of this, you know, when we talk about structural violence, when we talk about structural racism, so much of this is embedded in our laws. And these are things that we as physicians, for example, you know, I'm not able to treat our way out of those legal restrictions. And, you know, I think this really speaks to physicians as activists, as advocates, as bearing witness to what some of these problems are, and being there to back up members of the community who are trying to advocate for reform, for changes, to give them more sovereignty, give them the ability to have more control over their lands and their peoples.
So it sounds awfully close to an argument that the features that define a lot of indigenous communities, that put individuals at higher risk for severe illness from COVID, arose not by accident, but from active, largely federal policy.
Yeah, I think that's right. You know, and the federal policy evolves over time. So you start with genocide and extermination. Then you have a focus on relocation. Then you move to assimilation. You know, so it evolves over time. But in all cases, the intent is really to erase Indigenous people in one form or another. And so, you know, in addition to some of these Supreme Court decisions, the laws I've referred to, you know, so you have the forced relocations of Native people, whether that's the Trail of Tears or the Long Walk of the Navajo. What does that do? Well, that disrupts Native food ways in terms of their hunting, their fishing, their gathering, their farming. So if you disrupt their way of life, their way of providing food and so on for themselves, you're putting them in a situation where unfortunately they become dependent. They're forced into this dependency. And so another person I've spoken to about some of these issues is Martin Reinhardt, who's a professor at Northern Michigan University, is also Indigenous. And you know, he educated me about the history of fry bread, for example. What is fry bread? Fry bread is a food of oppression. So it's food that was cooked up out of necessity, out of rations given to people by the US military. And so, yes, this has become part of the culture, but it's also, you know, there's two sides to it in terms of remembering a certain history, but it's also a painful one. And if you look at whether it's fry bread or commodity foods, what are some of the commodity foods? Again, you could educate me better, but you know, anything from mystery meat to high sodium canned vegetables. These are not foods we know as healthy, but they become part of a way of life because that's what's been provided. That's what's been incorporated by necessity into diets. While at the same time, native foods, the ability to farm, the ability, for example, to herd has been taken away. On the Navajo Nation, for example, there's been a long history of sheep herding. The federal government really tried to restrict access to land and grazing because they were worried about overgrazing and what the impact would be on silt deposition in waterways and how that might impact the dams that were then in turn providing electricity to many of the Western cities in the US. You know, but what is the impact of that? So you restrict land on which the Navajo and other tribes could herd their sheep. That restricts their access to a native food, a native way of supporting themselves. You know, so that's another way in which the priorities of the colonizer are impairing what were indigenous ways, healthier ways in many cases. What are other examples? You know, and much of my time has been spent in the Southwest, so that's where I know the history best. But you look at the history of uranium mining. And so there's this period of uranium mining, particularly in the earlier half of the 20th century, but even more recently, where this was seen as patriotic. This was seen as being part of fighting the Cold War. And at the same time, this was also done either on indigenous lands or near indigenous lands. These mining companies took the resources, abandoned the mines, and did not do cleanup. And many of these are Superfund sites or should be Superfund sites. And what is the long-term impact of that? Well, it's not just the miners who might have worked in the mines at the time, it's generations since then, because you haven't had cleanup, and that uranium and other related toxins continue to contaminate the air, to contaminate the water, to contaminate the land. And so as a result, you now see higher rates of cancers among patients. You know, I was really struck by seeing the kinds of cancers that we saw, especially among younger people, that were quite unusual. And clearly that's not quote unquote normal. There's clearly something that's driving that. You know, in other parts of the country, for example, Louisiana, where you also have tribes like the Homa tribe, you have also a lot of oil and gas industry in that area. And that part of the southern Mississippi is in fact known as Cancer Alley, where either Black people or Indigenous people in general are suffering from higher rates of cancer related to oil and gas. So there's just this history of whether it's exploiting people or also very much exploiting the land for the benefit of the federal government or for the benefit of industry, and that having downstream effects on the health of Indigenous peoples.
So it would seem it's no accident that both you and Victor mentioned the importance of foodways, indigenous foodways, and the impact of environmental poisoning. And I'm pretty sure you two didn't plan that out ahead of time. Just to be, so we're all on the same page, we have about 20 minutes for our discussion and questions from the audience. And I'm terrible at this microphone. I'm going to pivot to a question that was raised during our lunch Q&A. Dr. Schnorr, who's the Emergency Department Director, hope I got that name right, at San Carlos Apache Healthcare, asked a question about research and positing the challenge of, I think I'm going to slightly rephrase his question. Sorry, Dan. How do we balance the utility of research versus the danger of extractive research? Victor, again, who's apparently the co-star of this portion, had a really good framing for the answer, is that engage the community in setting the framework for what the questions you want the research to ask. How would you contribute to that conversation?
Yeah, so first of all, I would point you to two people in this field who are both Indigenous, who are really expert on this, and there are many more, but these are just two I have interacted with. Dr. Dakota Lane, who's the Executive Medical Director of the Lummi Tribal Health Clinic, and Crystal Sosi, who's the co-founder and Ethics and Policy Director for the Native Biodata Consortium. And in terms of, planning research, I learned a lot from Dakota about the importance of tribal Indigenous IRBs. I think one, I hadn't really thought about it this way until he had explained it to me, is mainstream, quote unquote, IRBs are really much more focused on the individual. And they don't really think about community impacts. They just think about the impact on the individual who's enrolled in a trial. And especially when you're talking about Indigenous communities, but frankly, I think this should apply to all IRBs, is thinking about not just what is the impact on the individual, but what is the impact on the community of a certain study. And I think that is an area where Indigenous IRBs just do a much better job. They, that they understand that framing. And Dakota was involved in two different clinical trials, one for AstraZeneca, the COVID vaccine from AstraZeneca. That trial actually never took off. And then the second one that the Lummi were involved with was the trial for the Novavax vaccine for COVID, which, by the way, is an excellent vaccine. It just has taken longer to get authorized for use. And it, he explained sort of the differences in how he and the tribe interacted with both of the different companies. And, Novavax was much more transparent, much better about answering questions. AstraZeneca was sort of more, just high above, not really engaging, not being as responsive to questions. So I think that's a great example in their case of what worked well, what didn't, in terms of doing research with a tribe. I think Crystal, what I've learned from her is really the importance of, if you're using samples from people from the Indigenous community, if you're working with people from the community, enrolling them in your studies, you should be doing something that's to benefit their community. And if you're not answering a question that is relevant to them, why are you doing the research in that community? And this is something I've seen not just in this context, but also in the global health context, working in much of sub-Saharan Africa and elsewhere. Why would you study something in that population when it's not to benefit that population? It makes no sense. So I think really having boundaries about that is important.
Okay, thank you. Awkwardly transitioning to another point based in part on conversations, a question from someone in the audience, just an informal question outside, and knowing the panel that's coming on next, speaking on murdered and missing Indigenous women, children, and people. I'm going to be careful with my language here. Because I would like to say things that probably aren't fit for public consumption. So how does history, particularly that of forced or unconsented sterilization, inform our understanding of women's health, reproductive justice in light of Dobbs' decision revoking protection of a woman's right to control her own body?
Yeah, I mean, I think of this as colonization of bodies, whether it's Indigenous bodies or women's bodies, in this case, some of both. It's wanting to control, and whether that is in the form of controlling fertility, and that has evolved over time. In the US, you had forced essentially contraception, birth control among Indigenous communities. You also have a history of forced sterilizations that have been documented, performed within the IHS system, I think up until the 1980s, perhaps. And this was definitely an attempt at population control. You could say it's a form of genocide, really. And then in terms of missing and murdered Indigenous women, this is also an issue of sexual violence that relate to structural legal issues around jurisdiction, who has jurisdiction on tribal land, for example, who has jurisdiction over an Indigenous person on tribal land versus jurisdiction over a non-native person on tribal land. And some of you may be aware of the Violence Against Women Act, which was recently reauthorized. Some of that was expanded to improve or to address some of these jurisdictional questions, so that if a non-native person sexually assaults or otherwise attacks a native woman, that the tribe can then legally pursue with criminal charges that non-native person, but that has not always been the case. And also in VAWA, the Violence Against Women Act is funding now to help establish tribal court systems to be able to do this work. If you don't have a functioning court system, it's very difficult to do this. And establishing that kind of system costs money. So that is something that is slowly changing. But I mean, to give you a sense of the kind of problem that we're talking about with respect to homicide, if you look at homicide or murder victims who are Indigenous, more than 40% of those victims are killed by somebody of another race, which is very striking because for other racial groups, most of the killings that you see are within the same race, as opposed to somebody from another group being the perpetrator. And then among Indigenous women, about half report being the victims of intimate partner violence or sexual violence. And over 95% of their perpetrators are non-native. So non-natives, especially men coming into contact with Indigenous women, can really be a threat to their safety. And part of what's driven that is this idea that they, for a long time, could get off scot-free because there wasn't a way to prosecute them. And so knowing that, it incentivized them to go on reservations. I mean, to use the term, a woman I spoke to about this issue, Lisa Bruner. So she's one of the Indigenous women who worked very hard to include more protections in the Violence Against Women Act, who's been fighting for protection of Indigenous women against this kind of violence. I mean, the way she put it to me is you have white men who think that they can go hunting on tribal land. And I'm hopeful, I think many of us are hopeful that the greater empowerment of tribes and the funding that goes with that will provide at least some protections in the future against these kinds of crimes.
That's tough. So our next panel will dive into that last point in a little bit more detail, or a lot more detail. I think we're getting relatively close, and I hope is someone monitoring the audience for questions either in-house or on Zoom. I'm going to hit a follow-up question and trust my colleagues to tell me when to stop. You mentioned, so just to frame a lot of this conversation informs how we, informs our mindset when we're interacting with patients during a busy emergency department shift. So these are elements of the human being for whom we are providing care on an individual one-to-one basis. However, this also applies to the systems in which we work, the communities, the societies in which we work. And you had mentioned advocacy, allyship, activism. These are all things that are all near and dear to my heart. There are a number of different avenues in which we as physicians or nurses or pharmacists or any of the many other professions represented here can contribute to that conversation. How would you, for those of us who are uncomfortable entering that sphere, how would you advise us to begin moving in that general direction? Something that you have done within your career.
Yeah, I mean, I think I would start by acknowledging your ignorance. I mean, I have tried to educate myself, but I don't pretend to be anywhere near the expert at all to somebody like Victor, who has lived experience, who, I mean, it's something he knows in his bones. But I would say start by acknowledging ignorance about the culture, the history, try to inform yourself. And I think some of that really should be asking people from the community to educate you, and not to do that. You know, again, you don't want to repeat an extractive thing, but trying to, you know, coming at it from a perspective of trying to understand how better to help them in that context of really trying to understand. When I was at Gallup Indian Medical Center, I went out with John Irlew and some of the community health nurses on home visits, trying to really understand what that lived experience was of living in a Hogan. You know, what were our patients' experiences like on the ground? And then just being curious, asking questions. You know, I was also invited, for example, there's a couple different groups. There's the Red Water Pond Road community in Navajo Nation, which is a community that has been advocating for cleanup of these abandoned uranium mines. There's NDOM. There's a few other groups like that where, you know, on different occasions they invited me to come join them and just learn from them. There was the anniversary of the oh, now I'm blanking on the name. Church Rock uranium disaster when I was at GIMC, and I just went with them on their march for the day through the contaminated lands. And, you know, for me, that was a really meaningful experience. It was just them talking about what they had seen, what that had meant for them, commemorating mourning. And so I think to the degree that you can, you're invited to participate in those kinds of community activities, to give back, you know, if you're asked to say present on something, if people ask you in that way at some of these events, you know, to do that. You might also just be asked to listen in and learn. I think those are the places I would start. And then, you know, for example, so there's legislation that's been renewed for uranium miners and some of the benefits for them and other affected communities. Legislation called RECA. I I think helping the advocates on the front lines from community, arming them with some of the information or tools they might need to make their case. So that might be, from a scientific or clinical perspective, being sort of that expert witness that they can call on to help with some of those details. I think making yourself available in that sense can be great. And then I think this was, might have been Victor who was saying this or somebody else just before I joined, is making opportunities available to young Indigenous people, opportunities for them to shadow you in your work, to do internships with you, to do research with you if you're doing research. As we all know, we need our foot in the door to apply for medical school or grad school or, whatever it is. And I think mentoring that next generation is really important, in part because people like Victor, they're the ones that are really going to have the greatest impact in changing things for their communities, leading the way moving forward.
Breaking down barriers. That's what I said before you were on. All right, we're at T minus 4 minutes from conclusion. Questions from the audience or present or virtual? And I would like to just, so she did come for the fry bread. Will you leave my Piccadillys alone?
Hi, my name is Emily Bartlett. I'm a ER doctor at Gallup Indian Medical Center. One question I have is I think that there's a tension between wanting to make change within the system. So I'm a federal employee in the IHS, but then also wanting to be able to advocate for the changes we see that are structural issues outside the hospital, and knowing how to navigate those two worlds while also respecting sort of institutional boundaries is something that I find challenging. I'd be curious to hear if you have any thoughts on that.
Yeah, so somebody who has worked for city government and then also serving on the Biden transition team, you do have certain parameters you have to work within. And so that may prevent you from, say, signing on, like in my current job, if I'm asked to sign on to a letter of, some sort of advocacy letter, I can't. And this is something I've, had to weigh over time, is what am I okay not doing as much as what is it that I want to do? And I think in the end, where I came out was I prefer being on the outside of government myself, because I want those freedoms to speak out, at least on certain things. Whereas when you're in government, you really do have to toe the line. You have to, I don't want to say be a team player, but you can't betray your team, so to speak, right? And so if something is government policy, you kind of have to adhere to that. And so I think everybody has to figure out, am I somebody who wants to change things from within the system or from without? There's not a right answer. I think it's more of a personality question. You need both. I think it's more just, what are you better at and what are you comfortable with? But as somebody who is working for the federal government, you're not going to be able to speak publicly about some of these things. You're not going to be able to criticize publicly. You're probably not going to be able to go testify before Congress as a witness for a tribe, so to speak. You would be, if you go testify before Congress, it would be because you're called on as a representative of IHS. And so there are limitations. But I think in the background, there's a lot that you can do in terms of educating, empowering, being a resource to people. And even if it's just about engaging in community activities where you're able to learn and bring that to bear on how you care for patients, how you design programs at the hospital where you work, I think that's still really valuable.
Hello, my name is Yakaise Gorman. I work in academics, building curriculum around behavioral health, and most currently looking at different ways of educating our Indigenous people and being in the medical field. And so a lot of my work, as you were talking about
was how do we help our students understand their opportunities within these fields? And one of the things that I thought about as a student going to school at Northwest Indian College was that my college was the first Native American student to be able to receive a award at the SACNAS conference, and that was myself. And one of the things that I thought was, why aren't there more opportunities for Indigenous young people to feel like they belong there? And one of the things that I always look back on is that colonization, that piece where there was a lot of relocation, there was a lot of things that happened that kind of displaced them from being able to feel like they fit. And going back into my journey as an Indigenous woman, growing up, speaking my language as a Diné person, and then going into kindergarten and having to assimilate to speaking English. And a lot of times I had a lot of challenges when it came to making sentences, which resulted in me taking speech therapy. And so when we look at, how these instructions are happening or how education is happening, we have to look at the impacts of how are we being able to educate Indigenous people? How are we creating avenues between them and what you all do here? All of you have been through education. And I think an important piece is that the history that we know as Indigenous people is very different from the history that you've learned in public school. And I think acknowledging that type of demographic is very important. So I guess in my question is that, what are you going to do to educate yourselves to be able to understand our people and the things that we've had to endure to be able to live in this colonized world?
So is your question for the audience?
Anyone, or it can be for you, yeah.
You got first.
I mean, I'll tell you what I've done to educate myself. So, and this was really striking to me, is back in 2016. So it was right around the time of the that presidential election. There's also a series of papers that started to come out in JAMA from the Institute for Health Metrics and Evaluation, IHME. You may be familiar with them because they did a lot of the COVID modeling that you might have seen on TV and elsewhere during the pandemic. But their original work was really focused on first global burden of disease, looking at how much different diseases caused, or say infections or other conditions caused disease and death in various parts of the world. And then more recently, they've turned to doing similar analyses here in the US. And the first of those papers to come out was just focused on mortality. It's pretty straightforward by county in the US. And it really hit me as I was looking at the maps, what were the sickest, deadliest places in the US? Almost all were Indian reservations, by far. And, as somebody who up until that point had only, well, not only, but much of my work had been outside the country, again, largely in Africa. And I found myself asking myself, wow, I haven't been to these parts of the US. I don't really understand what's going on there. And so after that, I decided, you know what, I'm going to go spend some time there because that's how I'm going to learn. And so that's how I got to know Topher, is I signed up for locum tenens work, so contract work in different parts of the country, different reservations, different IHS and tribal health facilities. And that's how I learned. And, talking to people like Victor, like Ernestine Chaco, like, many other folks who are in this field who are experts, learning from them, and the fact is this kind of learning is very difficult to do from journals and books and the like. A lot of that history is oral history, oral information. And that's what I did.
So to sum up, showing up, breaking down barriers and listening is how we start. It's a lot longer answer than that for me personally as well. Okay, we are out of time, but let's go, let's have it.
Hi, my name's Tony Watchman. We're here, my wife and I are here, my wife Sharon. Question, you mentioned several different things highlighted. starting at the beginning with the Marshall Trilogy, moving along into checkerboard, sovereignty, and then on into more or less the environment of where a lot of reservations are taking place. And some of those things all having impact on how Native populations have come to evolve. As with any case, how do you take over a people? You affect their food source, which is basically what happened. The BIA stepped in and said, okay, you guys are no longer going to have that much of a herd. So they took the herd away. And then along with assimilation, they took the plants and vegetation away, severely affecting those types of areas. There's several things that need to be brought into light. BIA will never work with us in that sense. Also, BIA and IHS don't communicate as far as what we can see from here at the root. BIA, Bureau of Indian Affairs, is directly more towards its justice system and how it takes care of the land and the education on that side of it. IHS is healthcare, but somewhere along that line, there needs to be some type of communication at that level, at the higher echelon, if you would put it, for us, for what we're talking about, for that change to happen. But it's been over 100 years, we still haven't seen it. We're still, in that sense, we're still in the dark ages. Out here, we're still the third world country, as a lot of people refer to us. Because of that, the education portion of how do we move forward with how do we educate our people? How do we make sure we provide the proper health care for our people? How do we make sure that our people are aware of what's happening and what's taking place? Fortunately, we had some educated people for Navajo to explain how COVID-19 work and to explain how the different types of diseases and infectious diseases that coming into play in our area. We have those types of people to where we can explain that to them. Unfortunately, for other tribes like Victor's tribe, they had to struggle with that, and they had to find a way to get through that. Which brings me to provider education, and we've started that with at GIMC to where, how do we introduce ourselves to our Native people? How do we get across to say, hello, my name is so-and-so, these are my clans, I'm here to help you, rather than just walk in there and say, you know, hi, I'm Dr. Watchman, I'm here to help you, what can I do for you and what's wrong with you? There's a different type of traditional people. Native people are, as I think we're all aware of, we are visual people, and we're also people that like handshakes and most parts. And not everybody understands that. There's a lot of things that need to be understood when we talk to people as far as other nationalities, other tribes, and how they perceive you as non-natives. So because of that, there's always the side of fear. A lot of our children have grown up, and Generation X, where we're from, we were taught fear in school. A lot of our older people were taught fear in school because of the boarding school system. Part of the assimilation is you will not speak your language, your hair will be cut, and you will be dressed as a non-native. That portion was taken away. And the duality of man, where kill the Indian, save the man is still very much alive in our area. So because of that, some of our children and some of our people at my age even, and I'm going to use my wife as an example. She understands Navajo, but she can't speak Navajo for the most part of it. I'm not saying anything negative about her. She's doing her best, but you know, this is what we have to endure. And she struggles with that, even communicating with her own people. And it makes it hard for her because her own people now look at her like, well, what's wrong with you? Why don't you speak your own language? Which is kind of demeaning, and it's hard. So because of that, it goes back to what I started to say earlier, provider education. Teach our providers, teach your providers. We would be more than happy to sit with you and say, okay, this is where we're going to start. This is what we're going to do. And we tried it. We tried with doing an echo not too long ago at GIMC. And I was fortunate to be part of that. So with that being said, thank you for your time. Thank you for what you're doing. And it was a pleasure to meet everyone. And thank you for listening to me.
Thank you.
That was a great wrap up. Thank you.
Yeah.
Any final words, Dr. Gounder?
I mean, I completely agree with what was just said. And I worked at GIMC actually on a couple occasions pre-pandemic. We had some sort of orientation that we had to, that we went through about, you know, cultural competence and so on. But I think you can't just do a one-off training. And I think that has to be an ongoing, excuse me, ongoing process of education and learning. You don't learn a culture in a day. So I would just say, I think these efforts need to be consistent, continued, sustained, to really have the desired impact.
Break down barriers, build relationships. Thank you very much for your time. Thanks, Dr. Gounder.
Oh, thank you. And thank you for inviting me.
Absolutely. Now turn it over to my colleague, Dr. Jeannie Ringelberg, for the next panel.
Excellence in clinical care is something that we want to accomplish regardless of which site any of us are working in. And I think that includes excellence in clinical care for populations that are particularly vulnerable, as well as populations that may be in locations that are hard to reach. And so we have two amazing presentations coming up, one which is focused on the community health aid program in Alaska, the other on a program for healthcare for the homeless. And so I'm absolutely delighted to introduce our next speakers who have flown in from Alaska. We have Dr. Michelle Hensel and Jessie Judy. Dr. Hensel is a board certified family medicine physician. She was born and raised in Alaska and did her medical training at the University of Washington in Seattle, where I also did my residency training, so nice connection. She currently serves as medical director for the Alaska Native Tribal Health Consortium's Community Health Aid Program. And prior to her current role, she also worked clinically in rural clinics, hospitals, and emergency rooms in Alaska. She's joined by her colleague, Jessie Judy, who's a family medicine practitioner who has been working in Alaska for 6 years and has worked as a community health program instructor, both in Alaska and rural sites, including Bethel in Alaska. So with that, take it away. Thank you so much.
Thank you, Emily, for that introduction. And we really feel honored and privileged to be invited to speak here to talk to you all about the Community Health Aid Program in Alaska. We also really enjoy the sunshine and this beautiful place. And thank you for spending your Friday afternoon here. So we're both very proud to talk about the health aid program in Alaska. We're going to talk a little bit about the history of the program, how it got started, the function, and how our community health aides practice, and also talk a little bit about the future of the program and national expansion. We are going to be running a small group discussion later on today as well. So I just want to start by talking a little bit about Alaska. For those of you who are not familiar, this is a map of the traditional territories of the Alaska Native cultures. Traditionally, the Inupiaq were up in northern Alaska. the Yupik in southwestern Alaska and along the coast. The Alutiiq population was along the Aleutian chain. The Athabascan population was in interior Alaska, and the Haida Tlingit are in southeast Alaska. But of note is there are 228 federally recognized tribes in Alaska. So as you know, it's the largest state. There's over 665,000 miles of land in Alaska, of which only 20% is accessible by road. The demographics, we've got about 20% of the population in Alaska is Alaska Native or American Indian. That's about 148,000 people, just over that amount. It's been an increase in population of about 5% in the decade 2010 through 2020. And the largest population increase has been in the 65 to 79-year-old age group since the year 2015. Over 1 out of 3 people who use our tribal health system are under the age of 20, so a large pediatric population. And recently there has been a significant change in the rural versus urban living. It's about a 50-50 split now. It used to be a much larger percentage that lived in rural Alaska in the villages. And also just a couple slides to show the disease and illness burden in Alaska that's unique to us. On the left is the top 5 leading causes of death in the Alaska Native people as compared to US all races on the right. The top killer is cancer. The most common cause is lung, followed by colorectal, and then breast cancer. So the second cause of death, heart disease. Unintentional injury is third. The 2 most common causes there are poisoning and drowning. The 4th common cause, unfortunately, is suicide, and 5th is COPD. The average life expectancy of Alaska Natives is just over 70 years, and that has been increasing since the 1980s, although this data does not include anything related to COVID. The top 10 causes of hospitalization for the fiscal year 2019 are listed there. Number 1 is obstetric care for delivery, and then several others diagnoses in the top 10 are related to prenatal complications and obstetric care. There's sepsis at number 2, alcohol-related disorders, mood disorders, hypertension, hypertension complicating pregnancy, pneumonia, skin and soft tissue infections, which are quite common, and then schizophrenia and other psychotic disorders at 9, and then suicide attempts at 10. The 2 most common causes of injury hospitalization are falls and assaults after suicide. A couple other things worth mentioning is that the prevalence of diagnosed diabetes among Alaska Natives is 6.3%. Over half of adults have experienced tooth loss due to decay or gum disease. And our chlamydia and gonorrhea rates among Alaska Natives are 3 times the rate of non-Native Alaskans. And overall, the entire population, non-Natives and Native Alaskans in the state were number 1 in the country for chlamydia infections. And here's some of our beautiful salmon drying in the midnight sun. We celebrated 50 years a few years ago, and that was quite a celebration for us in Alaska. So the program has been around since 1968 when it was federally certified, although there was certainly some history that led up to that time. Here's a nice photograph of the first graduating class of health aides in 1968. And standing with them is Dr. Walter Johnson. He recently passed away in 2015. He's considered by many to be the father of the community health aid program. He came to Alaska as a young man in the 1940s. He left for his medical training, but returned and worked in Bethel. And he also served as a TB control officer. And up until 1980, when he retired, he served as the clinical director and medical director of the CHAP program. And so now we're just going to play just a 2-minute video that's from the University of Alaska Fairbanks archives, which shows a health aide. In 1950s, which shows a health aide in Allakaket, Bertha Moses, talking on the radio, the 2A radio with a physician in Tanana.
6. Seeing the value of the aid program model, Dr. Walter Johnson, a physician working in Bethel, sent a letter to the area medical director expressing the need for trained medical aides in the villages. Dr. Johnson's letter prompted a unified effort to develop a program for training community health aides. It took several years, but the program was begun in 1964. The Community Health Aid Program became a realistic way to care for people's medical needs, as the development of satellite radio during that time allowed for more regular communication with doctors and other medical providers. Listen to this early radio call from the 1970s.
But for Native people, having the use of a satellite means more than just experiments. It means, for one thing, being able to talk to a doctor every day.
Canada. I have June age 2 years old, and her mother thinks she has straining in her left ear, and her ear smells, and I checked her ear.
I'm Bertha Moses, the health aide for Khaki. I've been using the satellite radio 1 year now, and we can talk to the doctor every day.
Doctor Call is sponsored by the National Library of Medicine. For the first time, Native health aides in a dozen small villages can obtain daily medical advice.
Roger Alakakit, how has she been treated in the past, and for what periods of time with what antibiotics? Over.
Alakakit to Canada. She was put on ampicillin 10 days.
Bob Crooks, one of the 2 doctors at Tananoff, feels the satellite has affected the hospital as well as the villages.
The health aid system and radio call is an excellent system and just needs to be built on. We're seeing more cases that do need evaluations that we can offer in the hospital, x-ray, laboratory work, and a lot of minor problems are picked up in a village early.
So I love that video. I think it really captures the essence and the history of our program. So the problem that they were trying to solve many years ago, which are still very relevant today, is geography. It's a very large state with a lot of diverse climates and geography. A lot of the villages are small, so sometimes 100 people or less. There's harsh and unpredictable weather, which is an issue for travel, which is also very expensive. And we continue to this day to have difficulty retaining and recruiting trained healthcare providers. So this is what led to the initial problem solving, which led to the program. And this slide just shows all the red dots are villages, most of them staffed by community health aides or practitioners. And just an overlay of that, the green is the road system in Alaska. So as you can see, most of the state is not accessible by road. So the solution that they came up with years ago was to train the local people from their village and from their community to provide medical care. They were referred to and still are today as the eyes and ears of the physician. They provide all types of care in their village: emergency care, acute care, chronic and preventive care. On the left is a photo of the VHF two-way radio that are still in use today for village communication. They're not used for healthcare anymore, but villages use them to talk to each other. And even though we use EHR, and the internet and the telephone to communicate between physicians and health aides, we still often refer to it as RMT, or radio medical traffic. So how did all this start? In the 50s, chemotherapy aides, which is what they were called back then, were volunteers that were recruited from their community to provide directly observed therapy for patients that suffered from tuberculosis. In the 1960s, there was more formal training and pilot programs. It was funded in 1968 and formally recognized by Congress. They initially funded 185 positions in 157 villages. In 1976, the first community health aid manual was published, and that was based off the book Where There Is No Doctor, which I'm sure many of you have heard. In 1992, when Congress amended the Indian Healthcare Improvement Act, it mandated the IHS to create and maintain a federal community health aid certification board. And so that got going in 1998, and that formalized the process for maintaining the training, the curriculum, practice, standards, and procedures. We're not going to talk too much about this today, but the dental health aid program got started in 2004 in Alaska, and the behavioral health aid program got started in 2009. The day-to-day operations of the health aid program are really carried out through the tribes and the individual tribal health organization and not their certification board. And so now I'm going to hand it over to Jesse, who's going to talk a little bit more about the function and the training of our community health aides.
So that picture is actually my husband. He did not want his face shown to anybody. We lived in Bethel for 4.5 years, and he was responsible for the care of, I think it was about 8 villages, and this is in Tuxuk Bay, which is on the western coast of Alaska, right on the Bering Sea, and that's their ambulance that you could hook up to a snow machine in the winter and a 4-wheeler in the summer. So, and that is a pretty sophisticated one. Some people just like throw someone on the back of their 4-wheeler and drive them in, but that was I didn't get to go in it or anything. I thought it'd be really cool too, but I was not able to. So we have community health aides and community health practitioners. There's a little bit of a difference, and I'll talk about that in a little bit. But they are estimated to conduct 50% of the ambulatory visits in the state of Alaska. And that's a lot of visits. Like Michelle said, emergency care, acute care. In the event that a woman delivers in the village, the health aide is called on to deliver the baby. And women in Alaska actually have a high rate of postpartum hemorrhage. So we kind of focus on what you need to do after the baby comes out. There is preventative care. Our training is really based on skills. It's not a lot of anatomy and physiology and medical, all these processes and stuff. It's just based on, can you do this task? They don't ever diagnose anything. They make what we call an assessment. Their assessment might be strep throat, which is a medical diagnosis, but they don't diagnose. And they always work under the license or the medical supervision of a licensed physician. And that physician can delegate tasks to a nurse practitioner like myself or a physician assistant. So when health aides call in their RMT, it may be an NP or a PA on the other end that gives them their orders on what they're supposed to do. They respond to the trauma and the death and in their villages, and it's it's different. You know, in emergency medicine, right? I used to work in an ER, you know, you treat people and there's some very bad and awful things that you experience, but it's not your mother. It's not your nephew, you know, and our health aides do CPR on their best friends, and they respond to the suicides in the villages. And it's a it's a very hard job, and it's a difficult task. And the fact that they go out there every day and they come back every day to the clinic is pretty astounding. Just imagine 16 weeks of training when you're all done and you're dropped in a remote village with no road, and you have a book to tell you what to do. You know, there's no crash cart, you don't have x-ray. It's challenging, it's really difficult. So we should have brought health aides with us, really, we should have. This is a photo of Kasigluk, that is the lagoon. There are 31 Alaska Native communities that do not have running water or flushing toilets in their house. And this is what they deal with every day. The lagoons sometimes turn into dumps. And you are all aware, right? There's the connection between poor water and sanitation and poor health, right? The crisis in Jackson, Mississippi, they don't have water, but that's a reality for a lot of people in Alaska every day. Sorry, lost my train of thought. Top 10 health aid visits that they see, that list, most of them are acute care problems, pharyngitis, otitis media, bronchitis, skin infections, but hypertension, chronic lung disease, and arthritis and joint pain, they are able to see patients for chronic care visits. They don't adjust meds, they don't order labs, but they can see the patient who does need a refill on their hypertensive medication, report that, and then the provider can order it and it can be sent out to the patient, and they don't have to travel into the regional hub to actually see their physician. Again, expanding on the clinical skills, the CHAM it out. What is in your CHAM? If they have a question on how to do something, what does the CHAM say? We as instructors use it all the time, and they have to follow it. That gives them their scope of practice, but they do take a history. There's a designated set of questions they ask. They are told to examine these parts of the body for this particular problem. They perform labs when needed. There are some labs they can do prior to calling or speaking to a provider. Other labs, they need the provider to tell them, go ahead and do that. Like they can do a strep test on someone who has a sore throat. They can get a urine on someone who has urinary complaints without needing to talk to a provider first. They follow plans and they report. Patient education is always a big thing that we focus on too, and they administer their medicines. Now, typically when health aides report, they are not reporting to emergency physicians. They're reporting to, usually it's a primary provider assigned to RMT for the day. Smaller tribal health organizations, it might be one person that they talk to. The larger health organizations, like when I was in Bethel, 170 health aides, like over 250 RMTs a day. One person can't handle that. So there were several people that did that. But it's usually not emergency physicians unless it's an actual emergency. And then their CHAM, they're following their emergency part of the CHAM, and then they call the ER doc. They learn to start IVs. For fluids only, they never give anything, any medicines intravenously. Injections, we're pushing them to do a lot of immunization visits. Emergency deliveries only when needed. Wound care, lack of running water, sanitation, a lot of skin infections. There's a lot of abscesses, and they learn how to IND those. They can suture. Point of care testing, those 5 tests that are listed up there, we make sure we teach. Those are in our curriculum. Some villages have expanded to rapid flu, point of care testing, hemoglobin A1C, and there's now an initiative for point of care hepatitis C testing to kind of gather that population that is not always tested for hepatitis C. And then TB skin tests. Started with the TB pandemic, and TB is still out there, so they will place TB skin tests and they will read those. Initially, health aides were selected by their tribe. Their tribe would come to them and they would say, I think you would make a really good health aide. Do you want to go to training? And they would say, yeah, sure. Now, most of them are just hired directly by the tribal health organization. They see an opening online, and then they apply. They're hired and then they're trained. They don't really come with any training, with the exception that they must complete ETT training. I think ETT is fairly unique to Alaska. I could be wrong. So it's emergency trauma technician, kind of like a precursor to EMT, but they have to have that course and they have to stay certified in order to work as a health aide. Many go on and become EMT 1, 2, or 3s, but ETT is definitely a requirement. A pre-session kind of tells them what they're going to get involved with as a health aide. But the minimum requirement for education is a high school diploma or a GED and a minimum 6th grade reading and math level. So 6th grade reading and math level, and yet we're asking them to save lives and deliver babies. So there's kind of a contrast there, but they do an excellent job. They do an excellent job. Briefly, so we have 4 sessions of training. Students come in as a session 1 and they learn 5 body systems. I'm not sure why they picked those 5. I'm guessing because eye problems and respiratory problems and digestive problems are pretty high on the list for problems in rural Alaska. But they learn to start IVs, they learn how to do the labs, they learn their wound care in session 1. They go home, they see 20 patients, and they can be certified. So the certification has become a really big deal because in 2017, Medicaid in Alaska agreed to reimburse all health aid visits. Prior to that, they only reimbursed at session 3 and 4. So 50% of the ambulatory visits, and each visit is worth $444.04. So that's a lot of revenue that health aides can generate for their tribal health organizations. After session 1, they go on to session 2, they get the rest of the body systems, and then they also get a refresher on IVs and wound care. And we also start talking about mental health problems in session 2. Dental is also thrown in. They have a dental class on how to care for teeth in session 2. Session 3 is where we focus on maternal child health. Again, emergency delivery, well child checks, prenatal care. They get their prenatal care. They'll do glucose tolerance tests in the village, and just to get women in so they have a healthy pregnancy. Session 4, another review of the body systems. We focus on chronic care. We focus on preventative care, injury prevention, again, IV therapy, wound care, the stuff that they do every day. When they're done with session 4 and they've worked and they're certified, they move on to the P level, the CHP, which is the terminal degree for a community health aide. It's a 30-hour preceptorship with 15 patients, competency and skills, and then they get to be a CHP. And that is a great moment for all the health aides. They want to get that P status. They're very proud of that P status. After that, there isn't any more training. They also really like to progress through training because there's a financial incentive for them. A trainee comes in making about $20 an hour. By the time they get to be a P, they could, depending on their organization, make up to $45 an hour. You know, minimum wage is 15 bucks an hour, I think now in the country, but $20 an hour seems like a lot, but when milk's $14 a gallon and gas is $10 a gallon, 20 bucks doesn't really go very far. They also get university credit. This actually started with the University of Alaska Fairbanks, I think probably in the 90s. They've transitioned to Alaska Pacific University. Doesn't matter the university, but they get credit. So they get 8 hours for all of their 4 training sessions and then 2 hours for their community or the CHP status. So when they're done, they got 34 credits towards a degree. There's a graduation ceremony. In fact, those students in the upper left-hand corner. That was a graduation in Bethel. I think it was probably about 2018. They go through the graduation ceremony with the rest of the university students when they earn their certificate in community health, which is free for them. The tribal health organization picks up the cost of those 34 credits, which is pretty amazing. If they want to go on, APU offers an associate applied science. They just need to get the extra 26 credits. And since I talked about the health aides in the upper left-hand corner, the lower left-hand corner is Flora. She's a health aide that's been working out in Point Lay, which is up northern Alaska near Utiavik or Barrow for many years. 4 training centers in our state, Anchorage. In Anchorage, we take students from all over the state. The training centers in Bethel, Nome, and Fairbanks typically only train the students in their region because there's such a need. But in the event that they have an opening, somebody from Bethel could go to training in Nome, or somebody from someplace else could go to training there. We use the same curriculum. We follow the CHAM. We use the same standards, and we have pretty much tried to standardize the training across the board and across the state. Distance learning was started in 2015 as a pilot program for our session 4. Most of the health aides are women. There are men. I would say probably 98% are Alaska Native. There's a few people that are not, but most of them are. A lot of the people are single moms or single dads, and they have usually more than one child. So when they come into training, we're asking them to be away from their family for 4 weeks at a time. And that is very, very hard for a lot of them. They don't have childcare, or something happens to the person providing care for their child, and they have to leave training to go take care of their kid. So blended training was started. So if you go through blended session 4, you do most of your training online. That is if you have appropriate bandwidth in your village. And then you only have to go to a training center for 2 weeks. But it's not 2 weeks at a time. It's only 1 week and then it's another week. So it's less time away from home. The blended 1-2 training, it's a lot longer. It's 24 weeks, but when they're done with that training, they're actually a session 2 health aide. So they kind of progress through a little bit quicker. And then the 6 weeks at training centers are in 2-week increments. The whole process should take about 2 years. Session 1, about 3-4 months, and then go to session 2, and then they come back. But it doesn't always work that way. Some people, it'll take them 10 years to go from session 1 to a community health practitioner for a lot of different reasons. A lot of health aides, the trauma and the stress that they deal with, they quit and then they come back and they start over. You don't have to start over at session 1, but it depends on the length of time you were away. So it does take them quite a long time to do that. And for providers who are on the other end of the phone or the computer for the health aide, it's really important for them to know what level that health aide is. Because when that health aide calls you, I have an emergency, I'm a session 1 health aide. Okay, they're going to need to be walked through a little bit more than a CHP who calls you. She's like, yeah, doc, this person's really sick. And you know that because that health aide has been working a long time, you trust them and they have the experience and they really do know, what they're talking about. So the providers, and in Alaska, like a lot of other places, IHS and wherever else, right? It's a revolving door of providers. You get new people that come in and they just don't understand how it works. And sometimes health aides will say, yeah, that new doctor, he didn't believe me. And now the patient's medevaced in the ICU in Anchorage. So they want to be heard, and they want to know that what they say and what they do is actually right a lot of the times. This is the ambulance on in Macoriac, which is the only village on Nunavik Island, which is also one of my husband's villages, or was. But this one you can actually drive. You don't have to hook it up to a snow machine or a four-wheeler.
Okay, so you've seen this slide before. This just has the 4 training centers in blue there. So this talks about the programs throughout the state. So we mentioned each individual tribal health organization or corporation runs their own health aid program if they choose to. There's 25 programs in the state right now that service 148 rural clinics. The programs vary in size. It can be from 1 or 2 health aides in an organization up to 172 positions, as Jesse mentioned, in the Bethel region. There's currently 352 certified CHAP statewide, although there is 599 positions. So there's a fair amount of openings, and we really saw that take a hit when COVID hit. And just to mention, so there's 599 positions. That's up from the original 185 when the program was initiated in 1968. There is 90 behavioral health aides certified and 45 dental health aides currently certified in the state of Alaska. This is what we refer to as the hub and spoke pattern of care in Alaska, which we really try to keep as close to home as possible. And the health aides are what are the backbone of this system. They're what allows healthcare to happen as close to home as possible. So care begins in the village. If the region is highly populated, they may have a sub-regional clinic. If not, the patients can be referred in from the village to the regional hub clinic or hospital. And the tertiary referral center is the Alaska Native Medical Center in Southeast or in South Central Alaska in Anchorage, where Jesse and I, our office is, where we work there. And this just nicely demonstrates the large area that Alaska is. If you superimposed it on the 48 continuous states, you'd see it extends from almost the northern border of Minnesota, all the way east to Savannah, Georgia, and then all the way west to Sacramento. So you can see patients are sometimes having to travel. Like if you were out on the Aleutians on the island of Adak, you would travel maybe 800 to 1,000 miles for tertiary care. And this is a nice photo of Gamble in winter. So this is an oversimplified summary of how a health aide is able to practice with their limited training. So they must be employed by a tribal health organization. They must be certified by a licensed physician who can designate another provider to do the day-to-day supervision or RMT with them. And they have to follow the manual, like we mentioned. We do operate a website that may be of interest to you, www.akchap.org, which has a lot of useful information about the health aid program in Alaska, although it is currently a work in progress. So I want to talk a little bit more about the CHAM. That's the manual that was first published in 1976 as a paper book that was revised 3 subsequent times, most recently updated in 2006 on the lower right there. It became an electronic resource in 2014, which allows it to be revised and edited and updated much easier. And that's what I spend a lot of my time on, is helping with the CHAM revision. So this is a way that we can align with the current standard of care. It provides a framework for the health aides all over the state to practice in one way. It leads them through history questions for specific problems and a specific exam depending on what their problem is. And again, they don't diagnose. I would encourage anyone that does work with health aides, either now or in the future, to have access to that electronic manual if the health aides are following that in their region. But basically, it's what gives them the ability to practice out on their own of course, with the physician oversight. So it's their guide for every patient encounter. There's specific sections depending on what the problem is. They follow a specific plan, which usually the first step in the plan is reporting to the referral provider. There's an online resource, which we refer to as the eCham, and then there's an iPad app version, which is the iCham. It's just on iPads though. It doesn't yet work on a phone, on an iPhone. There are personalization features that each tribal health organization could, where each individual can actually make edits in there for them, but there's also regional notes that each of the organizations can tailor it to what their health aides might do a little differently from a different region in the state. So here's a screenshot of what we call the launch page in our manual. So it's where they start for every patient that comes in. We've had to put some alerts in there for COVID-19 and infectious disease screening. But basically, if they think it's an emergency, they're bumped out right away into the emergency chapter, or they might just start there if they're an experienced health aide. If it is an emergency and they can follow that hyperlink, it's going to bring them to a place where they're going to start with every emergency patient. And I just want to point out that very nice sentence that we remind our students of regularly: take a deep breath, do the best you can, follow the steps. And so that's kind of the first thing they would see, and then they'd be kind of guided through each patient. Here is a scene size up. This is designed to be a resource that they can take with them outside the clinic because they do respond to emergencies in their community. It leads them through first deciding, is the scene safe? What's going on? It reminds them right away to ask for help. And as you can see, there's a lot of words that they're kind of reading through here. So it's really nice if they have a helper who can read through the CHAM while someone's actually providing the care. And then it kind of bumps them out to either trauma or medical emergency care. So they are able to do certain procedures without talking to a physician first, such as CPR, starting oxygen. There's even a couple medicines they can give if patients meet a certain criteria before they can speak to a doctor. But eventually they'll go through a history and exam and they'll get to a plan. And here's an example of the plan for shock. Again, the first step in that plan is reporting if they haven't done that already. But then it talks about additional steps they can do. Sometimes they have to wait to get a physician on the phone. So there's other things they might be able to start doing while they're waiting. We often outline special care depending on what the problem is, which covers kind of very specific things for that assessment. And so that's just an example of an emergency plan. If it's not an emergency, they're guided through a standard set of questions for every patient after they complete the infectious disease screening, which we put into the CHAM in 2020. But it's a very kind of broad, like what's your problem? When did it start? Is there pain? Does it come and go? Just some general questions. And after they complete the general questionnaire, and they'll do kind of a past history in there too. I don't show that here, but they'll go through, meds, past surgical history, past hospitalizations, are their immunizations up to date? And do they have any high risk conditions? And we kind of spell that out for them too, what makes a patient high risk. So if they decide if a patient's coming in with a sore throat, they'll go through all of that kind of general stuff first and then decide what section of the CHAM they're going to go to next. And here's an example of the respiratory chapter. So if they are brought into the respiratory illness section, they'll be reminded about, should they be here? Is this the right section for them? And so they'll begin here if a patient has a stuffy or runny nose, a sinus problem, a sore throat. But there'll also be reminders usually above that of when you shouldn't be here, so that it can bring them out to the section that they should be in. For example, if a patient has chest pain, or if it's a kid who's having trouble breathing, it'll bring them to a more appropriate section. So within the respiratory section, they'll ask specific history questions related to that problem, and then also complete the exam. Once they complete the exam, they're encouraged to make their own assessment. So they'll come to and what we call assessment charts, which, and sometimes there aren't charts because there may only be one thing that they can end up with, but we encourage them to kind of use their skills to look at what history and what exam kind of matches the the problem the most. They don't always have to do that, especially earlier on in their training, but we really want them to be empowered to act upon, the skills that they've learned. And so here's just a couple examples of the assessments that they might come to. And here is actually another plan for like strep throat. We number all of these assessments too. And then we outline, okay, again, the first step is reporting. You would report more urgently if they had these specific symptoms to go along with it. Jesse's going to talk in a little bit about standing orders. There are some assessments they can obtain standing orders for, but we always list the conditions that even if they have a standing order, you're still going to have to call in if there's certain criteria that are met. They cannot prescribe or dispense medicines without a doctor's order, even for medicines that are over the counter when they're in the context of a visit with the CHAM. And we try to keep up with standard of care. We have great resources at ANMC and Anchorage that help us with infectious disease and other areas of expertise to help us keep this updated, but we'll often list a couple choices of medicines that are usually chosen for that specific problem, keeping in mind things like allergies and things like that. And then we always have recheck information in the CHAM about, if they weren't specifically told by the provider, and hopefully they would have been, but we outline that pretty well for them of what information they should give to the patient regarding patient education and when they should come back. And we also guide them through a recheck visit for their problems when they come back. Here is a couple pictures of some health aides up in the villages of Kobuk and Shungnak. And those were villages that I was assigned to about 23 years ago when I first finished my training and went up to the Arctic. And we have Beatty and Agnes on the left in Kobuk, and we have Rosie and Lottie on the right here in Shungnak. And since I worked there, they both have brand new clinics with excellent running water and sanitation. And when I would go out there for the weeks that I had to spend, I would have to bring my backpacking water filter to filter the water that actually came out of the faucet in the clinic. I hand it back to Jesse.
And we're running out of time, but briefly, standing orders are allowed after session 2 and only for certain assessments. There are a few assessments like ear infection and strep throat where that health aide can actually dispense antibiotics without notifying the provider, but only the ones that are in the CHAM, only the doses that are in the CHAM, and only if the patient does not have any of the things listed that would tell them report if these things are here. Giving standing orders is completely at the discretion of the tribal health organization. Some tribal health organizations don't let anybody have standing orders. Others give them after session 2. Some wait till session 4. It just is completely dependent. And the training center usually provides some guidance to the tribal health organization saying, yeah, this health aide probably can have standing orders, or you might want to wait. They have to take a test to make sure that they can follow the CHAM and they know when they need to report and when they don't. There are skills and basic training that we don't teach. Pap smears, Foley catheter insertion. We actually don't teach IOs, unfortunately. But if a tribal health organization wants their health aides to perform those skills, they can. They just need to have documentation of how the health aides trained, who's training them, and how they're going to make sure they maintain competency. Website, like Michelle said, that's our akchap.org website. It is a work in progress. So where are we heading? Michelle and I are not experts in this field at all. We know Alaska Health Aid Program, and many of you out there probably know more about what's going on in your regions than we do. So that's the disclaimer. But in 2016, the IHS wrote a draft policy statement creating a national IHS community health aid program. From the draft policy, they were exploring necessary steps to create national CHAP, including a national certification board. The IHS was supportive of and committed to the expansion of community health aides and community health practitioners throughout Indian country. It was their goal to use community health aides to the fullest extent permissible in IHS and tribally run hospitals and clinics. The health aides in Alaska are true proven partners in health. They are an asset. They are tremendous. And, you can't have a doctor in a village of 50 people, but you can have a health aide that knows the people and knows what's going on and knows the problems that happen there. And so the IHS is committed to seeing them expand throughout Alaska, which is very exciting. The Indian Healthcare Improvement Act, IHS must establish a policy that creates the program, which they did with the draft policy. And the state state authorization is required for the health aides. So essentially they need to authorize health aides to practice and they need to put it in their state legislature. Now, I am a little bit familiar that the fact that the Portland area has, I believe, their dental health aid program and their behavioral health aid program. I believe they have standards and a curriculum. The last I heard, they were waiting on the IHS to approve their standards so they could start rolling out their program. The community health aid program was lagging a little bit in the Portland area. I don't know why, but it's a huge endeavor. You know, you got dental, you got behavioral, then you got everything else. And that everything else does take a lot to coordinate. And I don't know, like I said, I'm not really sure what's going on in other parts of the country. IHS website in relation to the community health aid program expansion. And then there is a tribal advisory group that was started in 2018 with 14 members from 12 different regions. And then they had the a tribal self-governance advisory rep and a direct service tribes advisory committee rep. And the purpose of that was a formal charge to provide subject matter expertise, program information, innovative solutions, and advice to IHS to help establish a national community health aid program. One representative for each region with one alternate. In 2020, the Office of Minority Health announced a new initiative to support the implementation of the National Community Health Aid Program. So it's coming, it's very successful. It's been going on for over 50 years in Alaska. And I hope that soon it will be spread to the lower 48. And these are our community health aides from Kokonak, sorry, who are demonstrating their wonderful PPE donning and doffing skills for the COVID pandemic. I don't know if we have time for questions. If we do, great. If not, we do have a little breakout session later, and we're happy to speak to you about our community health aides.
Okay. All right. We got one more, and then the breakout sessions. It is a shorter day than the provider day of ATLS and much more entertaining. I get to great pleasure of introducing Dr. Asha Atwell. She's going to speak to us on another form of extending healthcare outside of the confines of the emergency room. And at the end of this talk, we'll clarify exactly what the breakout sessions will be. Dr. Asha Atwell is an emergency medicine physician who served as the director of the emergency department at Shiprock. And is now the proud mother of a very exciting healthcare for the homeless program out of Shiprock. And without further ado, I yield the floor.
Good job, guys. You made it this far today. So I'm the last speaker today. I'm going to be talking about Sihasin street medicine. So I started out, as Topher said, as the emergency medicine director in Shiprock, did that job for about 3 years and then burnt out. So if anyone wants to hear that story at some point, I'm happy to share. I, decided that I needed to take a new path and reconnect with the things that had brought me into medicine in the first place. And I got the opportunity to start this program. So this is something that I've been working on for about a year. It actually is new. The first street medicine clinics we did were October of last year. So this is brand new. Okay, go ahead and do I have a oh, sorry, nobody trained me on how to do this. No disclosures. So I just wanted to start with an overview slide. This is where we're going with the talk today. I'm just going to talk a little about background of street medicine and about my program, specifically how I went about developing my program. We're going to talk a little bit about homelessness, how that's defined in the United States, and And then also just the most important part of this talk is actually the trust gaining step of developing a program like this and how long that might take. So that's another thing we need to talk about. And then the last thing here we're going to talk about is just my plans and how I'm going to take over the world with street medicine, basically. So talking first about background of street medicine, I don't know if everybody in this room has already heard of street medicine, but when I started this program, before I started this program, I hadn't heard of street medicine. This had come out as in my research when I was trying to figure out a healthcare delivery model for giving patients that are experiencing homelessness care. And I initially ran into this. Jim Withers is the person who's most attributed to being the founder of street medicine in the United States. He sort of started the philosophy and started going out on the streets of Pittsburgh. I actually have a video of him, but it's his TED Talk that he gave. I think in the interest of time, we're going to have to skip it. And if we have time at the end, we can play it, but I don't think we will. In the 80s, he started going out into the communities around Pittsburgh and delivering healthcare directly to people out under bridges and wherever he would find them. So that is where street medicine began. And now it is mostly an urban phenomenon. So you'll hear about it in San Francisco, LA. Detroit has a really strong program. Even Santa Barbara has a street medicine program. But rurally and IHS does not have street medicine typically. So this is the first of its kind in the location that we are now giving care. The thing that makes street medicine really unique is the truly patient-centered aspect of it and the reality-based aspect. So when a patient comes to us or we go to them and we find someone and we say, hey, you know, what can we do for you? It is absolutely just driven by what they ask for. So we do not have an agenda about what we're going to be doing today. There's no GIPRA measures. And, you know, there's there is a street medicine guy. One of the other founders is Jim O'Connell in Boston. So he said that one of his patients he had seen for 2 years and he had never taken his blood pressure. So that's kind of the heart of street medicine. It's just that you're going out there, you're providing care, but it's really based on what the patient asks for and wants. So we build our trust slowly over time, and we don't expect that we're going to get trust right off the bat. We really kind of go for this expression of love and connection, and that's how we gain trust with our patients, and we kind of go from there. So how did this all begin? So as I was saying, I was pretty crispy in the emergency department, and I was really having a existential crisis, as some of you may know. And at that point, I was trying to think about like, boy, what else can I do? I really still want to be able to provide care for patients. I don't want my skills to go away. You know, and I learned through that time, I was sort of just exploring what was most important to me as a person. So as you all know, the care that we give in the emergency department is very lacking when it comes to continuity and when it comes to providing primary care for patients that are experiencing homelessness. And unfortunately, patients that are experiencing homelessness that come into the emergency department come in for maybe a host of needs that they think they're coming for. And then we say, okay, well, I can do this for you. And then you're going to be discharged. And that's kind of how it happens. There's a revolving door around that. And people come in multiple times a day. They may come in, you know, for pseudo seizures or for abdominal pain that we never seem to solve, or for alcohol intoxication or many other things. So as you all know, we're not really meant for providing primary care, but yet, you know, a good portion, you know, as this quote says at the bottom, a good portion of people experiencing homelessness use the emergency department as their sole means of interacting with the healthcare system. And also, you can just see that it's common that 3 times higher you'll see in the homeless population engaging in healthcare from the ER rather than standard modes as in clinics. So early in the pandemic, as I was the director there, I was talking with Chris Percy, who is a family practice physician in Shiprock, who's been there for 37 years as the community health director. And he and I had been talking about people experiencing homelessness and what are we going to do about these patients? Like, you know, I started really worrying about a lot of patients I was seeing and what was going to happen during the pandemic, because these patients are already vulnerable, they're already marginalized, and now what is a pandemic going to do? So he's a very, very busy guy. If you know him, he's always running to the next thing. He's in a million meetings, you know, any given hour, he has 3 meetings booked and he has to choose which one he can go to. So yeah, when I talked to him about this, he actually stopped and looked at me. And that was a good sign because he actually had to think about what I was saying. So he started going out under bridges, out to Bashas, out, you know, all over Shiprock and communities in the Shiprock service unit, and started testing folks when tests became available. He would drive patients. I know that's not allowed, but he would drive patients in his own vehicle to put them in quarantine in hotels. And he's just famous for being that kind of doc, that he just is going to take it into his own hands for the patient's best interest if he has to. So that is what started, is he started going into these communities and offering first, you know, testing. And then after a time, you know, vaccines became available. So he started doing vaccinations as well. When J&J came out, he went around Farmington and found every person that was out on the street and offered a vaccine to people. So anyway, so that's how it sort of started, was him going out there after our conversation. And then he noticed that the population seemed to be very inviting and actually happy to see him. And Amy McGilbert, who is she works with the public health department in Shiprock, that's also under his umbrella of community medicine. And she had been an EMT for 11 years. Sorry, this microphone is like loud, quiet. Had been an EMT in the area for 9 years prior. And so she knew the community very well. She also has some lived experience and had a lot of heart for that type of work. So as I was having my existential crisis, Dr. Percy contacted me and said, "Hey, would you like to do this program?" And I was like, "Yeah." So he gave me 2 months to sort of do some research and figure out what kind of healthcare delivery program or model would work in this population. And as I was going through and trying to figure out what would work best, I was thinking about maybe paramedicine, you know, but as you know, or maybe, I'm not sure, everywhere in the res has the same model, but we have EMS is run by tribal entity and not by IHS. And so that would have just been a little bit technically difficult for us to ride along with the ambulance, for us to go in helicopters and so forth. And then once I started really understanding what street medicine was and the philosophy behind street medicine, really meeting patients where they're at, you know, being there with them, you know, sitting on the sidewalk next to somebody, really breaking down the barriers of, you know, the institution and that power dynamic. That was where I thought, this is where we need to go. So that is how Sihasin Street Medicine was born. Before I get to that, Sihasin means hope in Navajo, and it was actually, we went around community medicine, which is a giant department, and I asked Native speakers for their opinions on the program and also on what they would name it. And so we had, like, you know, all these names, and then that was the name that stuck. So this is just the HUD definition of homelessness. I'm not sure how many people are familiar with it. I actually didn't know this before I started really delving into this program, but there are 4 categories of homelessness. The first is what we tend to think of as homeless. So when you hear, like, you know, it's called literally homeless, living outside, sleeping rough, that unsheltered, that's what comes to mind when you think of category 1. Category 2 is someone who is about to be homeless in the next 14 days. The third category typically has to do with homeless families or people that are moving frequently, so more than 2 moves in I think 60 days. And then also underage folks. And then number 4 is fleeing domestic violence. So one of the things that I had a conundrum about pretty early on was just thinking about homelessness on the reservation. And so, you know, in my research, I went around and talked to community partners all around Shiprock, really tried to understand what resources are out there already, what are the strengths of the community, what is offered. If somebody was experiencing homelessness, what can they do, you know, for themselves and what's out there. So I went around Shiprock, I went around Farmington, all of the Shiprock service unit kind of regions to make connections, to make friends. As I like to say, I go around and make friends. So talked to tons of people and got to know sort of what the resources are, what's out there, and then also tried to understand what terms are used to describe homelessness in Navajo. And these are some of the terms. And as you can see, that top one is a little bit more, it's on the derogatory side. But then the others are a little more neutral. You know, people who walk around, people who have backpacks, that kind of thing. And something else that kind of came out of it was a lot of people tend to think that there's no homelessness on the reservation because they have somewhere, they have a family somewhere. I know we talked earlier about how Native Americans have the highest rates of homelessness. And in a couple of slides, we'll talk about that. But while I was walking around, while I was talking to people, that was something that people were saying was, well, they have family somewhere. But as we all know, you know, if someone's using substances, drinking alcohol or something like that, they may not be welcome at their family home. And they may not have their own house or shelter. There's also the issue of lots of people, you know, living in broken down cars. There's people living in trailers that don't have electricity or running water, or just have a blanket tacked up for a door. There's a lot of different situations that people may be living in. So at any rate, going through all this, I decided to settle on kind of the term that was used over and over throughout everybody that we talked to, was that they call them the relatives. So that's what's stuck. So we call our patients the relatives. So as you can see at the bottom here, it says, you know, how many people in the overall population, and 1.2% of the national population self-identifies as Alaska Native American Indian, but 4% of all sheltered homeless. This is sheltered. And the reason why this is important to note is because it kind of points to this next point, that this one talks more about how Native Americans are 4 times more likely to be homeless than compared to whites. And you can see those top 2 bar graphs are both Native populations. So the thing that really bothers me about all of this is, you know, that was talking about sheltered homeless. So here, I just wanted to point out how we come up with these terms of how many people, how do we estimate how many people are experiencing homelessness in the United States? So what we do is we do a point in time count. Point in time means that the coldest night of the year, in the morning after that, volunteers largely go around in communities and they count. And they say, hey, where'd you sleep last night? And if a person slept in an emergency department or a shelter, they do not count as homeless. So only if you slept outside are they counted as a homeless patient or person. And that's just obvious to me that that's grossly underestimating how many people are experiencing homelessness. So think about that. And then you think about the reservation where people are already marginalized, and you know, there's no point in time count going on in Shiprock. My team actually did the point in time count last year, and it hadn't been done for 2 years before that, and only once at that point. So just think about that. You know, when you start thinking about marginalization of a population, and then you think about that particular fact, it just really kind of blows my mind. So the very first thing I needed to do was figure out, you know, who am I trying to serve, and how many people am I going to be seeing? So that was the very first thing I needed to figure out and wrap my brain around. And as I've kind of alluded to, the homelessness definition on the reservation may be more complex than we're giving it credit for. So after a whole bunch of philosophical debates with myself and many others, I just decided, you know what, we'll just serve whoever feels their needs aren't being met. So whoever shows up to our street clinic, that's who gets served. And for the most part, it is people who are experiencing homelessness, but there may be people who live in a trailer, but they experience food insecurity and they don't have a car or they can't get transportation to get up to the hospital, which is literally, you know, a couple miles away, but who knows what the factors are that make it impossible for them to get there. So we serve whoever comes to our clinic or whoever we happen to find out and about. So how does this work? So once we've now defined our priority group, and after speaking to a lot of different programs, so I talked to, you know, kind of a lot of the famous people in street medicine, which is a lot of people that are out there doing street medicine in urban areas. I tried to adapt those models to what I thought we could do on the reservation. So I kind of took different pieces out of all those. And then what we did was we formed a multidisciplinary team, which is one of the strengths of street medicine, is that you go out with a team that you think is going to be able to address needs. So, you know, you have a doctor, of course, but, you know, I'm there, Dr. Percy's there, but we're just probably, you know, just not quite key players. The real key players are people who are native speakers, people with lived experience, and those are the real shining stars of our program. So we have a couple of therapists that come out. One in particular, she's amazing. She's a Dene speaker and was raised traditionally. She comes up to patients and introduces herself with her clans. Immediately, you'll see people just relax. And you'll see people who were irritated or felt threatened just a second ago, all of a sudden they're like, oh, okay, she's talking to me. And she's got gray hair. She loves to tell everybody it's because of my gray hair. So she looks like a grandma and people love to talk to her. And then she offers them AccuDetox and she talks to them about what it is that has brought them out on the street. So what I wanted to say to any of you that were thinking about maybe starting a street med program is resist the urge to make it perfect and just get out there. I did have Shayla come out recently and that was what we kept telling her. It's just put some stuff in your car and get out there. So one thing though that we did talk about is our first clinic. We went out to our Bashas parking lot in Shiprock. And Dr. Percy, like I was saying, is family medicine and he's community-based. So he's done a lot of events. So what did he do? He thought we should set up a tent and put up some tables and do some questionnaires. So that sounds fun, right? So, so we go out there, we have the sole, we have rolls, we have like a little like lunch line, we're serving up stuff. And so we started at 10 o'clock and then by the time 2 o'clock comes around, people start getting more and more and more intoxicated during that time. You know, they're sneaking off, drinking some hand sanitizer or whatever, and then coming back and they're starting to get pretty rowdy. And so I had seen a patient that had like, I can't remember if it was, I think it was a toenail that was pretty infected. So I had gone up to the hospital to get antibiotics for that patient. And while I was gone, Dr. Percy and the entire crew had gone and retreated into the vehicles because some of the patients were throwing chairs around and telling us to get the F out and things like that were going on. And we're like, whoa, that's crazy. So we obviously did something we need to not do again. So we talked about that a lot. And what we came up with was we realized we are going into somebody else's environment. Like you're walking into someone's home, you're kicking your feet up on their coffee table and then telling them you need to fill out these questionnaires. Like, wouldn't you get pissed? I'd be pissed. So, so what we realized is that was really a poor assumption on our part, and we really can't go about things in that way. So the way we do it now is I've trimmed down a lot of our supplies and worked on that a lot, but there's medical supplies that we load into the back of a government GSA. So I use a Ford Expedition, you know, and those things are giant. So we load up all this stuff. I have donations in there. Every clinic begins with food and water. We also bring electrolyte solution and pickles. Pickles are actually key. I know that sounds funny, but I'll explain in a second. And then we start usually, so our first clinic started in Shiprock, as I've said, and we start in the Bashas parking lot just because that's where the largest conglomeration of folks tends to be. Everybody is congregating there, and usually we can find several people. So we start there, we kind of cruise around the parking lot, which is pretty big if you've been to that Shiprock parking lot, and you wouldn't believe it, but people will be, kind of tucked down into bushes. They'll be behind, all kinds of places, behind an electrical box. You can find places where people will hide. So you got to look around. So we drive around, we find people. We start with the burritos. We say, hey, are you hungry? Here's some food. Here's some water. Do you have a jacket? Do you have a sleeping bag? I carry all of those things actually. So during the winter time, we give out a bunch of sleeping bags, jackets, hats, gloves, socks, even shoes sometimes. And then in the summer, I was giving out baseball caps and sunscreen and all kinds of other things. And like I said, electrolyte solution. We go through cases and cases of water. And then we hop out, we just kind of start chatting. We are very careful about how many people hop out. So it's usually 2 people will approach a group at a time so that you're not kind of descending upon a group. And we all wear plain clothes. So casual attire is really important, not wearing sunglasses, making sure people can see as much of your face as possible, making sure that you really come up to somebody, shake their hand if they offer a hand, fist bump if that's what they want. Often now people will just come up to me and give me a big hug. And, and so we interact with patients as if they're our friends, and they are our friends at this point. We have a medical student or a resident with us every single clinic, and they help us do a lot of the paperwork, but they also get engaged in patient care and just discussing things with patients. So the nuts and bolts, kind of what I was talking about is that you just bring whatever you can out there that's going to make the biggest impact with the smallest amount of junk. And so I'm going to show you in a second some of the backpacks and the duffel bags and the things that we have that we bring out. And we also do like COVID testing. We do vaccinations. I have a point of care HIV syphilis test that's a antibody test, just takes a drop of blood. We do lab draws out there because we bring nurses with us as well. I actually have this pop-up tent that I do like genital exams, so we can look at, chancres or whatever we might have as our complaint. And it's just sort of grown over this past year based entirely on patient direction. So if patients tell me that they need more of this or they want more of that, that's what we try to bring out for them. So as I was saying, Shiprock Rounds started October of last year. And it started out being every Tuesday, 10 to 2. Now we're starting to go earlier. And, you know how IHS is. I started making this presentation probably 3 months ago. And since then, the number of people we've seen several more people. So we're up to about 250, close to 300 probably in Shiprock alone. And as I was saying, we bring out students and residents with us every single clinic. And I limit how many are allowed to come, just because I don't want this to become a medical tourism type of rotation where people are out like looking at people and it feels like a whole crew is descending. We have tried really hard to make our team to be a more consistent team. And then the students are just in there, just a couple of them. So it's a very small amount of students so that we don't have that feel like we're voyeuristic at all. A lot of our nurses are Danae. Actually, so the only people who aren't native that are a part of our team are me and Dr. Percy. And the entire rest of the team is actually native. And then the ability level to speak the language is just dependent on the person. But most of the nurses speak some Navajo, and several of them are fluent speakers, which is absolutely, you can't do this program without that. So the other thing that I did over the course of the last year was we had a patient who froze to death in October, at the end of October of last year. And as you all know, working in emergency medicine, we see that pretty often, and it's always horrifying. But what we did was we worked with the community and got a shelter open last year. So that is going to be open again October 15th through April 15th so that we can try to avoid the brunt of those kinds of exposures. Farmington, we started going out in Farmington in January of last year. And we start actually, so here it says we start at 10 a.m. And actually what's been going on is we've been going earlier and earlier. And most of that is because in the summertime, it's been so hot. It's like, you know, up to 100 degrees, 110 degrees in Farmington, and we're out in it all day. So we kind of want to start out earlier. We also can find people in their camps if you go a little earlier. So we've been kind of trying to, like I said, develop organically and figure out what works best for the patient population. One thing that's really that I would give as advice is if you wanted to start a program like this is patients tend to get drunk more and more over the day, and they're more sober in the morning. So sometimes you can catch people out there best when you see them earlier in the day. That's not always the case, but it's just being available earlier. Sometimes you have more meaningful interaction. At 10 a.m., we are always at this church-based organization called Harvest of Hope. And the reason we have that touch point is because a lot of times people are looking for us and they want to come to an appointment, which is really cute. A lot of people actually like show up and they come and they meet us and they'll say, hey, I know you haven't seen me for a few weeks, but it's because I'm doing really good. I've been sober. And we're like, awesome, you know, and people actually come just to tell us how they're doing, which is really cool. We also see people like, you know, for syphilis. So we've been treating a lot of syphilis out there. So I bring a medical refrigerator with injectable penicillin and we treat syphilis out on the street, and then we track them down for the next appointment. And then we, you know, find them for the next one. And so they get their 3 shots, which has been a challenge, but has also been possible. So in Farmington, we have seen now 450 people. And we also, so one of the questions I always get asked is, well, how do you deal with seeing non-IHS non-beneficiaries, right? Because we're supposed to, as IHS employees, treat beneficiaries. So we see the beneficiaries. We partnered with San Juan Regional Medical Center, who they have doctors they send out with us who see the non-bennies, but we do not discriminate when we're seeing patients. So they don't know that, you know, we're doing that we're splitting it up. And to me, that's especially important in a patient population that already feels really, you know, marginalized and forgotten. So it's important that we all express that we're seeing them. You know, we are not discriminating against anybody. We are seeing everybody, but that's how I've been able to get around that and make sure that everyone is being seen. It also means that people that are being seen in Farmington are getting better follow-up, because now that same group is going to be doing a clinic, like a follow-up clinic, so that they can have continuity for those patients. Because most of the continuity for our patients, we set up through Shiprock. So this is just an example of the backpack on the blue one here. And that's opened up so you can kind of see. Each of those little pods is removable, so you can just take it somewhere if you want to. There's a glucometer in one. I wear a fanny pack, and depending on your age, if you're my age, you probably laugh about that, but the younger generation thinks it's cool. And then there's the duffel bag over here. Like we have like saline in there. We have irrigation supplies. I even have an AED in there. And yeah, all kinds of stuff. I'm happy to share any of this stuff if anyone is interested. So the pharmacy bag, I developed the formulary based on things that I had seen very commonly in the emergency department, and just sort of like thought about what is going to be most common for this population based on what I had been seeing, right? So cellulitis, abscess, hands down, definitely the biggest thing that we treat out on the street. But I also see a fair amount of pneumonia. We see, which I didn't put on here, but we see a ton of dog bites. Fight bites is huge. You know, all kinds of STIs, and then of course the aches and pains, the withdrawals, you know, all that kind of stuff. The tricky thing is you cannot give medication that's going to be like 4 times a day dosing. So another thing that I did is really tried to trim things down so that I'm only giving 1 to 2 times a day kind of dosing in this patient population, and pretty much any, I mean, even one of us. Do you take your medicine 4 times a day? I mean, come on. nobody does. So it's really like kind of too much to ask, especially in a population where most of their day they're probably intoxicated. So you have to be, you know, like I said, reality based in your care. As I have on here, we have also naltrexone, and we give out a ton of Narcan, the intranasal one. I should have probably put this slide more toward the beginning, because this is probably the most important part of the entire talk, is about gaining trust. So gaining trust, you know, I mean, you can't understate it, but I've been told that it can take, you know, 2 years for some programs to gain trust with their population. I would say that for us, our population has been a lot more welcoming than that, and that's been really, really pleasant. We show up, you know, we make sure we remember, I try really hard to remember everybody's first name, if not their last name as well. I spend hours and hours delving into people's charts, trying to remember their medical history as much as I can. So when I show up at a clinic, I just walk down the line and say, oh, hey, Tommy, hey, so-and-so, you know, and I call people out by their names, and then I, you know, pull my face mask down. I'm like, hey, do you remember me? And they're, oh my God, you know, and so it's this consistency and also recognizing each person as an individual that really gains trust. And again, you know, it's really important to show the love and care that we can offer to patients, and they'll know from a million miles away if you don't have true love and care for them. So you really have to be honest. The other thing that Brett Feldman, who's the head of the USC program, he talks about the servant's posture. And all he means by that is that you get down on the same level as your patient, and making sure that you are down below their head, making sure that you are not in a threatening position. So there's a couple of pictures that I show a little bit later where I'm doing that. But that just comes naturally, I think, when you see someone on the ground. You can't just stand over them and, you know, talk to them like that. It's very threatening. I wanted to bring this up because I think this is a really interesting, this is how I thought that we would be approaching people, as sort of taking care of the bottom, you know, couple of needs here. We would be addressing mostly their physiological needs. We would be like, you know, providing some food so that we could bolster their immune system potentially, and their nutrition status. And, you know, we'd be giving water and electrolytes, and those are like, you know, potentially keeping people, this is how I was thinking, like, oh, out of the ER for their like hypokalemia, and, you know, and the pickles, that's where that comes in actually. So I had been told that Navajo kids sometimes get to go as a treat to trading posts and get a pickle. And that's like a memory that some of my friends have. And someone told me that, but it was after a patient of mine was like withdrawing, and he was like, man, I've been on this binge for about a week and I felt awful. And I said, oh man, you probably need electrolytes. He said, nah, I just need a pickle. And he said his legs are crampy, I just need a pickle. And I thought that's really interesting. So I actually looked it up, and there's literature to support pickle juice and eating pickles. I'm sure people who run in this group know about that, because that's typically where the literature comes from. It's not super conclusive or anything, but I was like, whatever, if it kind of like hits people in a really nice way, and they have this memory of going to the trading post and being able to have a treat or something like that, maybe it will have that effect on people, just kind of make them feel comforted. So here we are kind of addressing that bottom level, but I wanted to say that something that's been really awesome and surprising is we have a number of transgender patients that we see out on the street. And as you may or may not know, that's a common reason why some people are experiencing homelessness, is because their families don't accept them as they are. So there's in particular a couple of transgender male to female patients that we see and interact with. And our team, a few of the ladies on our team, they went out to Target, bought a bunch of makeup. And so we've been giving out eyeliner and different eyeshadows and things like that to folks that are transgender. And it is the most heart-melting thing you've ever seen, because people that you would normally think to yourself, like, here we are, we need to be addressing the bottom of this pyramid. And actually what we need to be doing is addressing the top of the pyramid, and then everything else is kind of taken care of, because you're giving all of the other things And we can figure out ways to support people, to make them more safe, to give them nourishment and things like that. But if you're not seeing them as human beings and you're not recognizing that they're seen, you're not addressing the top of the pyramid. So just thought that was an interesting thing and a point that I've really, over the last few months, have been thinking about a lot. So as I've already said, you know, showing up every single week, very important. People are already like, you know, oh, we'll see you in a week. Oh, we'll see you in a week. And people have become, you know, regulars with us. We see a lot of the same patients every single week. And so another thing we've started to institute is rounding at the end of our clinic. So a Farmington day will be about 60 plus patients that we see that day. So we have our green book, which is that government issue green book, and we wrote everyone's names down that we saw, everyone that we did something for, and so forth. And then we sit in a big circle out in a park with our whole team, and we talk about each individual and what that person meant to our team that day. So we talk about who was this person, what did they say to which member of the team, and this way we are recognizing not only the humanity of that person, but we are also processing what that experience was for us. So sometimes there are some difficult things that we see. Sometimes there's some really happy things. And we're also honoring that, you know, the history may have been obtained by the medical student or by, you know, Amy, she's actually the motor vehicle operator for us, MVO, that's her official title, but she is so much more than that. And she interacts and is able to get these stories that I never get. So we're kind of doing that to build in wellness and processing as a team every single day. So we go through that, and that also solidifies our commitment to each of these patients and making sure that they get what they asked for. Of course, I didn't really mention this, but always in the back of my head is thinking about the context that I'm working in. And so thinking about, you know, colonialism, how this has affected our population, the historical trauma that's here, the intergenerational trauma, all of these things. We really always, every time we're in this population, we need to be thinking about, you know, how we're interacting and be as trauma informed as we can. So on that note, actually, we stopped letting people wear scrubs because one of our patients got really upset just about scrubs. That was a trigger for someone. So there's just been like a lot of learning throughout the whole process, but it's been really, really fun to do. So that's me with the, I had to blur all these images because of, we didn't get explicit permission. But this patient right here is a wonderful example. So he actually hated us the first time he saw us. We were out in Farmington. We were talking to a whole group. There were 30 patients up against the state building fence, and we had been going along talking with patients. And he came up and he started saying, "Who the hell do you think you guys are?" And he starts heckling each one of us individually. And our team is like, you know, probably 8 to 10 people. So each person, he comes up to us and poking at us and kind of picking on little things and telling us like, "What are you doing experimenting on my people?" You know, and all this kind of stuff. So we actually ended up just being respectful, withdrawing our team and moving on. And then the next time we saw him, Amy, who I was talking about, she starts speaking with him, introducing herself in her clans. And then he's still trying to throw a little shade at her. And she immediately turns and gets one of our other patients involved. And she starts sticking up for us, this other patient. And then before you know it, this guy, he starts laughing and joking. And then he gets his first COVID vaccine that day. And it was a complete 180. This was the third time we saw him. And this time he shows us his art that he's made. He tells us he's a musician. He tells us he's been on the street for 7 years since his wife kicked him out and he can't see his kids. And he was expressing all his grief over what has happened to him. And then at the end of the encounter, he came up to each of us, apologized individually for his behavior the first time, and hugged us. So I think what I've learned the most is that you need to trust people, you know, and just kind of go with it. And if someone's not showing you, you know, whatever maybe is your best side at that moment, give them a chance. Because this guy, man, every time I see him now, he's like, "You guys are awesome. and he's like a promoter of our program at this point. So here's a bunch of us. There's the one that's on the left, that's us. Actually, I'm the one that you can't quite see, but there's 3 doctors around the foot of this patient, and we're removing some toenails that were super infested, nasty looking, with these big, he had like paronychia, and they were just festering nastiness. So he is a meth addict, and he paces a lot. And when he's pacing, he can't stop pacing. And it doesn't matter that he was now infected and that he's still going. So he had gone to the emergency department, and they had told him nothing's wrong with your feet, sent him out. And so I saw him on the street, took his toenails off, gave him antibiotics. We updated his tetanus. We got him his first COVID shot. We talked to him about his IV drug use. It was a really meaningful encounter. So he's another one that's a big fan and promotes our program now. Amy and I in the middle, and then this is me doing a suturing of a eyebrow lac out in the parking lot at Bashas in Shiprock. The one on the top there, that's me doing an IND. In Shiprock, there's this big concrete slab next to the gas station. We use that as our surgery suite often. And this one, I can't remember. I think I was just doing a staple removal, but somewhere outside, so you can see the dirt there. So that's me and Dr. Percy, and then a couple of our team. So I wanted to just kind of talk about a couple of next steps. So since I made this presentation, actually, we have expanded into Cortez. So I had that on my next steps, and it has happened. So we now have 3 different clinics that we do around the Four Corners area. So now we're seeing people in Cortez, Farmington, and Shiprock. And then, that generates enough work that we have PHNs and nurses that go out on other days to administer medication or to give prescriptions after we've already seen them and they need, follow-up stuff. So I've been able to luckily partner with Southwest Memorial there, Toyac IHS, and there's so many resources in Colorado compared to New Mexico. There's a lot of nonprofits in the area, and there's also a peer Indigenous counseling group. And those guys came out with us. They were amazing. There's 3 of them, and the 3 of them came out to talk about, so they do a well variety model and talking circles around Cortez, but they came out to connect with people out on the street. One of them does community outreach already. So he was like our community liaison, and he was helping us get to know the population. But that was amazing. All 3 of them are native speakers, and they're just essential. So it's been amazing to be expanding like I have been, and continuing to grow the program. Something else I want to focus more on in the future is the substance abuse arm of things. And I had initially thought that, doing like medical assisted therapy out there would be like the hot ticket, right? And it turns out that a lot of people are not quite ready to quit today, but maybe over time. We have been doing, some Vivitrol out there, but mostly we've been dealing with alcohol abuse and not so much opiate and not so much other stuff. So it's been an interesting, we're kind of pausing on that and just seeing where that's going to end up. So the biggest thing that I'm hoping to accomplish though, and the reason I'm here today is because I'm hoping that at some point this will spread throughout IHS, and especially throughout our reservation through the Navajo Res. And so if anyone wants to start a street medicine program, I've developed a toolkit so that you can kind of plug and play and see how that works for your team. All right, that's it.
Thank you. That was great. You want to go on now?
Asha, thank you. No, that was, thank you for your candor about your own journey through emergency medicine. I think we all need to hear that right now. And I'm really jealous that you found, we joke about things like an exit strategy, and we all love the practice, but what you've done is, I think you're gonna have a lot of questions for one thing from this group, but it's just really inspiring, and I'm happy for your patients most of all, but selfishly, as a colleague, I'm happy for you too. And it's truly inspiring, really. Thanks so much for that. We've had a very full day, and we have an optional continuation, as Paul mentioned earlier. First, I want to start by thanking, and I hope you all would join me in a quick round of applause for all our speakers today. We've covered a lot of material, both in breadth and depth, and I'm grateful for each and every one of them. And our farthest traveling in-person speakers were today. So now tomorrow we're going to have the farthest traveling virtual speaker who's going to join us from Australia. And you're going to hear a bit tomorrow about work with Aboriginal communities and Torres Strait populations as well, that are analogous to the work that many of you are doing over here. So I'll just quickly tease a couple more items tomorrow. We're going to hear from Dr. Loretta Christensen, who's the CMO for the IHS. We have another distinguished speaker lined up, a healthy dose of clinical medicine right in the middle of the day. So bring your clinical thinking caps. And with that, I think we're going to move on to the optional Q&A sessions, discussion groups. These are small groups. They're unstructured, but some of the experts that you've heard from today are going to give you the opportunity to just have open-ended conversations. And Paul, do you want to talk about how we'll divide that up?
Yeah, and it's totally fine. People feel free to, if you need to take a break, go home for the night. There's no pressure to stay. But I think in the back corner over there with the Alaska contingent to talk about the community health aid program and other things like that. And then I think we might also have Asha as well in that area to talk about kind of some crossover there.
And we have one other guest to add to that, JC Nashio, who's the head CHW from White Mountain Apache, will also be joining the tribe. So a robust small panel.
And then maybe in the other back corner over there, if we still have Hani from the MMIP here to talk about some questions about implementation. Yes, there we go, back in there. And so we'll probably be over by the chairs, kind of by that exit there. And then Dr. Chelsea White, if anyone would like to talk about EMS issues, there will be another break. He'll be